Good morning. Good morning. Welcome to the New York City Council hearing on the Committees on Health, joint with Mental Health and Substance Use and Disabilities. At this time, please silence all electronics and do not approach the dais. Again, please refrain from approaching the dais. If you're testifying today or have any other questions or concerns, please contact the Sergeant at Arms. Thank you for your cooperation. Chairs, you may begin.
Good morning, everyone. I am Councilmember Lynn Schulman, Chair of the New York City Council's Committee on Health. Thank you all for joining us at the fiscal 2027 preliminary budget hearing for the Office of the Chief Medical Examiner, OCME. I would like to thank Chief Medical Examiner Jason Graham, his staff, and everyone who is with us today. I want to acknowledge Council members Ariola, Caban, Epstein, Felder, and Narcisse is virtual. OCME's fiscal 2027 preliminary budget is $121.6 million, which includes close to $91 million for personal services and $30.7 million for other than personal services. OCME's budget has increased by roughly $916,000 compared to last year's fiscal 2026 adopted budget. While there has been an increase in overall funding, several areas within the agency's operations raise important questions about whether current resources are sufficient to maintain timely service delivery and support OCME's core mission. One area of concern is the absence of federal funding in the fiscal 2027 preliminary plan. OCME has had federal grants in the past, but none are currently reflected in this financial plan. Historically, these grants have supported activities such as forensic research and work related to the city's response to the opioid crisis. Although federal funding is often added during the fiscal year once grants are awarded, the absence of these funds in the preliminary plan creates uncertainty. We want to ensure that OCME has a contingency plan in case the loss of federal grants becomes permanent. Performance trends reported in the preliminary mayor's management report also indicate that several key operational metrics have worsened. The median time to complete autopsy reports has increased to 122.5 days, exceeding the agency's 90-day target. The median time for medical legal investigators to arrive at a scene has risen to 2 hours and 36 minutes in the first 4 months of fiscal year 2026. In addition, the forensic biology laboratory has experienced longer turnaround times for DNA casework, with median completion times rising from 51 days to 79 days compared to the same period in fiscal 2025. Staffing shortages appear to be a key factor behind these trends. OCME currently has a vacancy rate of 15.1%, with 734 of 865 budgeted positions staffed. The loss of experienced medical examiners due to retirements, recruitment by other jurisdictions, and a nationwide shortage of qualified forensic professionals has placed additional strain on the agency's workforce and may contribute to delays in case processing and report completion. In 2024, I wrote to OCME urging the city to increase medical examiner salaries to help address the growing vacancy rate and strengthen the agency's ability to recruit and retain qualified professionals. These concerns remain relevant today as the agency continues to face challenges filling highly specialized roles. OCME does excellent work for the city, and as chair of the Health Committee, I want to ensure that OCME has the resources it needs to operate at the highest level. Before we begin, I would like to thank the finance staff, Valeria Lazaro Rodriguez, Florentine Cabor, and Isha Wright for their work on this hearing, and committee staff Chris Pepe, Elizabeth Arzt, and Joshua Newman for their support. Finally, I would also like to thank my staff, Jonathan Boucher, Kevin McAleer, and Sammy New. I will now turn it over to the committee counsel to administer the oath to members of the administration.
Thank you, Chair. Good morning. If you could all please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to council member questions?
I do.
Thank you. You may proceed.
I'm free to proceed. Good morning. Good morning, everyone. Good morning, Chair Schulman, Chair Caban, Chair Hanif, and members of the Committee on Health and the Committee on Mental Health and Substance Use and Committee on Disabilities. On behalf of the Office of Chief Medical Examiner, or OCME, thank you for your ongoing support and partnership across our 24/7 mission to serve the communities of New York City and the times of most profound need. I'm Dr. Jason Graham, the Chief Medical Examiner for the City of New York. With me today from OCME, our First Deputy Commissioner, Nicholas Schultz, and Deputy Commissioner for Administration and Finance, Yvonne Williams. We appreciate this opportunity to provide an update on our budget and important current activities and look forward to answering your questions. When we testified last year, I introduced OCME Cares, which was our then newly adopted set of core values. These abiding principles of commitment, accountability, resilience, excellence, and service inform every aspect of our work and guide our interactions with all stakeholders. This year, the agency is particularly focused on the core value of excellence, striving day in and day out to achieve the highest quality in all aspects of our work at the intersection of public health and justice. Excellence raises the bar for what a medical examiner's office can achieve for the communities who rely on us during the most challenging moments. Our vision is to deliver innovative solutions to the most pressing problems in public health and forensic science, provided by caring professionals and readily available for all New Yorkers in need. I'd like to take this time today to share more about our planning and progress toward this vision of excellence, accessible to all. OCME is home to world-class, fully accredited laboratories that support our mission to deliver timely and accurate answers for stakeholders. Our molecular genetics laboratory is the only facility of its kind in the country in a medical examiner's office, which was a trailblazing vision established in 2003. The molecular genetics laboratory examines the DNA of decedents who, often very young and otherwise healthy, die suddenly and without apparent explanation to determine whether there might be a genetic reason for their deaths. Until recently, our lab could only deliver the news of a genetic cause of death and urge family members to seek testing for themselves. But with our focus on accessible excellence, we recognize that we can and need to do more for New Yorkers we serve. Now, with the launch of our Genetic Intervention Family Testing Services program, known as GIFTS, OCME can screen living, at-risk blood relatives at no cost, provide appropriate clinical genetic counseling, and connect them to potentially life-saving care, closing a critical gap in services. And we expect to begin testing our first family members very soon. Working to prevent deaths may sound novel for a medical examiner's office, but for OCME, helping New Yorkers live longer and healthier lives is already part of our mission. OCME contributes to public health by providing impartial data from our forensic investigation that informs policy and through many of our own ongoing innovations, specifically in the effort to reduce deaths from accidental drug overdose. Our Drug Intelligence and Intervention Group, known as DIG, works with surviving loved ones and close contacts in the days and weeks following an overdose death, offering them support, resources, and often simply an ear to listen. Staffed by social workers, epidemiologists, and program specialists, DIG leverages the unique relationship of trust between our office and the communities we serve, reaching more than 4,000 close contacts to date, nearly 3/4 of whom have accepted direct services and referrals to potentially life-saving interventions. As we move forward and deaths from overdose hopefully continue to trend downward, DIG offers a pioneering and proven model for how OCME can utilize data-driven insights to help additional populations in New York City affected by a whole range of public health challenges known to have a social component. We aim to make this excellence in service with its life-saving potential cutting across all walks of life available to all. The success of our mission depends on strong relationships with the community, and as we progress in excellence, our journey is expanding the trust necessary to advance our work. Well over a year ago, we began to implement postmortem CT scanning to elevate standards in diagnostic service. And I'm pleased to report that this technology has now been fully integrated into the practice of forensic medicine on the part of our medical examiners at OCME and is in daily use at our pathology centers where it's making a difference in our partnerships with the community. CT scanning is one of the many steps that we've taken to improve the working experience for our medical examiners, the highly trained forensic pathologists who directly deliver answers to families in the wake of a tragedy. As you know, OCME has been grappling for several years with a serious shortage of medical examiners. a problem that's rooted in a multifaceted national crisis that will not be fully resolved in the immediate future. However, we're pleased to report that our renowned forensic pathology fellowship training program remains a beacon for training and recruitment, attracting talented and caring physicians who want to pursue their specialty here at the most comprehensive and complex medical examiner's office in the country. OCME has filled all 6 of our coveted fellowship seats for the academic year 2026-2027, and we continue to hire medical examiners to serve New Yorkers from the ranks of our graduates each year. Our planning for the Science Park and Research Campus, or SPARC, Kips Bay project is also actively underway. This first-of-its-kind health and science campus will become the new home of our Manhattan Forensic Pathology Center and supporting facilities, serving as a training hub for the next generation of leaders in forensic science and medicine. OCME has been part of the bustling public health corridor in Kips Bay neighborhood for more than a century, and we're excited to be partners in this transformative next step in life sciences innovation and workforce development for our city. While raising the bar for forensic science and medicine, OCME also stays grounded in our foundational purpose: to provide answers for communities facing the most challenging times, no matter how long the mission takes. Few instances show the depth of this commitment more than our ongoing efforts to solve the coldest cases of missing and unidentified persons and return them to their loved ones. Since 2017, our cross-departmental cold case team at OCME has newly identified more than 130 individuals, many from decades-old cases, missing from as far back as the early 1980s, across all boroughs of the city, and including 20 victims of homicide. Leveraging our in-house expertise in identification investigations, forensic anthropology, and DNA science, while tapping into partnerships with law enforcement and other agencies, we're bringing long-sought peace to families and justice to those affected by crime. Our commitment to families is not limited to the office and the laboratory. We're also reaching into neighborhoods to bring assistance to those in need at no cost. For more than a decade, our annual New York City Missing Persons Day event has made expert resources and support services available in person to families and friends seeking long-term missing loved ones. Credited with dozens of identifications since its start, we brought New York City Missing Persons Day to Queens for the first time last October. This event connected more than a dozen families with confidential help, bridging a gap for those still in need of closure. The cold case and missing persons work of today extends directly from the lessons of our experience with the World Trade Center disaster of 2001. In the aftermath of the attacks, the pressing urgency to identify the 2,753 victims pushed the frontiers of DNA science and continues through the present moment, an enduring testimony to excellence. The scientific legacy of the unprecedented World Trade Center identification effort informs current active forensic casework as well as our cold case efforts, while we also continue to identify those killed on September 11th. Over the past year, OCME made 3 new identifications of victims from the attacks on the World Trade Center in 2001 and linked dozens of remains to previously identified individuals. The new identifications, representing the 1,651st, 52nd, and 53rd persons identified, resulted from renewed family outreach and advanced DNA analysis of recovered remains. The remains of 1,100 victims of the disaster have yet to be identified. But as we approach the 25th anniversary of this day that changed our city and the world forever, we continue to make attempts, reaching out to new generations of family members, undeterred and undaunted by the passage of time. We honor their memory with our work to remember, reflect, and renew. Thank you for the opportunity to testify today, and we look forward to your questions. Thank you.
Thank you very much. We've been joined by council members Joseph, Marte, and Lee, and our public advocate, Jamani Williams. Public advocate, you want to make a statement?
Thank you, Madam Chair. As was mentioned, my name is Jamani Williams, public advocate of the City of New York. I want to thank Chair Shulman, Caban, and Hanif, as well as the members of the Committees on Health, Mental Health, and Disabilities for holding this hearing today and allowing me the opportunity to testify. As New York City faces new challenges in navigating public health emergencies without data and resources from the federal government, it is imperative that we invest in our public health systems. The FY27 expense budget for the Department of Health and Mental Hygiene, DOHMH, sees a 13.59% decrease in funding from FY26, with proposed funding totaling $2.5 billion, down from $2.7 billion. While the administration's preliminary budget does baseline critical funding for child care, food assistance programs, and the newly launched 2K initiative, this budget also fails to fund many programs that saw one-year investments in FY26, including but not limited to the Maternal Health Campaign, Crisis Respite Centers, and the NYC 988 Crisis Intervention and Suicide Prevention Hotline. While we understand that the city faces a budget crisis, we must grapple with the reality of what these new cuts entail, especially after 3 years of sustained pegs under the previous administration. The state's expanded funding for mental health is heartening to see, especially for the commitment of $750 million in FY27 and $500 million annually thereafter for the Healthcare Stability Fund, HSF. While this will help to mitigate some of the losses expected from the Big Ugly Bill, projections remain worrying. Hundreds of thousands of New Yorkers will be left uninsured, and an expected loss of generated economic activity to the tune of $14.4 billion, with direct cuts to hospitals and health systems totaling $8 billion, and more than 65,000 jobs lost in hospital and other community health centers. In addition to HFS, the governor's budget also proposes integrating care for mental health and substance use disorders, increasing resources for supportive housing and supportive nonprofits that serve New Yorkers by ensuring reimbursements are consistent and timely. These changes will not only help serve New Yorkers experiencing psychiatric illness, but also those suffering from substance abuse, two groups that face many barriers to care, including lack of access to stable housing. I look forward to hearing from DOHMH on what the agency is doing to prepare for the impact of these federal cuts, and furthermore, how the city can work with our state partners to ensure that we're meeting the needs of New Yorkers. Before I move on, I do want to raise the issue of the new health care plan ratified by the Municipal Labor Committee back in September. Since implementation of the City of New York Health Benefits Program, I've heard countless issues raised by city workers as well as medical professionals frustrated with navigating this new system. Covering 750,000 city workers, this plan promised to cut the cost of the city's primary health care plan by more than 10% while expanding coverage and benefits. But coverage and benefits have been negatively impacted for many, and I believe the city must keep a close eye on how this program affects our bottom line and the people it's supposed to serve. Lastly, I'd like to briefly highlight that we should be moving away from. Last week, the federal government announced a new plan to allow the Department of Veteran Affairs, VA, to initiate guardianship proceedings in state courts for veterans who have no family and are unable to make their own health care decisions. Last year, as part of FY26 state budget, Governor Hochul insisted on expanding the criteria to involuntarily commit someone for psychiatric treatment, and in 2022, Mayor Adams announced a new policy to hospitalize homeless people deemed to be, quote-unquote, in psychiatric crisis. Each of these attempts failed to recognize the harmful effects of involuntary treatment. Research shows that involuntary commitment can negatively affect a person's earnings, which leads to poor outcomes. It can also show distrust towards health care, which is problematic when a person needs continued care outside of the hospital. In some cases, involuntary treatment can be a life-saving tool, but every person with a mental health condition is different. There is no perfect solution. I look forward to working with the administration to ensure that those in need of care are met with compassion and dignity, and that we really increase the structure, both actual structure and funding, so we can really push on the continuum of care that's needed and take away the cycles of hospitalization and Rikers and get folks the care they needed in the long term. Thank you for giving me the opportunity to speak. Thank you.
Thank you, Public Advocate. And we're first doing Office of the Chief Medical Examiner. We'll make sure that we, if you're not here when DOHMH comes, that we'll give your remarks to him.
Thank you, and Chief Medical Examiner, thank you for listening.
Okay, thank you, Public Advocate, appreciate it. So now we'll get to questions. In the fiscal 2027, oh, and by the way, I just want to clarify that when I announced that we were joined by Councilmember Lee, she's actually our finance chair, so I want to make that distinction. Thank you for joining us. In the fiscal 2020... Finance chair, what? Oh. Oh. In the fiscal 2027 preliminary plan, OCME has a budgeted head count of 865 positions. As of January, the actual head count was 734, reflecting a vacancy rate of 15.1% and 131 vacant positions. Can your office provide the committee with a breakdown of the 131 vacant positions?
Yes, we have vacancies in various areas that are largely a result of new positions that have been added to our head count that we're actively attempting to fill. We, in those new resources, have a concentration of positions in our forensic operational areas, and we will be able to follow up and provide you with a specific breakdown of our current vacancies, but they're largely concentrated in forensic operations, which would range from mortuary to investigations to other operational areas. So we will follow up and provide you with a specific breakdown.
Please, that would be very helpful to us as we move forward in the budget process. On average, how long do these positions remain vacant?
It varies depending on the position. Many of our positions at OCME require very specialized skill sets across forensic science, medicine, investigations, and so the recruitment of people with these specialized skills sometimes takes time, and so there wouldn't be a one-size-fits-all answer to that. I think that it varies, and we work as quickly as we can once we've identified suitable candidates and have offers that have been accepted to get them on board, get them acclimated and trained and in service as soon as we can.
How are these vacancies affecting operations?
Well, again, there's minimal impact to operations at the moment because these are largely new positions that we're still recruiting and hiring for. So the operational impact at this point is minimal.
How is OCME advertising their job openings?
We have not only through the routine posting of our jobs and city sites, but we also directly reach out to areas, to forensic organizations such as National Association of Medical Examiners, American Association of Forensic Sciences, the specific forensic organizations and colleges who are graduating students in the sciences that may be suitable to fill some of the roles in our laboratories and across our agency. So we have a multi-pronged approach through our human resources team to reach out to an entire variety of potential sources of OCME staff.
How many positions are temporary, and what is the rationale for hiring temporary positions versus full-time employees?
We have a relatively small number of per diem or temporary positions. I can get back to you with a specific number.
If you could, yeah.
Many, or at least a fraction of those positions came on board in that temporary role during COVID. Okay. And so that was during the pandemic in many instances, but we'll get back to you with a specific number.
Okay, no, I appreciate that. I actually have a question, it's not on here, but does the HB1 for immigrants affect, because I know it affects the medical industry as a whole, the waiver, does that affect your operation?
We have a very few members of our professional staff who have H-1 visas.
Okay.
We have had medical examiners and others on visas in the past, and to the extent we can support that, we do, but it can, in certain instances, present a challenge for us.
Okay, that's something that the Health Committee, I think, is going to look into and try to be helpful. So we can talk offline about that. The current fiscal 2026 budget added 25 positions, including 2 public health epidemiologists and 23 criminalists. What is the status of hiring for these roles, and have they all been filled?
Yes, there's these positions are grant-funded positions, and 23 of the 25 have been selected, so we're very close to having all 25 of those positions.
With the 2-for-1 hiring policy lifted in the preliminary plan, do you anticipate vacancy rates declining in the near term, or will Mayor Mamdani's instruction to cut vacancies by 50% impact OCME?
Well, with our Chief Savings Officer, we're continuing to develop a very strategic approach to addressing any vacancies or headcount reduction. We're working closely with OMB, and that's all in an effort to make sure that our critical functions, the critical most positions in our agency are maintained, and our services to the city are not compromised in any way. or reduced. We also feel that the removal of the 2-to-1 hiring policy is going to positively impact our vacancy rate. We believe that we can identify those critical roles and now, with greater flexibility, hire them. But we're going to be focusing on making sure that our services are not compromised or reduced in any way in terms of our critical role in the city.
Okay, great. OCME's current fiscal 2026 budget reflects $4.2 million in federal funding to support various grants. However, the fiscal 2027 preliminary plan does not reflect that funding. Of the $4.2 million, excuse me, how much of this funding supports post-conviction DNA testing, opioid abuse, and forensic research?
Well, that $4.2 million represents the budget provided by 16 federal grants. So we have 16 federal grants, and that is a combination of different types of grants supporting the work that you mentioned. But that is our current funding from the federal government in the form of grants. So we have 16 grants. We are anticipating that 4 grants previously that reached the end of their term, we've asked for renewal and been granted those. So we're anticipating that we're going to have additional federal grant funding beyond that.
Can you provide us, not here, but can you separately provide us with what that $4.2 million pays for at OCME? That would be very helpful to us.
Certainly.
Thank you, because we can also be advocates as well. Does OCME anticipate receiving any federal grants for fiscal year 2027? You kind of answered that.
Yes.
Great. Again, we can also be helpful there. When do you anticipate the grants to come through? You have any sense, or?
The allocations from the grant will come through at the beginning of the fiscal year. So what's not reflected at the moment, when the fiscal year renews, that funding will be allocated from those grants based on what will be needed for that year.
Okay, and also let us know if there's any changes, because I know the federal budget fluctuates on a day-to-day basis. So does OCME do you have a contingency plan if the federal government withholds funding?
Well, we've not seen any indication of that at this point. In that event, we would certainly work very closely with OMB and potentially the law department to mitigate any of those reductions. I think that we again are going to we're going to monitor closely for any indication of that, and then we would immediately be in conversations with OMB to strategize to again prioritize our critical positions and make sure that our services are not reduced.
Do you also have state grants, categorical?
We do. We have 3 state grants, which account for roughly $1.2 million in our FY27 budget.
And you don't expect any issues there, right?
No, we do not anticipate any issues with the state.
Yeah, if you can give us a list of not just the federal, but the state, so just so we have a sense, I appreciate that.
Certainly.
All right, Code Blue deaths. Code Blue weather emergency notice is issued when the temperature drops to 32 degrees Fahrenheit or less between 4 p.m. and 8 a.m., which we've had a lot of, unfortunately. No one experiencing homelessness who seeks shelter during a Code Blue in New York City can be denied. On February 12, 2026, Mayor Mamdani announced that 19 people died to the extreme cold weather that began in late January. Were OCME seen arrival times affected by the snow?
Our scene arrival times were not affected by the snow. We were able to respond to death scenes. We activated our continuity of operations plan, and we were able to continue to meet the need in the field. We dispatched our death investigation teams as routine, and they were able to successfully conduct scene investigations. And so much of the traffic that is often seen in the city was reduced during that time. So our transit to the death scenes were not impacted, and so our response times were not meaningfully impacted due to the snow. We did triage cases and make decisions about the priority that certain cases take over others, as we do in routine work. And so we were able to fully respond, and we continue to perform autopsies in our forensic pathology centers as routine, again, through activation of our COOP plan.
Thank you. Have all individuals who passed away been identified yet?
Well, we're talking about you're referring to the individuals that were discussed in the previous hearing.
Yes.
And those were individuals who died who were outdoors and either unhoused or certainly not in a residential
Yes.
setting.
Yes.
Yes, and so we were, during that period, we investigated a number of those cases. At this point, there have been 16 individuals who have been confirmed to have died of hypothermia under those conditions, and all 16 of those people have been identified.
Okay, and the others were separate? What was the other three?
Those turned out that they were not hypothermia related. So we investigated many cases, and we've confirmed that 16 of those outdoor non-residential deaths were due to hypothermia.
Were the other three, even though they weren't due to that, were they identified?
I would have to get back to you on that, but we're quite successful in getting people identified, so I would say likely, but I will have to confirm that.
Did OCME observe any trends in the locations or circumstances of these deaths?
Well, there were little differences in terms of the locations across at least 4 of the 5 boroughs. Staten Island was relatively spared, but across Manhattan, Brooklyn, Bronx, and Queens, there was a relatively even distribution. There was also a relatively even distribution across racial categories in the city. One thing that we did see was that among that group, among that 16, all but one of them were men. And so that was something that was noted. And we also, out of the 16, there were 11 of those individuals that alcohol and/or drugs or a combination were involved. And so those are, I think, some of the meaningful trends that we observed.
Okay. During the hearing on Code Blue on, let's see. No. All right, I'm going to talk to you about an issue that's come up before, about emergency vehicles and response time. So OCME vehicles are currently not eligible to be designated as emergency vehicles with sirens and lights, which can delay both arrival at scenes and return to headquarters. What criteria must OCME vehicles meet to be designated as emergency vehicles? Do you know?
This would require that the New York State vehicle traffic law include designate medical examiner vehicles to be response vehicles. And if that designation occurs by a change in the state law, we would have the authorization then to be equipped, have our vehicles equipped to be emergency response vehicles. And that is something we're certainly interested in pursuing. It would help with our response times to scenes. And aside from that, we would be prepared to go forward.
Is the mayor's office, have you had conversations with them about that, or?
We have had conversations around the fact that this is on the legislative agenda.
Okay.
And certainly any support would be appreciated in that regard.
Sure, absolutely. We can talk about that offline, but definitely. How much would it cost to equip every OCME vehicle with an alarm? Do you have that?
I can get back to you with that. We've, at different points, looked at that cost estimate, so we can follow up.
And does OCME have oversight or coordination responsibilities related to EMS response times?
I would have to defer to FDNY or EMS on EMS response times.
Okay. Are there any steps that you've taken to support EMS? Yes, right.
I think we work very carefully and closely with EMS in the field, and I think to the extent that we can improve our response times, it helps EMS in being able for their teams to get back in service and help others.
Okay. How do delayed response times impact OCME operations and case processing?
Well, really, with respect to EMS response times, that doesn't directly impact
No.
our response. A death occurs, pronounced death by EMS, and then cases are reported to us generally by the police, and then we respond in a coordinated way after that. So they have minimal impact on us.
Are there staffing or fleet shortages contributing to delays?
Again, I would have to defer to EMS about that.
Okay, what is the total number of OCME's fleet, and does its motor pool have enough vehicles?
We have 48 vehicles in our fleet, and that is adequate to keep transportation vehicles, investigations vehicles going 24/7, 365 at this point.
Okay, so OCME's motor pool has a budgeted head count of 26, but its actual head count as of January is 9. So this brings the vacancy rate to 65.4%. What are OCME's efforts to lower the vacancy rates, and what job openings are currently posted?
Well, we have various roles at OCME with respect to who is operating our vehicles, and so that could range from members of our mortuary teams to motor vehicle operators. And as I mentioned earlier, we've got a number of vacancies across our forensic operations areas that we're in the process of recruiting and hiring for, and so the hope is that that vacancy, those vacancies, along with the others we've already discussed, will be filling.
Okay, I also want to state we've been joined by Councilmember Osei. In the fiscal 2027 preliminary budget, OCME has 23 contracts totaling $3.1 million for general maintenance and repairs. Additionally, the plan also includes $210,000 in capital funding for vehicle replacements. What services are covered under the maintenance and repair contracts?
Those general maintenance and repair contracts are really centered around our facilities. So three primary areas: facilities and the maintenance and repair of our facilities, IT infrastructure and improvements, and laboratory equipment. So those three major areas account for that general maintenance and repair budget: IT infrastructure, facilities, and laboratory equipment.
What, do any of these contracts include maintenance or repair of OCME vehicles?
No, we work with DCAS with respect to the maintenance and repair for our fleet of vehicles.
So, the question I'm trying to get at, I think, is do you need more vehicles? And the question then becomes, instead of doing the maintenance on these vehicles, would newer vehicles cut down that cost and be more efficient, effective?
Well, I think that we, again, we work really closely on keeping our vehicles maintained. We have a fleet of vehicles that has a range of ages. Some of those vehicles used more or less frequently, disaster response vehicles, for example, that may not necessarily be in circulation every day, thankfully. And so at the moment, we're fully capable of responding to scenes on a routine basis in the field, as well as in a disaster situation. And at the moment, I see no challenge with respect to having our vehicles maintained and repaired and keeping a fully functional fleet of vehicles in circulation.
We're just trying to see, because sometimes it's more effective to have a new vehicle and as opposed to putting all of the maintenance into something that.
Well, we've also had new vehicles added to our fleet in
Okay.
recent times, yes.
Okay. All right, thank you. I'm going to go to the mayor's preliminary management report. The median time for scene arrivals by legal investigators was 2 hours and 36 minutes in the first 4 months of fiscal 2026, while it took 2 hours and 25 minutes during the same time period in fiscal 2025. In addition, the median time for fiscal 2024 as a whole was 2 hours and 13 minutes, which in fiscal 2023, it was 1 hour and 37 minutes. So what factors resulted in OCME's longer scene arrival time?
Well, our scene arrival time is very variable based on several factors. In many instances, our scene response is a coordinated effort with the police, certainly in suspicious cases or cases that are criminal. There may be a need for crime scene to attend a scene and do their work before we respond. So there are coordinated efforts that need to go into our response time. I think that's one factor. Another factor is what we've already alluded to in terms of our ability to traverse the entirety of the city, all 5 boroughs, dispatching our medical legal investigators from a single location in Manhattan, and the ability to navigate, depending on the time of day, navigating traffic to get to death scenes across the city has been a factor. Staffing with respect to the number of death investigators that we have, that has improved, and so I'm expecting that there is, and as we continue to hire those positions in forensic operations, I'm expecting our response times
Times go down.
to reflect that as well.
Great, we'll look forward to that. Are there specific neighborhoods that take longer for an investigator to arrive?
Well, I think, again, being dispatched centrally from Manhattan, there are, the far reaches of the city that we have to attend death scenes, and depending on the time of day, that can be a challenge. But we get to the scenes as quickly as possible once we're notified of the death, again, in that coordinated effort with the other stakeholders.
Okay, currently, the PMMR does not track whether scene arrival times differ when responding to calls at morgues versus private locations. Is this something that you track internally?
Calls in response to,
To a body in a morgue
yeah,
versus a what I'm getting at is that it's emotionally, difficult when somebody's in a private residence or a public location, as opposed to you picking up a body at a morgue. That's
yeah,
what I'm...
absolutely. And that is we have a set of triage priorities for cases that are reported to us. Deaths that are in hospitals or nursing homes or other settings that have storage, those are the cases that are in public view or in people's homes are top priority for our
But do you track
response.
the response times for each of those? Do you separate
we
them
do.
out?
We do.
Can you get us some of that
Sure.
information? That would be great. Was there a specific event in fiscal 2025 or fiscal 2026 that resulted in longer wait times, or again, it's back to what you were saying earlier?
It's the same factors that I was mentioning before, and I think there are also occasionally events that require multiple resources being utilized at a single time that can reflect some of those numbers. For example, response to the Midtown shooting incident, which was a complex, sort of protracted death scene, and certain instances that require multiple resources can also have an effect statistically on some of those figures, but primarily what we were referring to before.
The PMMR indicates that the median time to complete autopsy reports increased by 46% in the first 4 months of fiscal 2026 compared to the same period in fiscal 2025, reaching 122.5 days. According to the report, this delay is primarily attributed to the loss of approximately 1/3 of medical examiner staff due to retirements, recruitment by other jurisdictions, and a nationwide shortage of qualified medical examiners. I think you hired several MEs last year, is that correct?
We did.
Does the PMMR accurately reflect that you experienced a 33% decline with that position?
We've lost over the course of 2 years essentially 1/3 of the medical examiner staff. We have reconstituted that staff by a number of positions, but we're still, as I've testified here before many times now, in the midst of a crisis nationally, and that's a crisis that we're not spared of locally. We are doing many things to mitigate that, and I'm pleased with the negotiation that took place on the part of the Doctors' Council with the city to provide better salaries for our medical examiners, increasing our ability to recruit and retain. We've also added locum tenens pathologists who are trusted doctors that most of whom we've trained, who are coming on to support the doctors we have on staff. And we've also reorganized in many ways our operations to provide better support to our on-staff doctors to make them more easily able to focus on the work of being a medical examiner and reduce their administrative workload in order to produce a reduction in these turnaround times.
And we got the OCME salaries increased that time. Are they competitive now, or we still need to have work to do?
They're far more competitive. I think that this is an ultra-competitive environment when it comes to forensic pathologists, and so the contract is going to end in 2026, and so I'm hoping additional negotiations will take place around the salary issue in the next contract negotiation.
What's the starting salary for OCME medical examiners?
Well, we hiring out of fellowship, I'll have to get you that
All right.
that detail, but the high end of the salary range for a board-certified forensic pathologist is at $277.
Okay. Do you know what the average is around the country?
That has been fluctuating and rising over the past few years, as you might imagine.
Right.
We can provide data on
Okay, just so we have a comparison, so we can maybe be helpful there. What is the current size of the autopsy report backlog?
Well, the definition of backlog for me would be those autopsy reports that are not complete after our target turnaround time of 90 days.
Okay.
And so there are a number of those cases, but we're moving in the right direction. I'll get back to you on the current number.
Okay, great. All right, I'm going to talk about the Drug Intelligence and Intervention Group, which you mentioned in your opening remarks. The Mayor's Management Report and Preliminary Mayor's Management Report tracks agency performance and service delivery across the city. Since its launch in late 2022, OCME's Drug Intelligence and Intervention Group has played a key role in the city's overdose response by connecting surviving family members and close contacts of individuals who died from overdoses to grief counseling, social services, and treatment referrals. During the first 4 months of fiscal 2026, DIG reached 474 individuals, a 35% decrease compared to the same period in fiscal 2025. The PMMR attributes this decline to an overall reduction in citywide overdose deaths and a 50% staffing reduction. Is DIG supported by opioid settlement funds still?
Yes, it is.
How much is allocated to the program, and is the funding time limited or is it ongoing?
I'm very pleased to say that we've had $4 million of opioid settlement funding added to our baseline budget, and that will go nowhere. We will have that every year going forward, and that incorporates the DIG, which accounts for 11 headcount at our agency, as well as other areas across the agency that support overdose-related work. And so we're pleased that that has been baselined into our budget. And
Are all 11 positions filled, or are some vacant?
we have 7 positions filled, and you alluded to a staffing shortage, up to a 50% staffing shortage earlier, and that was on some levels related to a shortage of social workers. One of our family services team, who is responsible for outreach to families, composed of social workers and other support services, and so the shortage of social workers, I think, impacted those vacancies. So we had 7 full-time people who are on board now, 4 vacancies, and I'm pleased to also report that those 4 vacancies, we have identified individuals to fill those and are in the process of filling.
Great. By the way, I just want to acknowledge we've been joined by Councilmember Gennaro virtually. Do you have the job titles of the vacant positions, or can you get us those?
There are 2 social workers and 2 data team members. The specific titles for the data team members, we'll get back to you.
Okay, great. Beyond the decline in overdose deaths and the reported staffing reduction, were there any other factors that contributed to the decrease in individuals reached?
I think that those are the 2
Big ones.
primary factors. I think we also, generally speaking, have sometimes challenges in reaching families. Our DIG team comes in after we've done a death investigation at the scene, and we have contact for families. Some families wish to talk with us, and others may not. And so there are inherent challenges in doing that outreach work that could affect the number of people we're able to reach.
Okay, Healthy NYC sets a goal of reducing opioid overdose deaths by 25% by 2030. How has DIG contributed to progress toward that goal?
Well, I feel that the work that the DIG team is doing, and particularly on both the data side, sharing data with partners, stakeholders, to be able to use that data to then implement programs and policies in various public health and public safety agencies, has been directly contributory. I think even more directly impactful with respect to the increase of the life expectancy of New Yorkers and saving lives is the work, the outreach work that our family services teams are doing to families who are bereaved following the loss of someone to a drug overdose. This is a unique population that has a range of needs across the spectrum of social service needs, from suicidal tendencies to substance use issues that need attention, and the work of our social workers and the ability of social workers to contact those folks and refer them to care is, I think, active prevention, life-saving work. And so I think that on those levels, we've contributed on the part of the DIG team. And the DIG team has also now an even higher level of engagement with families. Now over 80% of the families that we reach, over 80% are now accepting services of some sort, be that even grief and bereavement support, ranging up to referral to healthcare for mental health services or substance use treatment.
What trends is DIG currently observing in overdose deaths, including changes in substances involved or demographic patterns? Anything?
Well, while we're very pleased that we've seen a reduction in the number of overdose deaths in the city over the past couple of years, that trend is certainly moving in the right direction.
Right.
However, the overdose crisis is not over. The opioid crisis is not over. We are still seeing over 2,000 deaths in the city due to unintentional drug overdose. There has been, and I would defer to the health department for the official statistics, but it's been seen clearly that areas of the city that are impoverished have disproportionately been impacted. Older black men have been disproportionately impacted, and while this crisis is still being driven by fentanyl, we are also continuing to have to monitor what drugs are on the street, what drug combinations are with fentanyl causing these fatalities, and the appearance of new drugs on the illicit drug landscape are of consistent concern. The novel benzodiazepines, the synthetic opioids, novel psychoactive substances. We're continuously monitoring for those and sharing that data with our partners so people can be aware of what's going on the street and what combinations of drugs are killing people.
Okay, no, thank you. Councilmember Osei, you have questions?
Thank you so much, Chair, and good morning. Thank you so much for your testimony. My constituents are concerned about the closure of the Crown Heights Clinic. I know that this happened last year, but there are still persistent concerns around its closure. This clinic provided a variety of key healthcare services that my...
Councilmember, this is Office of Chief Medical Examiner, not DOHMH.
Oh, DOHMH is not
Is
here
later.
anymore. My apologies. I saw the confusion on your face. I will forward my questions.
I can ask them for you.
Thank you
if
very
you'd
much.
like.
I appreciate
No,
that.
no worries.
Thank you.
Okay. Any other council members have questions? No? Thank you very much. Very thoughtful responses. We really appreciate all the work that you do. And I still, I know that you've asked us to come out. We will come out to take a tour, so at some point. So thank you.
Anytime. Thank you very much, Chair. Thank you all.
We're going to be taking a 5-minute break, and then we're going to be doing Department of Health and Mental Hygiene. Thank you.
Please keep your noise down. Keep the noise down, please. We still have a hearing rolling. Please keep it down.
Now I would like to welcome the Department of Health and Mental Hygiene and its Commissioner, Dr. Alistair Martin. DOHMH's fiscal 2027 preliminary budget totals $2.51 billion, which represents approximately 1.9% of the city's budget. Funding for public health services totals $1.54 billion, a net increase of $57 million compared to last year's adopted budget. Of this amount, $503.2 million is for personal services and just over $1 billion for other than personal services. However, to echo our concerns with OCME's budget, the potential impact of federal funding cuts remains significant. The plan as presented reflects a $32.8 million reduction in federal funding compared to the fiscal 2026 adopted budget. We understand that DOHMH typically receives federal grant allocations closer to the middle of the fiscal year, which is why these funds are not yet reflected in the fiscal 2027 preliminary budget. However, because federal funding supports a wide range of the city's public health activities, including disease surveillance, public health infrastructure, and prevention programs, we remain concerned about the possibility that some of these funds may not materialize by adoption. Given the ongoing uncertainty surrounding federal public health funding, it is important that the city carefully assess potential funding gaps and consider how reductions could affect programs that New Yorkers rely on every day. Several of the most concerning reductions appear in the disease prevention and treatment program area, which includes funding for communicable diseases, HIV, immunization, sexually transferred infections, and tuberculosis programs. The preliminary plan reflects a net reduction of $36.7 million compared to fiscal 2026 adoption. These reductions come at a time when the city is seeing increases in certain communicable diseases. According to the preliminary mayor's management report, PMMR, tuberculosis cases rose by 24% from 679 cases in calendar year 2023 to 839 cases in 2024, while new HIV diagnoses increased for the second consecutive year from 1,700 in calendar year 2023 to 1,791 in 2024. The rise in new HIV diagnoses is particularly concerning in light of recent reductions in access to sexual and reproductive health services. In 2025, sexual and reproductive health centers in Manhattan and Brooklyn closed, potentially limiting access to routine HIV testing and prevention services. Additionally, in late 2024, nonprofit organizations reported shortages of condoms and other safe sex products through the city's condom availability program. Reduced access to both prevention services and protective resources could weaken the city's HIV prevention efforts at a time when diagnoses are already increasing. That is why maintaining a strong capacity for disease surveillance, testing, and case management remains essential to protecting our public health. We are also concerned about reductions to programs focused on preventing chronic disease. In the preliminary plan, funding for chronic disease prevention within the Center for Health Equity and Community Wellness declined, including a $6.4 million reduction in city funding compared to the fiscal 2026 adopted budget and approximately $1 million less in federal funds. Chronic disease remains one of the leading drivers of premature mortality in New York City, and sustained investment is critical to improving health outcomes and addressing persistent health inequities across neighborhoods. Vaccination efforts are another area where continued investment will be essential. Vaccination coverage among young children remains below the city's 70% target. According to the PMMR, 63.5% of children ages 24 to 35 months were up to date on immunizations in the first quarter of fiscal 2026. This represents a slight decline from the same period in fiscal 2025. Ensuring that the city has sufficient resources for outreach, education, and vaccination access will be imperative to improving immunization rates. I want to commend you, Commissioner, for the newly launched media campaign to address vaccine hesitancy. Given the rapid developments at the federal level, it is important that DOHMH prepare for a range of potential scenarios. Careful planning will help ensure that the Healthy NYC initiative to expand life expectancy can continue to move forward and that the city's public health infrastructure remains strong. Once again, I would like to thank the committee staff and my own staff for this work on this hearing. I also want to acknowledge that we've been joined by... All right, I'm going to start over. Okay, we've been joined by Councilmember Finance Chair Lee, Councilmember Ariola, Councilmember Felder, Councilmember Osei, Councilmember Aldebal, Councilmember Caban. These are on. Councilmember Hanks, Gennaro virtual, Narcisse virtual. Okay. I will now turn it over to the committee council to administer the oath to members of the administration.
Thank you, Chair. Good morning. Please raise your right hands. Do you swear to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to council member questions?
Yes. Yes.
You may proceed with your testimony.
Thank you very much, and good morning, Chair Schulman, and good morning, Chair Caban and Chair Lee, and to all the members of the committee. I'm Dr. Alistair Martin, Commissioner of Health at the New York City Health Department, and I'm joined today by our Chief Financial Officer, Aaron Anderson, and members of my senior leadership team. Thank you for the opportunity to testify today on our preliminary budget as it relates to public health. I'm proud to represent the Mamdani administration, which puts forward a vision of a New York City we can all afford. That agenda is not secondary to public health. It is central to it. In our city, 1 in 4 New Yorkers are living in poverty. We know that that has a devastating impact on health. On average, New Yorkers in the poorest parts of our city die nearly 7 years earlier than those in our wealthiest neighborhoods. That is 7 fewer years to spend with those they love. As we work to design a budget that supports a prosperous New York City, we do all this work with that in mind. We have our work cut out for us. The data makes it clear that the problems of health and wealth inequity are intimately related. And the good news is that the solutions are too. Mayor Mamdani's affordability agenda and our health agenda are aligned. We are focused on buying New Yorkers more time, more health, and more joy in the city we call home. At the New York City Health Department, that work is not new. For decades, we have been working at the hyperlocal level to meet New Yorkers where they are. Every single day, we are making systemic changes by building individual connections. In order to change the material conditions of people's lives at scale, we have to move one conversation at a time. Many of our programs are built on that foundational understanding. For example, the city recently put $20 million towards the Strong Foundations Initiative, which will grow perinatal and early childhood mental health services and expand the Nurse-Family Partnership Program. I personally have seen firsthand just how meaningful that program in particular is. My mother worked as an NFP nurse for nearly 15 years. I know the impact of that program not by the statistics, but by the children's books and toys that would pile up in the back of my mom's old gold Chevy. And the stories she told me about mentoring new moms who were considering going back to school or changing careers like she did. A few weeks ago, I got to be part of making that announcement about the expansion of services in New York City with my mom in the front row. Public health happens in a million small ways, and it is grounded in the relationships we build across our city. All that work taken together contributed to New York City reaching its highest life expectancy in recorded history. That did not happen by accident. Our most recent data shows that in 2024, the citywide life expectancy was 83.2 years. That's higher than pre-pandemic numbers, and it's a testament to a whole-of-government response to the COVID-19 pandemic, years-long efforts on overdose prevention, and long-standing community work to move the needle on chronic disease. The increase in lifespan did not happen by accident, and it represents a monumental success. That said, we are far from finished. There are still devastating inequities in life expectancy by race, by neighborhood, and by income. We are working to improve health outcomes for New Yorkers harmed by the consequences of historic disinvestment. We know, too, that we have to interpret these numbers in context. Today's landscape is entirely different than it was back in 2024. Our latest data show none of the impact of the federal administration's efforts to sow distrust, revoke life-saving benefits, and send healthcare costs soaring. Public health and public services are being dismantled. Yet, we are working hard to maintain our progress in the health and longevity of New Yorkers. We stand as a bulwark against misinformation spewing out of Washington, D.C. We have done so since the inauguration of this administration, and we will continue to do so in the months and years ahead. For decades, the New York City Health Department was closely tethered to national and international public health infrastructure. But in the past year, the United States has adopted an increasingly isolationist approach to international work and a fractured public health strategy domestically. We are left to fill in gaps as much as possible here in this city. Earlier this year, the United States withdrew from the World Health Organization. In the wake of that decision, we became the first municipal health department in the country to join the WHO Global Outbreak Alert and Response Network, or GORN. Following an unprecedented overhaul of the federally recommended childhood vaccination schedule, we continue to distribute more than 2.5 million doses of pediatric vaccines to healthcare providers across our city, and to offer clear guidance where the federal government creates confusion. On Monday, a federal court temporarily blocked the CDC's attempt to change the longstanding childhood vaccination schedule. That is a public health win, but also speaks to the gravity of the federal misinformation we are currently up against. Without reliable leadership at the CDC, we are creating new avenues for collaboration and new avenues for information. We continue to work with our regional partners as part of the recently formed Northeast Public Health Collaborative. We are living in a time of heightened risk, and our team is working around the clock to protect the health of New Yorkers and everyone who travels through our great city. That takes sustained investment from all levels of government and the private sector. I'm now going to turn to the funding that makes all of this work possible. The New York City Health Department has approximately 7,000 employees, all of whom serve more than 8.5 million New Yorkers, 24 hours a day, 7 days a week. 2025 marked the third consecutive year in which hiring outpaced staff departures. We are successfully rebuilding our team to full capacity and recovering from staffing shortages caused by pandemic burnout. We have an operating budget of $2 billion for fiscal year 2027. About $1 billion of that is in city tax levy. The remaining $1 billion are sourced from federal, from state, and private funding. At the city level, we're grateful to see a continued commitment to public health as we discuss the 2027 preliminary budget. In particular, we are encouraged to see resources dedicated to child care site inspections and funding, which was also added for outreach and education for early intervention services at 2K sites. In response to the outbreak of Legionella in Harlem last summer, additional resources have been appropriated to support more cooling tower inspections, disease surveillance and testing, and community outreach and education. We appreciate the new funding to avert future Legionnaire's disease community clusters as much as possible. Additionally, we are happy to provide funding for community-based organizations that serve LGBTQ New Yorkers, especially as federal attacks on queer communities continue. And lastly, as a kid from Queens, I'm particularly excited to see startup funding for a Jamaica Neighborhood Health Action Center to invest in the health of this community. Our brick-and-mortar presence in priority neighborhoods is a critical part of our work, and I'm encouraged by the resources to expand that model to Queens. At the state level, the governor's fiscal year 2027 executive budget for New York State provides crucial support for public health. I want to personally thank Governor Kathy Hochul and Commissioner Dr. James McDonald for restoring the Article 6 matching funds of 36% to New York City. This reverses several years of cuts where New York City was the only jurisdiction in the state receiving lower state reimbursement for core public health services, despite the fact that we are home to the most individuals with low incomes and the majority of Medicaid recipients in this state. This year, New York State will finally restore parity between New York City and the rest of the state, and I'm deeply grateful for the governor's actions on that. I also want to thank Senator Rivera, Assemblymember Gonzalez Rojas for championing this issue in Albany, and we're pleased to see the Assembly and the Senate include this in their budgets. Finally, thank you to Speaker Menon, to you, Chair Schulman, and the entire Council for your continued advocacy on this issue. The Health Department also supports Governor Hochul's proposed plan for universal child care, taxes on tobacco products, and a continued commitment to reproductive health care. Finally, I'll speak to the federal budget. About 20% of our budget is federally funded. That amounts to approximately $500 million. The majority of that funding goes towards emergency preparedness and infectious disease control. We expect the federal government to honor its commitment and maintain that funding. But if history is any indication, we cannot rely on federal resources. Last spring, the Trump administration unlawfully rescinded $11.4 billion in public health funding. Within that massive cut, approximately $100 million was earmarked for critical disease control and outbreak prevention infrastructure right here at the New York City Health Department. Thankfully, our funding was retained due to a successful lawsuit led by New York State Attorney General Letitia James. That said, we must brace for possible future cuts. We are enduring coordinated and large-scale attacks on public health, and we do not foresee them letting up anytime soon. And so we have a dual responsibility: to care for New Yorkers and to serve as a national leader and a universal trusted source in public health. We remain committed to do just that. I'm very grateful for the support at the state and city levels as we continue to defend public health every single day. I'm confident that even amidst all of these challenges, a healthier, more affordable New York City is on the horizon. Thank you for your attention, and we're happy to take your questions.
Okay, before I ask questions, I'm going to ask Finance Chair Lee for her questions.
Thank you. Good morning. I was going to say afternoon. Sorry. And it's great to see you, Commissioner, and to see you in person versus just a picture. So thank you so much for joining us today.
Thank you.
So I'm just going to go right into the Chief Savings Officer plans, which I know that we've been asking every agency and the mayor's executive order to undertake a Chief Savings Officer and place one at each agency. So what was it, first, have you identified someone? Who is the person that you've identified? And what was the process to conduct the required review of spending and operations within the 45-day time frame?
Thank you for that question, Chair. Yeah, we are committed to doing everything we can to comply with this executive order and to follow through on the mayor's vision for the Chief Savings Officer role. Our Chief Savings Officer at this agency is Emiko Otsubo, who's our Chief Operating Officer. To share a little bit more about the specifics on what we're doing on the Chief Savings Officer, I'm going to hand it over to Aaron Anderson.
Yeah, good morning, and thanks, Chair Lee, for the question. Right, so CSOs, and I've been working very closely with CSO Emiko, have been tasked with identifying recurring savings through efficiencies, program consolidations, insourcing, and eliminating or sunsetting programs. We've been tasked as a city with achieving 1.5% in savings for the current year and 2.5% in the out years, starting in '27. And the mayor's been pretty clear that vital services will not be cut. So we've continued to go through that. It's been a long and detailed process over the past month and a half or so, and we're just finalizing our work on that and preparing for submission tomorrow, in fact.
Yes, due tomorrow. And if you could go into which unit of appropriations and program areas within the fiscal year '27 prelim budget are expected to be reviewed, which I know you sort of touched upon, and how will the agency determine which services deliver the strongest public health outcomes for New Yorkers? And with that question, I just want to emphasize that obviously in our conversations about savings and efficiencies on the council side, we definitely want to make sure that that is not going to sacrifice on the services that New Yorkers are receiving, because what you guys are doing is super critical work. So I just wanted to preface it by saying that as well.
Yeah, thank you for that, and I think we certainly share that sense of ensuring that we're preserving critical services while looking for, realistic and achievable efficiencies and savings. I mean, we've looked across the entire agency, right? We're a big, complicated agency that has lots of lines of work, from animal care control to disease detection to school health and lots of other things. So we're still finalizing what our proposals are and looking at all those areas, but we're really looking across the entire agency writ large, from insourcing potential, contracts. We're looking at IT contracts, other contracts, just across the board. So it's hard to say at this particular moment exactly what the final proposal will be, but we look forward to having further conversations once it's
Great.
once
No,
it's
thank you. And as you mentioned, yes, DOHMH is definitely a big agency. So it'd be great to see where those savings can be, especially things internally, operationally, contracts that could maybe be shared, like resources that can be shared as well would be great to look at. Do you anticipate any consolidation or restructuring of programs as part of the review? Or, I mean, I know you're looking into it, reports are due tomorrow, but just if you could speak to any of that.
Yeah, I mean, I think everything's on the table. We're casting a very wide net and looking across all of our programming, and also at the administrative side of the work that we do.
And how have you been evaluating those programs that you're looking at?
I mean, I think each program is different. Each program has different metrics and KPIs and measures of success. And so I think it's a different evaluation for each program. And they're so diverse, it's hard to apply a one-size-fits-all model. But we're certainly casting a wide net and looking carefully at everything.
No, and I appreciate that because, as you mentioned, the programs that you all have under your portfolio are very different. So it's great that you're looking at different metrics and outcomes to see what makes sense in each of those program areas. So I appreciate that. And how, moving forward in the out years, because I know it's 2.5% in the out years. So once you guys identify those savings, what are some of the systems, I guess, that you'll have in place to sort of follow that?
I mean, I think it depends on how it all plays out. I mean, this is a City Hall, specifically First Deputy Mayor-led initiative, so we're in regular and close contact with both the City Hall teams and the OMB teams about what this will actually look like. But this is the first phase and the first step of that, which is just casting a wide net, looking at options, and then evaluating what might actually be feasible.
Okay, and we look forward to looking at the report, so thank you. I know it's not easy work, so appreciate it. And then just moving on to medical debt, because this is a topic that we had talked about briefly at the Health and Hospitals hearing as well. And having worked under the head of a social worker at a previous, at a hospital, private hospital, I know that the way that they approach the medical debt relief is different depending on the hospital, depending on who's in charge. Some are more patient-oriented, some are not as much patient-oriented, so. But DOHMH has partnered with Undo Medical Debt, formerly known as RIP Medical Debt, to clear New Yorkers of $2 billion in medical debt. And the program was first announced in January 2024 and was first funded in fiscal year 25 executive plan for $18 million, dispersed between fiscal years 25 through 27. So just wanted to check, is the city on track to relieve the full promised number of people and amount of medical debt by the beginning of next year?
Thank you for that question, Chair. This is an incredibly important subject that you can't remove from the conversation around affordability.
Right.
As we know, medical debt is the biggest driver of personal bankruptcy in the city for New Yorkers. Mm-hmm. And the work that we've done has been a tremendous start. We've been able to erase about $135 million in medical debt so far. Just over half of the individuals who have received those envelopes in the mail, relieving them of their debt, are in TREE neighborhoods. And so, we see this as an incredibly important tool in our toolkit when it comes to addressing healthcare affordability. With regard to the future of the program, we're working very closely with Undo Medical Debt to identify how we can leverage that $18 million and really make sure that we make a dent on that issue. And so, the conversations are ongoing, and this is a place of personal interest of mine.
Thank you. And just out of curiosity, how are communities and individuals identified for inclusion in the program as a first step? And then are there geographic or income-based targeting criteria? And then the second part of my question, which is not in here, which is something close to me, is how are those people being reached out to? Because I know you said mail, but in different languages? Because as we know, we're a very diverse city, and some folks may look at it, if it's in English, they might just discard it and not realize. So just wondering what the outreach efforts are as well,
Yeah.
once those folks are identified.
Yeah, it's a really good question. So first of all, we are working to cancel debt citywide. Now, the individuals who do receive the interventions typically end up being from communities that have rates of legacies of historic disinvestment. As I mentioned, over 50% of those who have received the intervention are in those tree neighborhoods. And so there is targeting to make sure that we are helping folks who are low income, communities of color, individuals who are underinsured, uninsured, and we're building that sort of broader monitoring infrastructure to make sure that we can really target this intervention.
Great. And then I guess roughly in your estimates, how much support would that amount to dollar-wise as well?
It's a great question. You know, we Chair, are taking advantage of the ability to buy debt cheaply here, and so that $18 million, you know, if we add that up, you know, as we think about how we can go on the market and buy that debt from participating hospitals, we can get into the billions. You know, the numbers, you know, range between 1.5 and 2 billion, and so, you know, we're aiming to hit those targets. And I'll say one other piece, and that is that the issue of medical debt can be addressed in different ways. And so we are looking at all the different levers that are possible, and this partnership with Undo is an essential part of that plan.
Okay, great. And how much of that 18 million investment is reflected in the budget for DOHMH?
That's a good question. Let me hand it over to Aaron Anderson to show a little more on that.
Yeah, so it's $6 million per year, so there's $6 million included in FY27.
Okay, perfect. And I think I know the answer to this, but is the allocation sufficient to meet the $2 billion relief goal?
You know, so the goal of this work is to really work closely with Undo Medical Debt to make sure that that funding that we have can be used as effectively and as efficiently as possible. And so we're working closely with them to try and identify how to do that, how to maximize the money that we have.
Okay, thank you so much. And that's why I just want to reiterate, definitely an issue in terms of communities of color, for sure, where it negatively impacts them a great deal. And this is why prevention is so important, because we need to make sure that we're keeping people healthy, which saves the city and state dollars in the long run. So thank you so much for your work, and that's it. Thank you, Chair.
Thank you, Chair. So I also want to I'm going to ask somebody, one of my colleagues, to ask questions so that they can move on to their next hearing. But I also want to mention, in terms of Undo Medical Debt, that the CEO of Undo Medical Debt is a friend and constituent of mine. And she's, her program is being done across the country, and she's met with the governors of almost every state. So I'm very glad that we're doing work with her and that we can relieve people of their medical debt, which I think the president just said that they're not going to let people take that off of their credit reports anymore. So it's even more needed. I'm going to ask Councilmember Osei to ask some questions, and then I'll get to mine.
Thank you so much, Chair, and congratulations and welcome to the new commissioner. My constituents are concerned about the closure of the Crown Heights Clinic. This clinic provided a variety of key healthcare services to my constituents that they truly depended on, including rapid COVID, flu, RSV, rapid testing, as well as STI testing. Constituents are concerned that with the closure of this clinic, many will lose access to accessible rapid testing, especially those with chronic illnesses who need to know their COVID status sooner rather than later to ensure they can get Paxlovid, or other COVID prevention treatment on time. My first question is, why did the Department of Health decide to close down this clinic? And I know that this took place prior to you being in this position, but many are requesting this question from my office.
Yeah. First of all, thank you for your leadership on this issue, Councilmember. As you know, we offer a range of clinics which are low cost to no cost clinics. We have 6 sexual health clinics, 3 TB chest centers, and then 1 immunization clinic. And what we see coming through these clinics is because we're providing low barrier of care services for folks, we see that about 87% of the individuals that are coming in are historically disenfranchised. With regard to the clinics that have been closed, 3 of those clinics were closed during COVID. And so we have, a priority around trying to reopen the Washington Heights TB clinic and the Crown Heights clinic, which you mentioned. And so that is absolutely a priority of ours. At present moment, we don't have the ability to do that, but we are absolutely intending to move in that direction.
So you said that, I really do appreciate that there is a plan to reopen those clinics. What are the obstacles in getting to the reopening of this specific clinic?
Yeah, let me clarify. We certainly are interested in doing so.
Sure.
And the ability to do so is going to be contingent on the funding and resources to be able to do that. And so we're in constant conversations with our colleagues at OMB and across City Hall to do this. And we look forward to working with you and continuing the conversation around what the future holds.
Do you have any idea in terms of how much it would cost to open one of these clinics? Like if I were to advocate for the reopening of this specific Crown Heights clinic, how much should I be advocating to the mayor to include within the budget?
Yeah, good question. Let me hand it over to Aaron.
Thanks for the question. We're actively working on estimates and potential projections and continuing those conversations with OMB. So there's not a specific number at this time. But
Okay. I appreciate hearing that. May I ask one more question? My constituents are also concerned about the lack of gender-affirming care in the city. We're also aware of NYU Langone's decision to close its transgender youth health program as the federal administration continues to threaten healthcare facilities and roll back funding from LGBTQ+ health organizations. As I'm sure you know, healthcare that is accessible and safe for queer and trans New Yorkers is now a pressing issue for our city. How can the Department of Health ensure that gender-affirming care services and other health resources for LGBTQ+ New Yorkers continue to remain available in H&H clinics and other DHMH sites?
Thank you again for your leadership on this issue, Counselor. We are very much invested in the care for individuals in the trans community and non-binary community, and think it's a priority of ours to make sure that we can provide the services that this community needs. We recently met with the Commissioner on Gender Equity to begin really thinking through how we can do a better job of prioritizing the needs of this community. But this is something that we'll continue pressing on, and we look forward to working with you and your team on making sure this is reality.
Sure. Would love to hear from both of you, especially when it comes to budgetary costs of how much both of these issues would cost, right? I think it would help on our side of things be able to advocate for this funding. So whenever you do have those numbers, I would love to hear back from your office. Thank you, Chair.
We can follow up.
Thank you. I just want to acknowledge we've been joined by Councilmember Nurse. So now I have a bunch of questions for you, Commissioner. In the preliminary plan, DOHMH's federal funding decreased by $32.8 million in fiscal 2027 compared to the fiscal 2026 adopted budget. The city primarily receives federal funding for the disease prevention and treatment program area, in which communicable diseases had the highest decrease in funding, followed by sexually transmitted infections and tuberculosis. We remain concerned that the city might lose part or even all its federal dollars for health services. Is the reduction of $32.8 million due to the federal government's new policies, or is it due to external factors?
Yeah, thank you for that question, Chair. We share your concern with what we're seeing at the federal government and the way they've threatened public health funding, the way that they're communicating with regard to public health messaging. We are in an unprecedented era here. And also, we are not going to wait for the federal government to come in and swoop in and save us here in this city. We are leading, we are stepping in, and we are making sure that New Yorkers have what they need to be safe and healthy. With regard to the $32.8 million that you discussed, That reduction is actually not due to the federal government clawing back funding. That's due to the fact that these federal grants have not fully been loaded yet in the preliminary budget. And so we think that once those are loaded, the expected federal funds will be about 20% of our total budget, or around $500 million a year. And that's sort of the standard budget timing, and these are not confirmed cuts.
Okay.
And Chair Schulman, I'm sorry, just to add
Yes.
to that, it's true, a lot of our funding, as you acknowledged in the opening, is loaded over time, with one exception. So it's not a cut, but there is the expiration of federal COVID funding, supplemental funding, that's ending this July. And so actually, when we sat here, this hearing last year, exactly 1 year ago, and said that $100 million was what we had left, the day after that hearing, it was rescinded and replaced. But we're basically in the final stages of spending that last amount down through this coming July.
So that'll be how much less for next fiscal year?
So the final annual amount currently of that supplemental funding is about $30 to $35 million. So that's
Okay.
one of the reasons that's contributing here.
Like, what are the major federal grants that DOHMH received for healthcare in fiscal year 2026?
Yep. Thank you for that question, Chair. In FY 2026, we received $453 million in federal funding. More than half of that supports disease control. We're talking about surveillance, labs, HIV support, childhood vaccinations. Just double clicking on the HIV and STI funding, which is about $225 million, 87% of that budget comes from federal funding sources. I'll hand it over to Aaron to share anything else he's got.
Yeah, thanks for the question. So some of the major federal grants that we receive include Ryan White, which is probably the biggest, epidemiology and laboratory capacity, housing opportunity for peoples with AIDS, which we split with the Department of Social Services, public health emergency preparedness, and then we have our core cooperative awards for TB control and immunization. Those are sort of the biggest ticket pieces of
Right.
our federal portfolio.
Yeah, have you, for fiscal 2026, has DOHMH received reimbursement for all its programs as anticipated? Sounds like it. Yes.
Yeah, we have not experienced any significant changes this year, and we remain
And do you
optimistic.
expect any of the federal grants to be reduced or eliminated? I mean, I know it goes back and forth, but,
I mean, based on our best reading of the tea leaves and the budget that the feds passed, the continuing resolution, it appears to be okay at the moment, but we've certainly experienced whiplash over the past year. But we're in an okay place right now.
excluding any COVID-19 related funding, which you just mentioned, how much funding do you anticipate the DOHMH will receive from the federal government by adoption?
So we expect the total to be around $500 million, around 20% of our budget. It's hard to know exactly until then.
All right. Does DOHMH have a contingency plan if the federal government withholds funding?
Yeah, thank you for that, Chair Schulman. We are closely monitoring the situation. We're trying to really, as Aaron said, read the tea leaves and predict what might be coming down the path. But we are currently in active discussions with OMB, with the law department, and the mayor's office to come up with plans. If there are cuts to specific activities, we will assess and make decisions around what will protect New Yorkers' health and safety the best in those moments.
Okay, the New York State fiscal 2027 executive budget proposes total spending of $260 billion compared to $252 billion in fiscal 2026. Within the city's budget, DOHMH's fiscal 2027 preliminary budget includes $311.5 million in state funding for health services, an increase of nearly $65 million compared to last year's adopted budget. How much funding do you anticipate DOHMH will receive from the New York State fiscal 2027 enacted budget for public health programs?
Thank you for that question, Chair. As you know, the funding that comes into this department is really broken up in three different sections: city tax levy, the feds, and the state. And so we work very closely with our state colleagues, and we're encouraged by what we're seeing in the governor's commitment to restoring critical public health funding. We're going to talk about Article 6 in a bit, but what we're seeing in the FY27 state funds is that the funding that we'll get from the state is about $722 million, which represents approximately 30% of our total budget. Let me hand it over to Aaron to share more.
Yeah, thanks, Commissioner. Right, so that's the total state amount for the entire department. On the public health side alone, we're expecting probably around the order of 400 million.
Okay.
And a big piece of that is, of course, the Article 6 restoration, which we are delighted to have.
Yay. Which DOHMH programs are expected to receive the largest share of state funding?
You want to take that? I'm going to hand it to Aaron.
Thanks. The single largest program on the state side is early intervention.
Okay. That's great. The state's Medicaid program serves 6.8 million New Yorkers, and the executive budget includes changes to the essential plan and Medicaid eligibility due to federal policy changes and funding reductions under H.R. 1. How will the proposed transition from the Section 1332 waiver back to the basic health program under Section 1331 impact New York City residents, particularly the more than 460,000 essential plan enrollees expected to lose coverage when the income eligibility threshold is reduced from 250 to 200% of the federal poverty level?
Yeah, thank you for that question. We share your concern, Chair. The transition from Section 1332 to 1331 is, put simply, going to mean that more people will lose their health coverage. And as we know, 460,000 of those folks who will likely be affected by this change, the majority of those people are here in the city.
Right.
And so the ultimate estimates around what DOH at the state is thinking about is about 713,000 New Yorkers will potentially lose their coverage through a combination of all of these different federal policy changes. And so we have not remained stagnant on this. We are not sitting back. We've submitted public comment to limit the essential plan impact. We're planning public education, provider outreach, advocacy to try to meet the moment and help keep people covered.
Yeah, I mean, it's interesting because none of this was in any of the one state and the Assembly or Senate, their budgets that they put out, so, which was odd to me, but okay. So we have to keep advocating for that. Federal changes will eliminate eligibility for certain non-citizen populations and end federal Medicaid support for some legally present immigrants beginning in October of 2026. How many New York City residents could be affected, and what steps are being taken to ensure they maintain access to coverage?
Yeah, thank you for that question, Chair. We are, again, alarmed, and we share your concern with what the federal administration is doing. In effect, they are abusing immigration law in ways that are dangerous to residents' health, to their well-being. And this is, quite frankly, going to mean that not only will there be a chilling effect across individuals coming to our sites, but also healthcare sites throughout the city. And then on top of that, you add the fact that coverage will also be threatened for these communities. And so what we are doing, we launched the Every New Yorker Without Exception campaign and adopted policies restricting cooperation with ICE on DOHMH property. But we know the fight is not over. We know we have to continue to push and to advocate and to make sure that we protect folks in the city.
But how many New York City residents do you think could be affected by those changes?
Yeah, so the state estimates that we have from New York State is in total about 713,000 New Yorkers.
That's for the state, right?
For the state, yeah.
What about the city?
We can get back to you in terms of sort of the slice of that are city and the slice that are
Would like
immigrants.
to have that. Aaron, you don't have those figures? Okay, all right. The executive budget notes that federal policy changes will significantly reduce federal funding for the essential plan and other health services. What fiscal and coverage impact could these changes have on New York City residents and the providers that serve them?
Yeah, I mean, the overall impact here, Chair, is that we're going to likely see an increase in uncompensated care. Folks are not going to be covered because not only will we see the changes, which will hit in July to the essential and basic plan, but we're also going to see these new changes, which will hit in January of 2027 around Medicaid specifically. But we also have to acknowledge what happened in December of 2025 with Congress's failure to sustain the ACA subsidies, which has meant that premiums have increased by quite a bit, 38%. So we
Right.
have a number of different things that are happening here which are leading to individuals not being covered. So we think that ultimately we're going to have more individuals who are going to likely need uncompensated care, going to places like H&H, our partners at across the city, and other safety net providers. And we are helping New Yorkers explore alternative coverage and affordable care options.
What coordination is occurring between the state and city to prepare providers and enrollees for these policy changes?
So, you know, I can speak, you know, from the perspective of the health department. We are committed to using every single lever we have to help individuals stay covered, to know that they have to do these work requirements, which now have to happen every single month, helping them do their renewals, which now will have to happen twice a year. And so we're committed to trying to find every single intervention that we can to do that work.
In New York State, total Medicaid and essential plan spending is projected to reach $122.9 billion in fiscal 2027, including $65 billion in federal funding and $48.5 billion in state funding. In fiscal 2027, the state will also assume nearly $9.2 billion in costs that could otherwise have been incurred by localities. How much Medicaid funding does DOHMH currently receive, and how might that change under the fiscal 2027 executive state budget?
Yeah, thank you for that question, Chair. You know, Medicaid is a critical funding source for so much of the core programs that allow New Yorkers in this city to get the care they need. And so we have a number of Medicaid-dependent programs, our early intervention program, our mental hygiene contracted services like supportive housing, the ACT team, IMT teams, and our public health clinics. And so we're working with our colleagues at OMB to really assess the full exposure and what might be coming down the pike here. So let me hand it over to Aaron to see if he has anything else to add.
Sure. Just to add to that, so we receive approximately $68 million in Medicaid funding. And that's a combination. It's really two parts. There's the direct services we get reimbursed for, then there's Medicaid admin. So depending on the program, it's one of those two things. But we do expect a similar amount for the next year.
Which DOHMH programs rely most heavily on that Medicaid funding?
Yeah, I can share and then have Aaron add on. So as I mentioned, a couple of the programs that rely very heavily are early intervention. And so that is very much part of, Medicaid is very much part of the revenue that we rely on for patients to get the care, or New Yorkers to get the care they need through the early intervention program, our sexual health clinics, TB chest centers, or school-based health centers, and the mental hygiene contracted services. So all of these different programs serve Medicaid-enrolled individuals. Let me hand it over to.
Can you get us what, you may not have it now, what percentage of those program budgets is supported by Medicaid, a breakdown? All right, if you can get that to us, that would be great. Because like I said, we want to advocate, so we want to figure this out. The state budget provides an additional $75 million for the medical indemnity fund in addition to its $52 million base. How many New York City children are currently supported through the indemnity fund?
Yeah, thank you for that. We're committed to ensuring that children with birth-related neurological injuries receive all the support that they need. As you know, the Medical Indemnity Fund is a state-administered program, and so we're working to support the state in their efforts. But we don't directly manage enrollment or distribute those funds.
Okay.
Let me hand it over to Aaron to see if there's anything else to add.
Yeah, just to add that, as with so many of these state initiatives, we're closely monitoring what's going on with the state budget, and we'll see what's agreed to in the executive budget and an enacted budget in April, and take it from there.
With what's been stated as potential additional funding, will that expand coverage for New York City children? We don't know yet, right?
Which additional funding?
The state budget, it is giving $75 million more for the fund. We don't know, okay. Article 6, which I took on as soon as I took office in 2022, and we've been advocating ever since, and then was joined last year by Assemblymember Gonzalez Rojas and State Senator Gustavo Rivera, and we were finally able to get that done, so I'm very appreciative of that, and we've been pushing, it's been on the agenda, the council's agenda with the state for all those years, and I had the privilege this past weekend to meet with the governor and thank her personally for that. So I'm very happy that we have that. So with that additional restoration of $60 million for fiscal 2027, what programs and services are going to be, are we going to be able to restore funding to, or what programs and services will be supported with that $60 million?
Yeah, first, before I answer that, just to say thank you for your leadership and for your advocacy on that issue. This is a hugely important equity issue, as you know. That the disproportionate share of individuals who are on Medicaid are here in the city, and so we need every single dollar in the city to be able to carry out the core public health mission of the work. I'm going to hand it over to Aaron to talk a little bit about the specifics of how the money is flowing.
Yeah.
Did we get that yet, or we didn't? We're going to get it when the budget passes, and is that the way it?
We're optimistic and confident that it will appear in the final budget. It's in the it's in the initial budget, so it's.
Well, if it doesn't, you tell, we'll figure it out, but.
Yeah, and
I'll get to
just
it.
echoing the commissioner's thank you
Yeah,
to
yeah.
you and the rest of the council. Right, so this sort of reverses a major cost shift from the state to the city that occurred under prior admins dating back to 2019. The biggest change now is that we will no longer need to cover with city funds the difference between the 20% reimbursement rate, which is what it was, and now it's 36%. So it's really, this is about core public health services. It's family health, it's communicable disease control, it's chronic disease prevention, it's environmental health, emergency response, and it goes on and on. So this is a huge change, and it's really reversing this cost shift that had been in place for so many years.
We should, when we get that money, maybe we should do something publicly around what we're going to be funding, and
Love that.
so the state can see what, the governor can see firsthand, like what we did, maybe invite her or something. If Article, let's see, nope. Do you anticipate that a full restoration of Article 6 funding would allow the city to reinvest local dollars into other public health priorities?
Chair, we think that a full restoration would certainly free up additional city resources. And so with those extra resources, I think the core public health functions of this department and all of the contracted CBOs that we work with will be made more effective and reach more people.
Okay, by the way, I want to acknowledge we've been joined by Majority Leader Sean Abreu. The Mayor's Management Report metrics indicates that 1,791 people were newly diagnosed with HIV in calendar year 2024, up from 1,700 in 2023, 1,591 in 2022. This marks the second consecutive annual increase following a decade of steady declines prior to 2020. The PMMR also notes persistent inequities with the majority of new diagnoses among Black and Latino New Yorkers, men and people ages 20 to 39. At the same time, 90% of people with HIV who are in care have achieved viral suppression. What factors may be contributing to the recent increase in new HIV diagnoses?
Thank you for that question, Chair. So we use a multi-pronged approach to improving access to testing, to treatment, and to prevention. This is a complicated question in terms of what's driving these rates, but some of the factors include things like increased testing engagement, population changes, possible increased transmission, but also some of the structural, more difficult social determinants of health issues, poverty, housing instability, lack of insurance, and unmet service needs. And so we know that this is an area that we need to watch closely to make sure that these trends don't continue, and we're committed to investing every single resource we can to reversing that trend.
What outreach and testing strategies is DOHMH using to reach communities most affected by HIV, particularly Black and Latino New Yorkers?
Thank you. I'll say a few words, and then I would love to have Dr. Sarah Bronstein join me. But we have a number of sexual health clinics that we currently operate, 6 sexual health clinics, a telehealth hotline, the Play Shore Network 2.0, one-stop model, our considerable resources around Ryan White. And so we have a number of tools at our disposal to really tackle this problem head on. But let me hand it over to Dr. Bronstein.
We have to swear you in first.
Please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to council member questions? You may proceed.
Thank you, Chair, and thank you, Commissioner, for the opportunity to speak about what is a persistent concern about the persistent inequities we see in the impact of HIV on New Yorkers. As you noted, there's been, in fact, it's the 4th consecutive year that we've seen an uptick in new HIV diagnoses in the city, and we are very concerned. We do, though, use the very robust information we capture in our HIV surveillance system to design an array of programs that are responsive to the epidemiologic trends and the our knowledge of communities' needs related to HIV. And many of these are really aimed at supporting communities most affected. We know that we have to tailor our resources accordingly. So the Commissioner mentioned our Play Shore Network 2.0, wherein we fund nearly 20 clinical and non-clinical agencies to provide an array of sexual health services, including related to HIV, really in a one-stop shop model, in a whole person-centered approach to give people all the services they need when they have that touch point with the healthcare system. And Play Shore providers are required to focus their efforts on serving communities most affected, including Black and Latinx communities. Another good example of this programming is our Be Into Health program, which is designed to support people living with HIV and really ensure that specifically members of these populations and communities we know are most disproportionately affected by HIV are achieving the HIV outcomes that the tools and technologies exist to achieve, so that they are achieving viral suppression, that they are firmly engaged in high-quality HIV care, so that their own health is protected and the public's health is protected. We certainly also have our sexual health clinics, which provide really critical HIV and sexual health services, again, to communities we know aren't able to or aren't willing to access services elsewhere.
And I appreciate that. And by the way, just mentioning the sexual health clinics, my office also gets complaints about the one in Crown Heights that's not there. So it's particularly there was a need that was being filled there. So we should really take a look at that. Why does DOHMH report new HIV diagnoses rather than estimated new infections as a PMMR metric?
Dr. Bronstein.
Sure, thank you for that question. It's a complex one, actually. But I mentioned our robust HIV surveillance system, which we are very proud of. How robust that system is. And in that system, we're able to capture new HIV diagnoses, which are based on laboratory and provider reports of positive HIV tests and new positive HIV tests. The metric that you mentioned, Chair Schulman, the estimated HIV incidence, is really an estimate. It is based on a pretty complex model that CDC develops and that all health department jurisdictions use to estimate incident or new HIV infections. And so data on new HIV diagnoses, which we can actually count and measure in our surveillance system, are more reliable, more robust for tracking the epidemic here in New York City. So that's why we report on new diagnoses in the PMMR, but we certainly do report on estimated incidents in our annual surveillance reports.
Okay, given that the Trump administration has cut funding for HIV prevention programs, including access to PrEP, how is DOHMH planning to sustain HIV prevention and treatment services?
Yeah, thank you for that, Chair. We are closely monitoring the situation with regard to, bless you, Jury Leader, closely monitoring our exposure. As you know, $225 million in our budget goes to HIV and STI funding, and 87% of that funding is exposed. And so we're in constant conversations with OMB, with the Law Department, and with the Mayor's Office to shore up our defenses and make sure that we have a contingency plan in place. But I'll hand it over to Aaron to see if he has more to add.
Yeah, just to add that over the last year, we've watched that we've had this whiplash with the federal administration, right, around what's going to happen. There was a House proposal, there was a Senate proposal, there was the president's budget. Each of them differed in the risk associated with what was going to happen with HIV funding. Ultimately, as it stands today, knock on wood, we're in an okay place. But obviously, we remain vigilant always.
Access to sexual health prevention resources remains a critical component of the city's HIV prevention strategy. As new HIV diagnoses have increased in recent years, nonprofit organizations reported in late 2024 that New York City's condom availability program, which distributes free condoms through community partners, was experiencing supply shortages. At the same time, recent clinic closures, including the Planned Parenthood of Greater New York Manhattan Health Center and 2 Brooklyn sexual and reproductive health centers operated by Public Health Solutions in Fort Greene and Brownsville, raised concerns about access to testing, prevention resources, and sexual health services. Together, these developments raise questions about whether New Yorkers have sufficient access to the prevention tools needed to reduce HIV transmission. What is the current status of the reported condom shortage?
Thank you for that question, Chair. So the NICAP program, or the Condom Access Program, or Condom Availability Program, is one of the largest free, safer sex programs in the country, and we take any disruptions in that supply seriously. We did experience a temporary supply shortage in 2024.
Okay.
We worked quickly with our vendors, with our distribution partners, to make sure that we restored the inventory levels across our community partner network, and we have monitoring systems in place to make sure that we're tracking distribution volume. We're confident that our current supply can meet the demand.
Okay. That's great. Given that the MMR shows new HIV diagnoses have increased in the past 2 years, does DOHMH believe that limited access to condoms or other prevention resources may have contributed to the trend?
Yeah, thank you for that. No, we don't think that that limited shortage caused that increase in HIV rates. We think it's a much more complicated picture than just that.
And you have monitoring systems, I assume, to figure out the condom distribution and all of that?
That's right.
Okay.
That's right.
How has the loss of sexual and reproductive health clinics in Manhattan and Brooklyn affected the availability of sexual health services, including HIV testing, STI screening, and condom distribution in these neighborhoods? Similar to what Councilmember Osei was asking about.
Yeah, thank you. I'm going to say a few words and then invite Dr. Bronstein back up. We think that the sexual health clinics are a critical part of our infrastructure when it comes to protecting New Yorkers and providing this low to no cost alternative for New Yorkers. And we also understand that for many New Yorkers, it's better for them to come into one of our clinics than to go to see their doctor. There's a level of it's just a better environment for them to do so. And so for those New Yorkers, we really want to make sure that we are providing this resource. Let me hand it over to Dr. Bronstein to share a little bit more.
Thank you, Commissioner and Chair. We are really proud of our sexual health clinics. We are really a leader in the types of services, the breadth of services, and the culturally responsiveness of the services that we offer in these clinics, and we know they reach the communities that need them most. So the 6 sexual health clinics that are operating now, offer a huge range of services, right? We are offering sexual health services, HIV testing, STI testing, including also linkage to or provision of post-exposure prophylaxis for HIV, pre-exposure prophylaxis for HIV, reproductive health services, including medication abortion, vaccination services for STIs, and then increasingly, as we develop more and more partnerships with community organizations in the areas that our clinics are located in referrals for additional services that community members might need.
So how are you maintaining or expanding access to sexual health services and prevention resources in the areas where the clinics were closed?
We do have, in addition to the sexual health clinics, we do have our funded community partners, both clinical and non-clinical, who are located throughout the boroughs, and again, in high-needs areas, including some of the ones where our clinic closures have occurred. So between the sexual health clinics, our programming, our condom distribution that happens, again, in high-priority areas, we are confident that we are covering the needs of communities with our sexual health services.
Okay, DOHMH administers several, I'm done with HIV, you can. DOHMH administers several maternal health programs aimed at improving pregnancy outcomes and reducing infant mortality, including maternity, infant reproduction, newborn home visiting, nurse-family partnership, and universal home visiting programs. The fiscal 2027 preliminary plan includes $49.9 million for these programs. At the same time, pregnancy-associated mortality continues to show significant racial disparities, particularly among Black women and birthing people. In the preliminary plan, the maternal infant reproduction program was allocated $7.3 million, a 9% reduction from $8.1 million in the fiscal 2026 adopted plan. What specific services will be reduced as a result of this cut?
Thank you for that question, Chair. You know, this is an incredibly important issue that we must remain focused on addressing and trying to close the racial and ethnic gap. What we know from our data is that for Black birthing people, 75% of maternal deaths are preventable, and many of those happen in the post-discharge period, which makes the work of community-based and clinical support after birth very, very, very critical. We also know that Black women are 4 times more likely to die from pregnancy-associated death and 6 times more likely to die from pregnancy-related deaths versus their white counterparts. And so we have a number of different initiatives to try and meaningfully address this. One of the programs that I'm most proud of and take pride in is the Citywide Doula Initiative, which we will talk more about. But also, you know, interventions like the Stress-Free Zone in Brownsville and the nation's largest nurse-family partnership program, which does home visiting services to new parents. And so this is an issue that we remain committed to addressing. We have a number of tools in our toolkit, and we will not let up until we make an impact on this issue.
You're going to address the cut?
Yeah, and just to add to that, Chair Schulman, so there has been no cut or reduction in the maternal health world. I think what you may be referring to is that the city council funds are not baselined, so the amount that you're seeing perhaps in the current year is a little bit higher than the funding that's going to be in FY27.
Okay, so what portion of the $49.9 million in maternal and child health funding is dedicated specifically to addressing racial disparities in pregnancy-associated mortality?
Thank you for that question. I'm going to hand it over to Aaron to share more there.
So, I mean, I would say that all of our maternal work is driven by that goal. You know, one of the Healthy NYC goals, we aim to reduce the rate of pregnancy-associated death among Black, non-Hispanic women by 10% by 2030. It's a central goal for the agency. There's no specific dedicated funding stream because the agency is oriented as a whole to addressing racial disparities in our work, and that is public health.
What metrics are being used to evaluate the impact of the $49.9 million to address racial disparities?
Yeah, thank you for that question. So the metrics that we're using are pregnancy-associated events, adverse events, preterm labor, emergency C-sections, and of course mortality after birth. We have other important metrics that we can share more, but those are some of the most important indicators that we look at.
How do DOHMH and H&H collaborate in improving maternal health efforts, and how do the services differ between the two?
Yeah, thank you. We work very closely with our partners at H&H to make sure that we are offering a synergistic approach in making sure that we do the best we can to provide comprehensive maternal health services. We are developing the Maternal Home Collaborative, which is a delivery and payment model which helps to reduce mortality by supporting birthing people in both clinical and in community settings. And we're exploring and moving forward with the 1115 Medicaid waiver to fund that work. We also have a number of other programs, including the home visiting programs, which provide this sort of community to clinical continuum. And H&H really is able to intervene in the healthcare setting, in the hospital and health center setting. And so it's really this sort of combined approach there in the traditional kind of brick and mortar, and we are in the community doing the work. But both of our teams have a role to play in making sure that we address this issue.
Are current funding levels sufficient to meet the city's maternal health goals?
Thank you for that question. I'm going to hand it to Aaron to talk a little bit about the budget there.
One thing I would say is actually the number that you cited earlier, the 49 million, is actually one piece. It's the largest piece. But actually, when you think about the maternal health work that happens across the agency, which happens in at least 3 different divisions,
Okay.
It's actually $69 million. So it's a substantially higher amount. I mean, we're always thinking about resource levels and what we need to achieve goals, but I think we're continuing those conversations.
Okay, I mean, we haven't been able, at least since I've been in the council, to break this pattern, so I'm hoping that you, with all of your different expertise and background, can help to break through here, because it's difficult. And I worked at Woodhull, where they had a large number of maternal deaths, so it's an issue. So whatever we can do to be helpful, and I don't know, I don't know the, I don't have the resolution, but, so.
Yeah.
And,
well, we're committed to making an impact on this issue, and we're committed to working
and I don't,
with
some of it is the training of the docs, some of it is, it's all different ways that and the way that we interact with patients, the way docs interact with patients, and, it's all different kinds of things, but hopefully you'll be able to break through that. I have confidence in you.
Thanks, Chair Schulman.
Following changes to, one second, Sean, do you want to ask, because I have a number of questions. Do you want to? All right, so I'm gonna break for a second. I'm gonna ask Majority Leader Abreu to ask his questions, and then we'll come back.
Great.
Thank you, Chair, and congratulations, Commissioner, to
Thank
your
you, Majority
appointment. I'm confident you're going to do a great job for New York City. I have a set of questions on the sleep apnea pilot program that we passed last year. In April 2025, the Council passed Local Law 52, requiring DOHMH to establish a sleep apnea pilot program and public education outreach campaign. The local law established a 3-year pilot program to provide access to sleep apnea screenings at no cost, as well as access to home sleep apnea tests. This law required DOHMH to conduct a public education and outreach campaign on sleep apnea. For me, this is a very important personal bill. I suffer from sleep apnea. I know a lot of New Yorkers who suffer from it. DOHMH communicated to the Council that the pilot program started on October 13 of last year. However, we have been told as recently as December 12 that the public education and outreach component was still in development, quote unquote. This morning, I visited the Sleep Disorder Lab's webpage on DOHMH's website, which provides information on sleep apnea. However, there was no mention of the free sleep apnea screening pilot program. How are New Yorkers supposed to access a free program that has received zero public outreach?
Yeah, thank you for your leadership on this issue, Majority Leader. We are working closely with H&H to get information on this program, and we hope to be able to provide specifics after we convene with them and get back to you with how things are going with the program.
How fast what's the turnaround you're thinking here? Because obviously we're already beyond the deadline when this public outreach was supposed to begin. And can you speak to the mediums of public communication that your agency is looking into?
Yeah, thank you very much. We hope to have this posted in the next few weeks, and we're looking at every single option that we can to get outreach out to community members. We take this issue very seriously, and I think that there's a lot that we can do to join you and your leadership in moving this issue forward and making sure that we work with community members on this.
Thank you. And just lastly, the law requires DOHMH to conduct an outreach campaign through social media, the internet, digital kiosks, and other appropriate mediums in citywide designated languages. DOHMH is required to inform the public on health risks associated with sleep apnea, common signs and symptoms of sleep apnea, and how to access health care for sleep apnea, including the screening pilot program. It would be great for, all of these criterias within the law to be satisfied, and not just one of these requirements. And so I hope that when you look into, posting this and conducting this campaign, we're able to do the wide array of mediums that are available to you, including getting the mayor to do a social media. He has a big following. It would be great to see some kind of work there.
Thank you very much, Majority Leader. We are committed to making sure that this information gets out to individuals who have sleep apnea, and we're looking at all the options. We're looking forward to working with you on this issue to identify what the best media are for getting that out.
Thank you so much, Mr. Commissioner, and congratulations again. I'm sure you're going to do a fantastic job. Thank you, Chair.
Thank you.
You're welcome, and I want to echo Councilmember Abreu's questions and say if you can get back to us with a specific timeline of when this will be implemented, that would be, I was a co-sponsor of the legislation. It's very important particularly for people who are affected, and there's so much that's been coming out since the legislation was passed about this issue and the interventions that are available and all of that. So just come back to us with a specific timeline that, so we can know.
You got it.
Thank you. Okay, Healthy NYC, I'm gonna ask like a few more questions. So Healthy NYC, it's a 5-year health agenda aimed at increasing life expectancy, 83 years, which we've met, but there are inequities still around that.
Yep.
What is Healthy NYC's current operating budget, and how are funds allocated across the 7 priority areas?
Yeah, thank you, first of all, for your leadership on this issue on Healthy NYC, and we are, elated that we have reached the goal of 83.2 years, of 83 years, and passing it by hitting 83.2 years. We also know the work is not done. And so we remain committed to making an impact, not just on this life expectancy goal, but also to continue to push forward on our work on each of these 7 key drivers. So the dedicated budget is $1.7 million, which supports staff. It also supports the Institute for Healthcare Improvement, who we have on contract, really helping to move the work that we're doing on each of these key drivers, on many of these key drivers, even more deeply into the work that we do. But I will say that this is really an all-of-agency approach. This is not just the people who report to me in my office. Every single staff member in our agency is working towards, in some way, hitting one of these drivers. And so we're all rowing in the same direction. Let me hand it over to Aaron to see if there's anything else to add on this.
Yeah, not much to add, just to say that, arguably our whole budget could be considered, an effort to advance the goals of Healthy NYC.
No, because I think that there are ways that I want to see. Do you believe that we can meet all the indicators by 2030, the 2030 targets?
Yeah, thank you for that. We are continuing to drive meaningful progress on each of these 7 drivers. And, these drivers are not going to change, Chair Schulman, in terms of we're not moving the goalpost. And so we are committed to continuing to try and hit each one of those. We've had a considerable amount of success on a couple of these, as you know, with COVID deaths being down about 93%, overdose deaths down about 28%. But there's so much more work to do on the other drivers. And so I'm committed to mobilizing our agency to go after them.
And I would encourage, you and I have spoken about this, of getting your champion partners behind this as well, because they have a stake in it, because it affects their entities as well. So, and then we can talk offline about some other ideas around that too. So.
That's great.
The PMMR reports that 832 patients were diagnosed with tuberculosis in calendar year 2024, a 23% increase from 679 cases in 2023. The report notes that staffing shortages and limited funding have affected the department's ability to carry out key tuberculosis control activities, including contact investigations and case management. The city's TB response also relies heavily on federal funding, which you had mentioned earlier, which may be subject to reductions. So what factors are driving the increase in tuberculosis cases? And my second question to that is there any correlation with an increase in homelessness?
Yeah, thank you for that. First of all, to say, we have one of the strongest TB programs in the country. And we know that TB is preventable, it's a treatable disease.
Right.
There are a number of factors, Chair. We can start locally, with the federal government's posture towards immigration activities and the chilling effect that that's causing here locally, individuals not going to get care, not coming into our clinics, not going to health and hospitals, not going to the other hospitals and health centers throughout the city. We can also think about it, nationally. We're living in an era where the federal government is strangling people's access to health coverage, and so people are uninsured, underinsured at higher rates. And then we can think about it globally as well. We think about the federal government's defunding of USAID. And so, and that's one of the defensive tools that we use to internationally and globally, provide the treatment that stems tuberculosis cases. We know that 90% of the people who we have seen as newly diagnosed with TB are non-U.S. born.
Okay.
And so, yeah, there's a number of different factors that we think are contributing.
What strategies are we implementing to prevent further increases in TB cases, particularly in high-risk communities?
Yeah, thank you. I'm going to go ahead and ask Dr. Bronstein to come up, but as she's doing so, we have recently received new support with regard to staffing to be able to do the work of prevention, do the work of treatment. But let me hand it over to Dr. Bronstein.
Thank you, Commissioner. And we, as you've cited, we've been very concerned about recent trends in tuberculosis numbers, just incredible upticks. I will share, though, our 2025 TB report, annual TB report that's coming out in a few days, is actually going to cite an 11% decrease in TB cases last year, which is really incredible news. And we are very hopeful that this decline will be sustained, but absolutely, though, remain vigilant and concerned to make sure that it continues beyond just 2025. Yeah, as the Commissioner cited, there are really a combination of factors that have led to what we've seen recently in terms of trends. And I just want to speak to the point about homelessness. That has long been a factor, of course, in the
But there's been a substantial increase in homelessness.
Absolutely.
Therefore.
But I will just cite that, as you might be aware, since 2022, the Health Department has collaborated with various city and state agencies to really enhance TB screening and services in shelters, in the HERCs, and other temporary housing sites. And these numbers are pretty incredible in terms of the reach we've been able to make. So between 2022 and 2025, over 30,000 individuals received on-site TB-related services through this initiative, including things like TB testing, chest X-ray services, directly observed therapy. So really, really impactful. And I will also note that you'll see in our upcoming report that the number of people with TB who experience homelessness fell by 56% in 2025 compared to 2024. So hopeful that we're really making a dent here due to our really incredible TB program, but certainly something we'll remain vigilant around.
Thank you.
And Chair, I mentioned the new staff that we got. I want to hand it over to Aaron to unpack that a little bit.
Yeah, just to add, I mean, you mentioned federal dollars always being at risk, including in this area. I mean, one of the optimistic things that happened recently is that last year we got new funding for 79 new staff and over $7 million. And so that brings our total TB budget to just over $20 million and like 250 heads. So, I mean, I think while federal funding is always, a concern, the fact that the city's made this historic investment really decreases our reliance on federal funding and paves the path towards stability. So
now I'm going to ask my last questions. On December, this has to do with the health care price comparison tool. On December 23rd, 2025, DOHMH launched New York City's health care price comparison tool, which allows individuals to search and compare prices for 33 common health care services across the city, regardless of whether they have health insurance. The tool was developed pursuant to the Health Care Accountability and Consumer Protection Act, Local Law 78, legislation introduced by Speaker Menon, and is intended to increase transparency around health care costs and help New Yorkers make more informed decisions about where to seek care. Since the launch of the healthcare price comparison tool in December 2025, how many users have accessed the platform, and what trends has the department observed in how residents are using the tool?
Thank you for that question, and thank you to Speaker Menon for her leadership and advocacy on this issue. You know, we think that you can't have a conversation about affordability without having a conversation about accountable pricing, and
Right.
just the lack of transparency that New Yorkers are suffering when it comes to deciding where to get their health care. With regard to the price comparison tool, we are tracking usage and working to expand the number of services and making sure that we increase public awareness. We can get back to you with regard to the specifics and the metrics
Okay.
and follow up with you on what the use has been.
No, that's fine, and, you know, I see that your social media has really done an uptick since you've joined us, but if we can do some, if we could do some around that, because it's important. How does the department, and it goes to the mayor's also agenda as well, so we have a mutual agenda there. How does the department collect and verify the pricing data included in the tool to ensure the information is accurate and regularly updated?
Yeah, so we have pricing that is sourced through our partner at Turquoise Health.
Okay.
And so they're aggregating price transparency data, and we're awaiting updated contractor reports on this, including pricing data and city claims as well. And so we're working with our partners at Turquoise, as well as OLR and Milliman for that.
Yeah, okay. And we talked about this already, so we want to expand, when you come back with the metrics, we really want to expand that out. So once we have that, then we should come up with a plan of how we're going to expand that out so that people are using it, because I don't think a lot of people know about it. I mean, we know about it because it was passed by the council, but.
Exactly.
Give me one second. I'm now going to hand it over to my colleague, Councilmember Caban. She has some questions.
Thank you. Good to see you. Congrats. Really excited to be working together. I'm going to ask you a few questions specifically on early intervention. Early intervention offers special needs educational services for children with developmental delays, and the preliminary plan includes $367 million in FY27. And that's a 34% increase from the $277 million in the adopted plan from FY26. So can you just start by talking us through the services that are provided for early intervention, specifically the healthcare services provided for early intervention?
Yeah, thank you. And I'm going to start us off and then ask Deputy Commissioner Lydia Ledniak to share more. But this program is a marvel. It's a program that's incredibly effective. We, in a recent Journal of the American Medical Association study, found that for children who are receiving these services, they have higher test scores in reading and in math by third grade. And so we have a number of different intervention points and services that we use to carry out this program, and I'm going to hand it over to Deputy Commissioner Ledniak to share more.
Yeah, and in talking about those different intervention points, I think we're also specifically interested in sort of, you know, like, what is uniquely DOHMH's role in that intervention as opposed, you know, as it differs to ACS, DOE.
If you could please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to council member questions?
Yes.
You may proceed.
Okay, thank you for your question. So early intervention services and the program is a federal entitlement program for children birth to 3 with developmental delays and disabilities. So early intervention services are provided without regard to race, ethnicity, income, or immigration status. Early intervention services broadly are available to eligible children. And the most typical services delivered by early intervention are service coordination, which is case management, evaluation, physical therapy, occupational therapy, speech-language pathology. Those are sort of the most common services. We serve 30,000 children a year. Early intervention as a program is fully administered and coordinated by the New York City Health Department. It is a separate program from any service that is offered by the New York City Public Schools or ACS. But New York City Public Schools and ACS are important referral partners to the early intervention program.
Also, I guess in terms of the referral relationship, what happens with kind of the cross records? How are they sort of negotiated, or like how is the information taken together and then sort of a plan made?
I'm going to pass it over to Deputy Commissioner Lydia Ledniak on that.
Sure. So thank you for your question. Early intervention is a completely confidential program. So we will only share information with a system like the New York City Public Schools when we have a written parental consent.
So like a HIPAA release?
Kind of like that. We are bound by both HIPAA and FERPA, so
Okay.
which makes us unique in that way for early intervention. But when we do have consent to share information, we will share information with New York City Public Schools, particularly when a child is preparing to leave early intervention, right around the time that they turn 3 and are beginning to enter, New York City Public School services, particularly the committees on preschool special education.
Okay, so you're working with a family and a child. You do a screening, and you're in the process of doing this referral to the appropriate care workers, right, to support the child. Can you just break down sort of the steps for children that have been identified to have disabilities, and also how long that process takes? And then from there, do y'all have enough staff to do that, or like, do you need more?
Thank you for your question, and also thank you for your interest in early intervention. So when a child is identified as having, say, a concern about their development, and again, early intervention is a type of system where there's no wrong door, meaning that anybody can make a referral to EI when there's a concern about a child's development. So once a concern is identified, they're referred to us at the New York City Health Department. We will take the referral and assign a case manager. Every family that is referred to early intervention gets assigned a service coordinator, which makes it very unique.
What's the ratio, by the way? What is the caseload for a case manager?
There is no established state requirement for a ratio for a case manager, but it's about 65 children to a case manager. We have in early intervention, and I have this number, we have over 1,200 service coordinators. They are not all employed by the New York City Health Department. They are all early intervention services are delivered by a network of over 168 service provider agencies.
Would you be able to testify anything about sort of what best practice might be in terms of caseloads? And I don't know what that is. Nurses will know what safe staffing is. I was a defender, and I was like, holy shit, my caseload of 100 is way too many. So I just am curious of understanding, we're always asked to do a lot with a little. The need always outpaces sort of what we have. But can you tell me kind of what would be best practice in terms of a ratio?
I think that, let us come back to you with that figure.
Okay, thanks. Sorry I interrupted you and
It's okay.
finish. Yeah.
Do you have?
So I just wanted to sort of finish
Yeah,
process
please,
for
yeah.
you, right? So once a child is identified, we assign a service coordinator. Then that service coordinator helps the child receive an evaluation to determine whether the child is eligible for services, meaning whether there is a developmental delay or a disability. If a child is eligible, and around 68% of children are eligible who are referred, right? We have an individualized service planning meeting where we authorize a plan of care in partnership with the evaluator, the case manager, and the family. So that's sort of the whole process. And that process, ideally, between from referral to the time that we have a plan, is approximately 45 days.
So you said ideally, but how long is it typically taking?
So I have that number. Go ahead.
Chair, while Deputy Commissioner Ledniak is finding that, I want to turn it over to Aaron to share a little bit more about the staffing that we have, because part of your question is, are we staffed up to do this work, right? So let me hand it over.
Yeah, I mean, from a funding perspective, I would say one of the most important things that's happened in a number of years happened in the prelim budget, and that is that this administration addressed a long-standing fiscal cliff for the early intervention program. So we now have baseline funding of $79 million this year, growing to $144 million 5 years from now, for the first time in a number of years, which is a huge, huge win. So that in itself stabilizes the city's commitment to this program.
And for that increase that we're seeing in the FY27 budget, I mean, in terms of staff lines, for example, what do you anticipate that it might be possible in terms of growth?
I mean, the funding that was added here was really to just a recognition of the true costs of the program that had been sort of under budgeted for.
Yeah, that happens way
Right.
too often. Okay, got it.
I'll turn it back over.
Sure. So 81% of initial IFSP meetings are held within 45 days of referral.
Sorry, what was the percentage?
81%.
Okay, thank you. Yeah, you don't want me to ask this? You're good? Okay. All right, I'll hand it back to the chair.
So I'm going to ask a few more questions. Some of the questions are from a colleague and member of the committee who is not here, but because she's virtual, but because we don't have quorum, I have to ask them on her behalf. So this is from Councilmember Narcisse. We've seen spikes in measles and other preventable diseases nationally. What is New York City's current risk level and our vaccination rates where they need to be?
Thank you for that question, Chair, and thank you, Councilmember Narcisse. We think it's incredibly important that our city's children have access to effective vaccines, and through the Vaccine for Children's program, we are currently able to work with over 1,200 providers. We're vaccinating 2.5 million children every single year. We do this work every single day to make sure that we are keeping our children safe. With regard to measles, there is, at this moment, no heightened cause for alarm. We are aware that because of the federal policy shifts around vaccinations and some of the messaging that's coming out from the federal government, we are aware that families are getting different pieces of information, and it is causing confusion, sowing doubt, eroding
Right.
public trust. And so last week we launched a brand new campaign, paid media campaign, aimed directly at this issue with regard to childhood vaccinations. And the goal of that campaign is to really get families to talk to the most trusted messengers in their lives, and these are the pediatricians.
Right.
And so that's some of the work that we're doing in as it relates to the measles work.
Okay, and how are we measuring whether interventions are actually lowering rates of diabetes, hypertension, and heart disease?
Thank you very much. I'm going to ask Dr. Zahira Knat to join me. This is part of our routine work that we are focused on through delivering through the Healthy NYC framework. As you know, cardiometabolic risk factors is a driver that we're continuing to address. We have a number of different interventions that we are focused on. I'm going to hand it over to Dr. McNatt to share more.
If you please raise your right hand. Do you swear to tell the truth, the whole truth, and nothing but the truth before this committee and to respond honestly to council member questions? Yes. You may proceed.
Thank you so much for the question. Appreciate the opportunity to highlight some of the work around diabetes prevention and self-management in the city. The diabetes prevention efforts are very focused on food and physical activity across the 5 boroughs. And so we do a great deal of work around food security and food affordability. Namely, we have 3 citywide programs in this regard that help to work on food affordability and food security as a method of prevention in diabetes and other chronic diseases. Those include Get the Good Stuff, Groceries to Go, and Health Bucks, and would be happy to elaborate on them. We also focus on diabetes self-management. So once someone is diagnosed with diabetes or another chronic disease, we have numerous evidence-based programs that are aimed at supporting residents once they're diagnosed through that journey. Those programs are anywhere from 5 weeks to 6 weeks, and some are even 1 year long. And they offer robust services that help folks with behavior change. They also are support groups, so they spend a lot of time together with other people with the same diagnoses. And then also these workshops and classes are taught by community health workers or registered dietitians and other actors. And so it's also an opportunity to receive a great deal of education about how to speak to your healthcare provider and what types of questions might help you learn more about your disease state. This evidence-based intervention is actually taking place nationwide and has really great outcomes in relationship to diabetes self-management and the prevention of loss of eyesight, amputation, kidney disease, and other potential outcomes. So lots of work in prevention and self-management on diabetes.
Where are we with diabetes? Because I passed the Diabetes Reduction Act a couple of years ago, so what's the status of where we are, just in general?
Sure, thank you so much. So diabetes prevalence has increased over the past 10 years, as a result, we have a lot of efforts, including the Diabetes Reduction Plan. And as of 2023, diabetes remains a pressing public health challenge in New York City, affecting about 850,000 adults, which is about 1 in 8 in the adult population. And as you know, Chair Schulman, diabetes disproportionately impacts folks living in the lowest income environments and Black and Latinx communities. And so in part, that's why our prevention and self-management efforts are really focused on tree neighborhoods, but then very specifically on the South Bronx, East Harlem, and Central Brooklyn.
Are we seeing a lowering of the incidence at any point, or?
So we are, we are seeing some early signs that the work is impactful, but we are still, dealing with a major challenge.
Okay, we'll talk more about that.
Thank you so much.
Thank you very much. The CDC has faced challenges with employee turnover, including firings and reinstatements, particularly under the current administration. Have federally funded CDC positions been backfilled in the city?
Yeah, thank you for that question. We are certainly alarmed by what we're seeing at the CDC, not just with regard to the confusing public health messaging that we're hearing, but also the way that the conversation has really devolved and eroded public trust around public health. I'm going to hand it over to...
Yeah, I'm talking about the CDC positions at DOHMH.
Yeah, I'm going to hand it over to Aaron to talk about it.
Yeah, thank you, Chair Schulman. So we have 14 CDC staff that are assigned to the health department. Fortunately, none of them were RIF'd, the reduction in force, which is the term for the government, feds laying them off, and none of them are currently furloughed. So it's a good, stable right now.
Didn't we have somebody that was sent to Arizona? Wasn't that a CDC employee?
Our former Deputy Commissioner of Disease Control, Celia Quinn, is back from Arizona.
Oh,
we are
okay, great.
Happy to report.
Okay. Now my very last questions are about Legionnaire's disease. At the September 19th, 2025 oversight hearing on Legionnaire's disease, the administration testified that additional inspectors were needed to strengthen oversight and enforcement. Last year's Legionnaire's disease outbreaks highlighted the importance of inspection capacity, timely compliance, and strong enforcement of cooling tower regulations. The November plan included a baseline of $14 million in city funds and 93 new positions. The preliminary plan reflects $3.5 million in city and state funding in fiscal 2026 and $3.2 million in fiscal 2027 and the out years Legionella response efforts. Why was funding reduced by $250,000 in fiscal 2027 and the out years?
Thank you for that question, Chair Schulman. You know, first of all, we learned quite a bit from last summer's outbreak in 2025 in Harlem. And as you know, the Legionella sampling window has been shortened and reduced from 90 days to 30 days. We also have new staffing that we're going to be leveraging to really attack this issue head on and make sure that we keep New Yorkers safe. I'm going to hand it over to Aaron to talk a little bit about the budget pieces of the conversation.
Yeah, thanks, Chair Schulman. So yes, we're very excited to get this baseline new funding, very important. What you guys are seeing as the 3.5 and the 3.2 is just a technical adjustment that's about us drawing down state funds. So that's not actually a reduction.
Great. And how is the Legionnaire's disease funding allocated? What portion supports cooling tower inspections versus community outreach, disease surveillance, and laboratory testing?
Yeah, so there's the three buckets. So in disease control, so it's really surveillance and testing, we have $9 million and 50 headcount starting in FY27. In the environmental health world, which is the cooling tower inspections, we have $2.5 million and 28 staff in FY27, and Center for Health Equity and Community Wellness, which is really where the community outreach and education work lives. It's $1.1 million and 15 staff.
Very good. Why does the fiscal 2027 preliminary plan reflect no additional positions compared to the November plan?
Sorry, I'm not sure I follow the question.
I'm trying to ask you. Oh, let me ask the follow-up. Have all 93 positions been hired? What is the current headcount and vacancy rate?
We're working to hire up as quickly as possible. I can speak right now for the environmental health piece, at least, which is, 14 folks have been named of the 28.
Okay.
And we're in the process of ramping up across the board in all three areas.
All right, you'll keep us posted, because I passed legislation around that and making inspections more frequent and all of that. Yep. Does DOHMH have sufficient inspection capacity to oversee all registered cooling towers?
Thank you for that. I'm going to ask Deputy Commissioner Corinne Schiff to join us at the table.
Okay, so I'm going to ask, so that's one question. The next question, and then when I get through this, I'll be done and we'll go on to the next thing. What is the current inspected to cooling tower ratio?
Could please raise your right hand? Do you swear to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to council member questions?
Yes.
You may proceed.
Chair, as you know, the City Council has established really the most rigorous and protective laws for operators of cooling towers in the country and perhaps in the world. And in your legislation that was enacted this fall, you further strengthened those requirements so that cooling tower operators will need to conduct Legionella sampling not 90 days, but every 30 days. And we think that will go a long way to giving owners more information about what's happening in their cooling tower to be able to control that Legionella bacteria. The additional staffing that we got will enable us to conduct the annual inspection and any follow-up that's needed of every cooling tower in the city, which, as you know, has been our goal. So we're very pleased about that, and as you heard from Mr. Anderson, we are working very quickly to hire, and I've met many of our new staff. They're a great bunch, and so we've got a really good team.
And what is the current inspected to cooling tower ratio? Do you have that, or you?
So there are about 6,000 cooling towers in the city, and once we are fully staffed, we'll have about 56, I think the number is, scientists, water ecologists out inspecting, doing the work related to inspections. The question about ratio, I would say, I would think of it in a more nuanced way. Some of the buildings have multiple cooling towers.
Understood.
The compliance profile can be different. So really, we asked for what we needed to be able to do those annual inspections, and I'm very pleased that we got
Do
them.
you need additional resources to prevent future outbreaks, or you think you're good now, for the moment?
So the program is to promote compliance with the rigorous requirements that New York City has. And as we discussed in the fall, that is designed as a prevention measure. We can't commit that nothing bad will ever happen again.
Right,
We do a lot of education and a lot of outreach, and also these inspections that are designed as a prevention measure.
Okay, thank you. And Councilmember Caban has a follow-up to the 2K.
Yes, thank you. I know we talked about the early intervention, but I just wanted to ask about 2K inspections briefly. I know that the prelim shows 96 positions to be hired. I just want to know how many of those hires would be specifically for background checks and clearances?
Yeah, it's incredibly important that we get this right and that we don't have huge backlogs of folks who are waiting to get cleared. And so let me hand it over to Aaron to talk about the staffing piece.
Yeah, thanks, Chair Kaban. Just to clarify, I think there are two pieces related to this in the prelim budget. So one is actually fixing a prior cliff. There's this $5.4 million, and that's related to 3K. This 3K rollout that happened that was funded with temporary federal dollars some years ago. So that fixes that longstanding cliff, and that's around inspections and the regulatory side and the environmental health world for 3K. There's another piece that was added, which is great, for 2K, and that's really 10 headcount that grow to 23 headcount and a couple $1 million around the 2K rollout. So I'll defer to Deputy
So,
Commissioner.
and then also, what would the overall numbers be then for staff dedicated to those background checks?
So let me get back to you with exactly the numbers of staff we will add for background clearances, but I would just say that, as the city moves towards universal child care, I think the mayor has made it very clear that meeting health and safety standards is going to be a key part of that. And that is our role in that system, including to conduct those background clearances. So we were pleased to get those additional staff, even as this expansion is just starting to roll out.
Great, so it's, for 2K at least, it's 10 to 23, and then you'll follow up with any additional numbers.
And that includes, some piece of that is specifically for the background clearance work. Part of our health and safety work includes conducting those background clearances, doing those inspections,
Yeah,
doing
and that's
follow-up.
that is what I'm particularly interested in, is breaking that up and being like, okay, what's the number of staff that's dedicated to specifically the background checks, the staff background checks?
Got it.
Thank you.
We'll follow up.
Okay, so that is, that's the end of this portion of the hearing. We're going to take a 5-minute break, and then Chair Caban and I are going to trade, please. 10-minute break. Okay, she wants 10 minutes. That sounds good to me. 10-minute break. And then she and I are going to
Thank
trade
you, Chair.
places, and then we'll do the mental health and substance use part of the hearing. Thank you to everybody.
You all right? Oh, great. Yeah, seriously. Thank you.
3 weeks.
Before we end, I want to acknowledge we were joined by Councilmember Althea Stevens.
Do you need to restart anything, or am I good? Yeah? All right. Good afternoon, everyone. I'm Councilmember Tiffany Caban, Chair of the New York City Committee on Mental Health and Substance Use. Thank you for attending today's hearing on the city's fiscal 2027 preliminary budget for the mental hygiene portion of the Department of Health and Mental Hygiene, or DOHMH. I'd like to thank nobody. I'd like to thank the wonderful staff who are here. There we go. I would also like to thank Dr. Martin and his team for staying to testify today. They're going to be here. They're downstairs for that very exciting announcement that's taking place. In the fiscal 2027 prelim budget, DOHMH Mental Hygiene's proposed operating budget is $855.4 million, of which $60.8 million is spent on personal services, covering 591 budgeted positions. The budget also includes $794.6 million, and other than personnel services, most of which cover 388 mental hygiene contracts. The changes to the agency's mental hygiene budget in the prelim plan are mainly driven by about $82 million in additional baseline funding starting in fiscal year 2026 to support our supportive housing units. DOHMH's mental hygiene's OTPS budget of $794.6 million covers key mental health programs and services, including assertive community treatment, intensive mobile treatment, New York City 988, assisted outpatient treatment, justice-involved supportive housing, and many more, and I'm eager to discuss these programs and their budgets today. As I mentioned at our oversight hearing on March 4th, connecting New Yorkers to mental health services is not just a public safety issue, it is a matter of dignity. The city is in the midst of a mental health crisis, and we want to ensure that these programs are adequately funded to allow DOHMH to connect people dealing with mental health issues to the services they need. So before we begin, I'd like to thank the finance staff, Aman Mahadevan, gotta put respect on the name, Florentine Kabor, Aisha Wright for their work on this hearing, and the committee staff, Sarah Sucher and Justin Campos, for their support. I'd also like to thank my staff, the legislative director, Jonah Birch, and I'm going to turn it over to the committee counsel to administer the oath to the members of the administration.
Thank you. Will you please raise your right hand and respond verbally? Do you affirm to tell the truth, nothing but the truth, before these committees, and to respond honestly to council member questions?
I do.
Yes.
I do.
Thank you. You may begin your testimony when ready.
Good afternoon, Chair Caban. Good afternoon, staff and forthcoming members of the committee. I'm Dr. Alistair Martin, Commissioner of Health at the New York City Department of Health and Mental Hygiene. I'm joined today by our Chief Financial Officer, Aaron Anderson, Executive Deputy Commissioner, Dr. Jean Wright, Assistant Commissioner, Dr. Rebecca Lynn Walton, and Assistant Commissioner, Jamie Nichols. Thank you for the... It is. Thank you for the opportunity to testify today on our preliminary budget as it relates to mental health. This is my first time testifying before the Committee on Mental Health and Substance Use, and so I would like to briefly introduce myself. I found public health by working in the emergency department. It soon became clear to me that many of my patients were in the ER not because of an acute health emergency, but because every other system had failed them. The ER was the last place for them to turn. I learned how much upstream systems matter by watching them fail again and again. There's one particular story I'd like to share with you. On the 6th day of my emergency medicine training as an intern, a woman came into the ER at 2:30 a.m. She was wheeling a suitcase behind her. My patient sat before me with smudged mascara, shoulders curved inwards, and hands knotted in the sleeves of her sweatshirt. She told me her story. After surgery to fix a shattered ankle, she came home with a row of neat white pills. When her Oxy prescription ran out, she turned to her husband's old bottles in the bathroom cabinet. When that too ran dry, she found herself accepting pills through a half-opened car window behind a CVS. The night she came into the ER, she showed up because she wanted her life back. She asked me for help, and I naively thought that I could help her. But when I asked my attending, the supervising doctor, about next steps, he told me something simple: discharge her. There was nothing we could do to help, in his words. It was just not what we do here. I did what I was told. I sent her away. I would like to think she got the help she needed, but the truth is, I don't know what happened to that woman. What I knew was that I didn't want that to happen again, to her or to anyone else. Driven by that experience with my patient, I founded Get Waivered to help ER clinicians obtain the waivers they need to treat substance use disorder on the spot. That program grew into a national movement, helping thousands of providers re-envision the emergency department as the front door for addiction treatment. Above all else, this patient showed me that there are so many larger systems we need to invest in to change the circumstances that bring people to the ER in the first place. That is the kind of upstream work happening at the New York City Health Department each and every day. Our mental health programming spans substance use, serious mental illness, support for justice-involved populations, youth mental health, supportive housing, and so much more. All of it is making a meaningful difference in the lives of New Yorkers every day. What I share with you today are just a few of the highlights. One of our most encouraging metrics of success is that in 2024, overdose deaths in New York City fell by 28%. And that's the first decline that we've seen, significant decline that we've seen in nearly a decade. That did not happen by accident. It happened because sustained public health investments in programs that meet New Yorkers where they are worked, without judgment and with resources that save lives. It happened because of community health workers like Ava and Miriam on our response and engagement teams. They walk the streets every single day and engage with New Yorkers one-on-one. I was out with them near Penn Station a few weekends ago, and Ava told me the story of a shift that she worked last summer. She and Miriam were working in the South Bronx when she came upon an unconscious man surrounded by bystanders. She administered Narcan, and she revived this man. She called EMS, and he made it to the hospital. Were it not for Ava, that man would not be here today. And again, that 28% decline is not passive. It is the result of years of deliberate investment in naloxone distribution, in harm reduction, and in programs like Relay. Relay is our hospital-based, peer-led overdose prevention program. Peer wellness advocates are sent into emergency departments to meet patients who wake up from a non-fatal overdose. As these patients recover, they are met with compassion, with connection, with care. Relay reached nearly 1,600 patients in 2025 alone. 95% of them accepted services in the ER. Relay is a monumental success. We recently expanded to Wyckoff Heights Medical Center in Brooklyn, which is now the 16th hospital that is included in this program. Again, that 28% decline is not an accident and is not caused by any one program. It is only because of a broader network of harm reduction, resources, and community-based care. It is the result of the naloxone we helped to put in the hands of some 300,000 New Yorkers just last year. It is a result of the response and engagement team members like Ava and Miriam, who do the quiet, unsung work of representing this agency every single day, connecting New Yorkers to care and sometimes reviving them in the field. It is also the result of coordinated engagement with you all at City Council, with community organizations, and with peers all rowing in the same direction. What we are seeing is an impact not just in citywide data, but in alleviating the racial inequities too. For the first time since 2018, we saw overdose deaths decline among Black and Latino New Yorkers as well. That is what public health funding does. It saves lives. And the progress is continuing. Early 2025 data show the lowest quarterly death count since 2020. Of course, none of these challenges happen in a vacuum. For so many of our neighbors, medical issues are not the underlying drivers of their mental health struggles and substance use disorders. It's structural. Often what New Yorkers need most is solid ground to stand on. They need a safe place to come home to. Everything else can follow from there. The most tangible way we can provide that is through supportive housing. We remain committed to the goal of the 15 over 15 program to develop 15,000 units of supportive housing, which provide affordable, independent, and permanent homes to New Yorkers who are unhoused and either have or are at risk of a serious mental illness or a substance use disorder. This year, we surpassed 13,000 units in total of both the 1515 units and the state-city partnership program units. We are well on our way to meeting or exceeding our goal. Especially in one of the most expensive cities in the world, these units are a lifeline for thousands of our neighbors. We also continue to invest in our crisis hotline through 988. We provide confidential support services at all hours of the day and night, and 90% of these calls are answered within 30 seconds. And we offer services in English and Spanish with interpretation services available in over 200 languages. Our callers are trained to refer New Yorkers to the appropriate services and make sure that whatever their concerns are, they know they don't have to face them alone. We want every person in our city to know that help is available. So earlier this week, when we launched a social and digital 988 campaign in English, Spanish, and Chinese. That campaign is reaching New Yorkers right now and will continue through April. Now I'll turn to the funding that makes all this work possible. At the New York City Health Department, mental hygiene care is critical to our overarching vision to achieve longer, healthier lives for all New Yorkers. Our Division of Mental Hygiene leads that work and employs about 600 people with an operating budget of $850 million for fiscal year 2027 as of the prelim budget. We are grateful for that continued funding and are particularly encouraged to see a sustained city investment in our supportive housing portfolio and our outreach and syringe litter teams. At the state level, we're grateful for several investments in critical mental health programming, including $17.5 million to expand teen mental health first aid for all 10th graders statewide. Finally, at the federal level, we are watching the administration's actions very closely and have been gravely concerned to see national mental health infrastructure devalued over the last year. At the New York City Health Department, our federal funding is concentrated in our disease control and emergency preparedness divisions, and our Division of Mental Hygiene is not heavily reliant on federal funding. But every part of our agency is impacted by the rapidly changing public health landscape. Here in New York City, we will continue to meet the mental health challenges of New Yorkers with compassion rather than criminalization, and I'm proud to lead this agency in a way that puts that into practice every single day. I'm grateful for the support at the state and city levels that allow us to do this life-saving work. Thank you for your attention, and we're happy to take your questions.
Thank you. And we have also been joined by Councilmember Narcisse on Zoom. Just wanted to make sure that we knew.
Great. Thank you.
Okay. Great. I would love to start with the ACT and IMT teams and do just a line of questioning there. So we know the ACT team's a treatment program for folks with serious mental illness who have high service needs that are not being met in traditional settings. The ACT program provides essential team-based high-intensity treatment and wraparound support services for individuals with SMI challenges, substance use disorders, frequent contact with the criminal legal system, experience with homelessness, et cetera, et cetera. What are the current fiscal 2026 and fiscal 2027 projected budgets for ACT, and how much of the current funding is contracted out?
Yeah, thank you for that question, and thank you for your leadership on this issue, Chair Caban. We see the ACT program as a critical part of our spectrum of services that we can provide for folks who are dealing with mental health crises. And so this is an incredibly important tool in our toolkit, providing highly specialized long-term care for New Yorkers who are struggling with mental health issues. I'm going to hand it over to Aaron Anderson to talk a little bit about the budget to answer that question directly.
Sure. Thanks for the question, Chair.
Yeah, and if you could hit head count also when you talk about the budget too.
Sure.
Yeah.
So for ACT and FACT together, the FY26 budget for the current year is $27.8 million. and the FY27 budget is 23.3 million.
But is there a reason why you lump the amounts together for ACT and FACT? Can you separate it out?
Sure, I can get you the separate numbers for that. Yeah.
Okay.
But aside from that, so all of the teams are contracted out to
Okay.
mental health service providers, so there's no headcount, department headcount.
What I mean, even contracted headcount, I guess, is what I'm trying to say. Just because it helps us think about what the need is in relationship to the referral lists and all those kinds of things.
I'll just add here that an ACT team has a staffing pattern that's established by state licensure. So it's really, there's excruciating detail on the New York State Office of Mental Health website. The staffing pattern ranges from about 9 to 11 or 12 FTEs, with the FACT team having extra staffing to address the forensic issues.
And ACT teams in particular, they are operating in all 5 boroughs?
Yes.
Yeah.
Okay. What are the days and hours of operation for those teams?
Pass it to Mrs. Commissioner Jamie Nichols.
Yeah, so ACT teams are required to be available to their clients 24/7. Every client upon enrollment is given the emergency contact number, and there's always on-call and available. They're seeing clients typically, during regular hours, but are expected to be available during other hours as needed.
Got it. And can you just list the providers that are contracted with for ACT teams?
Sure, I think we provided that in writing. I don't have, I can pull it up. There's about 20 or so different provider organizations, so it's a long list of.
Great, thank you. And so that's been submitted. Thank you. How many people are currently on the referral list for ACT? And then from that list, how are they prioritized?
Can I ask a follow-up?
And I know we talked about this at the last hearing, that sometimes folks will qualify for ACT and IMT and, figuring out those things, but curious how they are prioritized.
Are you asking about the wait list or the referral list? Which?
The wait list.
The wait list.
Yeah.
Okay, great. Well, first of all, we know that having a wait list is not the ideal scenario for what we'd like to.
I know. I want you to have more money.
That's right. And ultimately, folks who are on the wait list have the ability to be engaged by a care coordinator while they're waiting, and so people have that right as soon as they jump on that wait list. There's a pretty large variation in terms of the numbers of the wait list. I'll hand it over to Assistant Commissioner Jamie Nichols to talk a little about each one of those programs.
Thank you. Wait lists it's an important issue, so I'm glad you're shining light on it. We've got 312 people on the waiting list and referral list. We use those terms interchangeably sometimes at this point in time. And as the Commissioner said, everybody is offered a care coordinator while waiting for a higher level of care. Some people are in other treatment programs while they're waiting to be stepped up to an ACT team.
Yeah, I mean, I'd be curious if there's a breakdown on sort of like who's engaged in programming while they're waiting, what kinds of services people are getting, how many of those folks on a wait list maybe aren't getting any services. And yeah, this is really important because in my mind, the way that I see it is if there's somebody on a wait list or referral list, their options then become an emergency room or Rikers Island. And I think that that's what's at stake. How long does an applicant wait in each stage of the process, from application to approval and then from approval to placement?
Hand it to Jamie to share more there.
Yeah, so applications to our single point of access are submitted by a treatment provider, typically, most commonly as a part of a hospital, discharge plan, also from community-based treatment providers on behalf of the person. The person themselves may not always fully realize that an application has been submitted on their behalf. Just want to point that out. And so they may or may not.
How do they find out? How do they find
care.
out when somebody else refers them? Is it just by the contact or?
So when we receive the application and find a person eligible, we'll connect them with an ACT team. And that ACT team goes out and finds the person. Okay. And sometimes that's how the individual finds out. And sometimes that's a surprise to them. The time at which they were referred, they may not have been, they may have been in a difficult position and not, paying attention or fully, absorbing or remembering everything that was going on. Totally understandable. So the ACT teams are it's a difficult position, right, to show up at somebody's door and to say, hi, I know a lot about you. I'd like to, help you. Sometimes that's troubling to anybody, right, to have somebody knock on your door. So it takes time for them to engage folks in care.
But could you give a timeline?
Timeline. So the referral. Sorry, that was your original question. The application
sorry.
comes in. Just I got lost in the human story. So the application comes in, gets reviewed within a couple of business days, depending on a number of factors, may influence the timeline to assignment to care. The first priority goes to people who are mandated to mental health treatment through assisted outpatient treatment. So we're required by New York State law to prioritize access for those folks, and so they may get connected to a treatment team within a few days. Other folks may wait longer. I think it's up to about 3 months is the average time from referral to enrollment in the program when that ACT team shows up at their door.
And so I understand you prioritize the mandated folks, but for that other grouping of people, what does the prioritization look like? Like, sort of, what are the things that you're looking for? I'm just going to throw out an example. Is it like, do you see if they live with family, or do you, what are the things that you look at to figure out prioritization?
Sure. So one of the things you mentioned earlier, you were wondering about, what's going on with those folks who are on the referral list. Are they in treatment? So if they're in treatment, and it's not optimal, but they're somewhat connected, we would see that as less prioritized than somebody who's not connected to any care without a mandate. So it'll be a factor like that, risk factors as well. If there's more frequent hospitalizations, if we see a risk of harmful behavior towards self or others, that could also elevate the clinician's decision.
Thank you. And ACT is eligible for Medicaid?
Yes.
Do you have any concerns on the outlook in terms of Medicaid reimbursement and are you concerned about that right now?
I can, yeah.
I just want it on the record. I mean, obviously it's an obvious answer, but we want it on the record.
Yeah, we are very concerned as an agency writ large. The federal administration's posture towards health coverage for individuals who have a history of being marginalized or disenfranchised is dangerous. It's unfounded, and it's something that we are fighting back on here in this agency, and it certainly relates to the work that we do in mental hygiene, but it's across the entire agency.
Totally. Can you talk briefly about specifically how ACT teams support the LGBTQIA+ community?
Yeah, I can start us off and then hand it over to Assistant Commissioner Nichols. Through the ACT teams, we provide individualized assessments and person-centered interventions for folks, and we really make sure that we meet the unique needs of each and every participant who comes onto our list, and that includes individuals in the LGBTQIA+ community. Let me hand it over to Assistant Commissioner Jamie Nichols to see if she has more to add.
No, I think that covered it well, right? The criteria are adults with serious mental illness, but all of us have sort of intersecting identities, and so certainly a person's sexual orientation or gender identity it may be one of those, and that needs to be supported by the team in their person-centered service planning.
And what I'll say is we are 100% open to partnership and taking advice and guidance, on this. So looking forward to continue those conversations.
Thank you. And I know that obviously the span of healthcare support and mental health care support for specifically queer, trans, and gender expansive communities it's a hard environment, especially with private hospitals deciding that they aren't going to deliver care. And so, yeah, I'm wondering what we've talked a lot about, is H&H prepared to take on more clients? But I also wonder if there's room for gaps to be filled in this way. So I'm just curious about that. But I'm going to move more directly to funding again. Really happy about the $4.5 million that was added to FY26, the adopted budget for the expansion of the ACT teams to kind of start clearing out some of that weight. How much funding needs to be added and baselined to expand ACT, specifically also to just to clear the wait list?
Yeah, let me start, and then I'd love to hand it to Erin.
And I really want a number.
Yeah. First of all, we share your commitment on trying to make sure that we lean in as much as possible for this program. It's a program that works. It's a program that is effective and meets people where they are, literally. And so we want to do everything we can to try and bring as many resources in to expand the program. let me hand it to Aaron to share more.
Thanks, Commissioner, and thanks, Chair Caban. And first, just to state on the record, the breakdown from earlier for ACT and FACT. So FACT is $4 million per year.
Okay.
His budget, and ACT, the current budget is $23.8 million.
Okay,
For the
thank
two
you.
act- Yeah. Yeah, so for the $4.5 million, no, thank you for the advocacy. I don't know that there's a specific number in terms of the baselining conversation, but I can say that we continue to work with the council finance team, with OMB, and
Yeah.
with City Hall on the best way to expand these services.
Yeah, I mean, we're eager to hear what you need so that we can like champion that cry. Like it is really, really important, effective work, and y'all are doing an incredible job with it. According to the PMMR, the number of individuals who receive services from long-term mobile community-based treatment providers increased quite a bit, right? From close to 5,300 in the first 4 months of fiscal 2025 to approximately 5,500 in the first 4-month fiscal of 2026. So just curious what you think are the factors that are contributing to the increased number.
Can I ask, just to follow up, are you referring to AOT, assisted outpatient treatment, or which program in particular?
I think we can, well, can you break it down?
Yeah.
Yeah.
I'm going to hand it to
Sure.
Jamie Nichols to share more on that.
Yeah, I think what you're referencing are the folks who are enrolled in ACT and FACT and IMT teams, the mobile treatment services accessible through our single point of access. I'm glad to see it's increased. The cause of that is the expanded capacity. So New York State Office of Mental Health awarded a number of new treatment teams that flow through our single point of access, including Flex Act, which is a step-down model for ACT to expand those caseloads. So there's 4 of those new teams in New York City. That funding flows through us, and the access comes through our single point of access. Additionally, New York State Office of Mental Health established a new Forensic ACT team. It's operating in Brooklyn, and those spots come through us, and we're able to make all those people coming in, we're able to connect more people to care with those new resources.
Well, thank you. I'm going to move specifically to the IMT teams. And I said this again at the last hearing, that especially appreciative of them because of the flexibility. I mean, given that obviously that they aren't relying on the Medicaid funding, it allows the teams to just be more nimble and really meet people's needs. Can you tell me the projected budgets for the current budget, FY26, projected for FY27, just for IMT, and then the head count associated with it?
Yeah.
Including contracted positions.
Yeah, I completely agree with where you land on this as well. This is a hugely important tool that we have in our toolkit to provide an extra level of support for individuals who are dealing with serious behavioral health concerns in complex life situations. And so in FY26, the budget's $53 million, and in FY27, it's $12 million. Let me hand it over to Aaron to share more about the headcount.
Actually, if we're talking about contracted headcount, I think I'll hand it over to Commissioner Nichols. All of this is contracted out.
Got it.
Surprise me there. There we go, it is 8.5 FTEs per IMT team. So that works out to a 3-to-1 client to staff ratio.
Okay. But what's the total number? Sorry.
8.5 times 36.
Okay.
Whoever
You
can
got the
do that
calculator? Whatever that number is. Yeah. I went to law school, math school. IMT's operating in all 5 boroughs.
Yes.
And those teams are 10 to 8, right? Is that correct? The hours of operation?
No, their hours are flexible. So
Okay.
they are responsive. We require them to be available to their clients 24 hours a day. All staff, not just, that includes the psychiatrist. They don't get to sleep at night.
Yep.
And their hours, their business hours are flexible. We require them to offer services and to be proactive in their outreach in non-traditional hours.
And you sent us the list of those providers
Yes.
also?
Yep.
Great. How many people are currently on the wait list for IMT?
Thank you for that question, Chair. So what we have on the wait list as of the end of February 27, so February 2027, is 575 individuals who are on the wait list.
Okay. What do you need? How much money do you need? I mean, again, you had the one-time $11 million that was added. to expand IMT. So same question is like, what additional resources are needed to expand this program?
First of all, thank you for asking the question. Thank you for your advocacy and helping us to make sure that we can provide this service. As you know, this service, unlike some of our other programs, is not billable by Medicaid, and so we're constantly looking for alternative ways to fund this very important work. I'll hand it over to Aaron to talk a little bit more about the funding piece.
Yeah, thanks. I mean, I think the conversation on this is similar to the conversation around ACT and the money that was added last adopt. So, I mean, those conversations are continuing with the council finance team and our partners in City Hall.
Great. My last question on the IMT teams is, and I am going to ask it with a caveat. Again, I mentioned this at the last hearing, but what steps has DOHMH taken to address the issues with IMT identified in former Comptroller Lander's 2024 audit of the program, with the caveat that actually I do not agree with all of the criticisms, because I think that when you have something that is driven by so much need, doesn't have these different requirements in terms of Medicaid reimbursement, those are things maybe that can't be quantified as easily when you're putting out those reports. So like, with that said, were there issues in there that you said, well, these are valid, they're concerns, we should build on them, and what are those?
Yeah, we agree with your position on this, and look, we welcome oversight, we welcome accountability, we welcome opportunities to continue to improve our process, and we are taking those steps to make sure we're not just shirking off the recommendations and the pieces that were useful for us. And so we're continuing to move forward with the process improvements to the IMT.
Could you name what some of those are? Were there particular recommendations that you've taken under advisement and plan on doing some work on?
Yep. So let me hand it over to Assistant Commissioner Jamie Nichols on that.
Sure. The Comptroller's audit and the auditors really focused on client contact with the psychiatrist or the prescriber, nurse practitioners sometimes as well, and the client's adherence to prescribed medications, rather than the sort of full breadth of their contact with the multidisciplinary team. Of course, contact with the prescribers is important, but there's a lot more to the IMT treatment than that. And so time spent searching for clients, engaging collateral contacts, indirect communications, all these variations in the intensity and duration of the service, and sometimes periods of not finding the person but keeping at it. All that demonstration of commitment and persistence is a part of the treatment, right? That shows that the team cares and builds trust for folks who have been really traumatized. And so I don't think that was really appreciated by the auditors, who were doing their best. And I think they made some really important points about the data collection and reporting out. So we've refined that process, right? The program has grown and matured substantially since that audit. We looked at a period of time during the pandemic. Right now we're well beyond that. And so we have three main performance measures that we're looking at for IMT, including retention in care, right? These are folks who have been really poorly engaged by everything else, housing stability, and reduction in jail time. And so we're seeing and tracking that, reporting out on it, seeing good outcomes, sharing that with the providers, and that's a big lesson learned from that audit.
Well, thank you, I appreciate that. I'm going to move over to co-response, non-co-response teams, but I want to take a second to sort of clarify what we're talking about, because I think a lot of people conflate the two. A non-co-response team does not mean that the NYPD is not a part of or involved in the response. It just means that they are not the first point of contact with another person as part of that initial team. I think it's important because I know you guys know the difference, but I think generally there's a lot of the public that sometimes will conflate them. Can you talk a little bit about what DOHMH's current FY26 and projected FY27 budgets are for co-response teams?
Yeah. Let me start with just a couple of words at the top on this. We think that co-response teams absolutely have a role to play. They're another tool in our toolkit. They're not the tool for all situations, but they're certainly a part of the puzzle. In terms of our FY20.
That's probably where we disagree, but that's okay.
Okay, all right. Well, hey, look, we welcome the conversation, and the continued, collaboration to figure this out together. Our FY26 budget is $3.1 million, and FY27 budget is 3.2.
Right. And do you have data on co-response versus non-co-response teams involved in mental health crisis calls in New York?
Yeah, so we do track data across things like demographics, referral sources, services provided. We are going to have to follow up with you to get you the exact information with regard to co-response versus not. But let me hand it over to Dr. Wright to see if he has.
Yeah, I mean, I would love it, like at the very least, a listing of what the data that's kept and what kinds of comparisons that are made, especially since I think we sent them yesterday, so I give you a little bit of grace there, but we did send it ahead.
Yeah, thank you for your question, Chair, and thank you, Commissioner. In terms of the comparison, we'll have to get back to you on that, but since 2025, the CRT served about 500 individuals, and as the Commissioner stated before, as one tool in our toolkit, I think it's important to really focus on the partnership between police officers and the mental health professionals in terms of what they do and how they go together. They do trainings together. They don't just do CIT trainings together, but they also do de-escalation trainings and all those things. And so getting you the number in terms of the comparison would be great, but I think it's important to really understand the sensitivity and thoughtfulness that goes into those partnerships, and the fact that, even when they do a referral or something like that, they follow individuals from 45 to 60 days afterwards just to make sure that they get connected to their first appointment, that they're able to really follow through on the recommended treatment. So I think that's important to add in to that partnership.
Thank you. I mean, I'd love to keep talking about it. I know, I mean, Be Heard would be a discrete example, and while it's a program that I love, we're seeing that police are being called in to respond at far, far higher rates than in other cities around the country, and that is not because people that have SMIs or experience acute crises are fundamentally different in New York City than they are elsewhere. And I think that there's a lot of broad overall data around sort of the efficacy of non-co-response versus co-response, and so like I'm eager to have that conversation more in the future. Can you talk to me a little bit about the intake process for individuals that are contacted by a co-response team? You started with a little bit of that detail, but if you could dive a little deeper into that, that would be great. Because you said that there was my understanding there was like a new intake process in May 2025, and then onboarding of new staff in July of 2025.
That's exactly right. There have been some improvements to the process, mostly with regard to streamlining the intake process. And so in the past, we had intake staff that were essentially not located within the CRT teams. And so what we do now is we do have an embedded model where the intake staff are with the co-response teams. And so I think that part of what we're seeing in terms of the intake numbers and individuals contacted is partly us streamlining the approach.
Great, thank you. We have been joined by Councilmember Hanif and again by Councilmembers Nurse and Stevens. Do any of y'all have questions? Yeah? What's that? Okay, Councilmember Nurse. Wait, are you ready? I won't have to. Okay.
Sorry, my station over here is chaotic. We were not ready. I just had some questions around clubhouses and syringe programs, and maybe the mental health continuum as well. One of the things that we've been really fighting for as a council is to get all of the smaller clubhouses that were operational in a lot of neighborhoods to be, continue to have operational funding from the city and support for serving those communities. In 2023, you all did the RFP for $30 million, and 7 smaller clubhouses lost funding. In June 2024, the council began funding 5 of those clubhouses under our own initiative. What's the plan this year for funding these clubhouses?
Yeah. Let me say a few words about the program overall and then hand it over to Assistant Commissioner Jamie Nichols. So yeah, we think that this is an incredibly important tool that we have for individuals to get the care that they need in settings that are not the traditional hospitalized, more sterile environments. And so this offers us an opportunity to help individuals in a different way. And so let me hand it over to Assistant Commissioner Jamie Nichols to talk a little bit more about it.
Yeah, I appreciate your interest in clubhouses. They're an essential part of our public health approach to supporting people with serious mental illness, right? We need treatment, we need housing, we need a community, a place to belong, and support one another and participate in meaningful activities, right? For your own health and wellness, part of your recovery. We reprocured them, as you know, a couple years ago. At this point, we don't have another reprocurement planned, so we're a few years into that contract, and the programs are, expanding with new membership every day. And we're sticking with the procurement that we launched 2 years ago.
And are you all in touch with some of the smaller ones that lost funding?
Sure. So I think that those
I think
city
it was
council
7,
contracts
unless
go through us, yeah.
unless I'm wrong. It was 7 that lost.
I think it's
5?
5.
Okay, 5. Are you all in touch with them? Do you stay in contact with them?
Sure. So the city council funding flows through our agency, so we have some modest amount of contact with them in that capacity.
Okay. I mean, I have a small one on Halsey and Broadway. I visit every year. I can't remember if they got included or not. Feel free to correct me if I'm wrong. But, we're aware of what the programs do. That's why we picked up the tab in the past, and we want to continue to see even the smaller ones receive some level of support. These places are also an opportunity for families to have support as well, and a place for folks to go and have things to do, and also to allow families to take a break for a little bit. And so I don't know. I really hope that we can come to a better solution for how to pick up these small ones. And then I'm going to move on to the syringe redemption pilot. Local Law 124 of 2022, which was sponsored by our former Deputy Speaker, Diana Ayala, involves the collection of syringes. The program offers participants up to $10 a day to collect used syringes to help keep their neighborhoods clean. There are 8 sites across Brooklyn, Bronx, Manhattan, and Queens. There was $3 million added at fiscal year 26 adoption to support this. This was in one of our priorities last year. It was also a huge priority for the Progressive Caucus. Does this $3 million represent the total budget for the program? And if not, what is the budget moving forward?
Yeah, let me say a few words. This is absolutely has been a successful pilot. Over 1 million syringes have been redeemed. As you know, the funding that individuals can get, typically goes towards them taking care of themselves and buying things like food. This also offers an opportunity for individuals to be engaged in a harm reduction way. And so this program wins on a number of different dimensions. I'm going to hand it over to Aaron to share a little bit more around the budget.
Yeah, thank you so much, Councilmember. So the current budget is $3 million. That's the total budget for the program. There is not a budget at this time in FY27, but we're in constant conversation with our partners at OMB about our needs.
Yeah, I mean, if this is a successful pilot, I think we should put money in there to continue it going. I'd love to hear more in the follow-up if we could get more information. How many? You said $10 million has been
1 million syringes.
1 million syringes. I mean, that's something we should be communicating to New Yorkers, right? Especially in neighborhoods where there's a lot of complaints about syringe garbage and things like that. We should be doubling down on things where we have high success rates. So it would be great to, find out how many does that 1 million syringes represent? Is it 100 individuals? Like, how many people are utilizing this program and coming back? And let's put some money in it for this year. If it's successful, let's not break it if it's working. Thank you, Chair.
Yeah, I just want to double down on that. I think especially since it's such a material thing that people feel
and see when they walk in their neighborhoods. Before passing it to Councilmember Hanif, I just wanted to relay a comment by Councilmember Berina Sanchez, who is with us on Zoom. She's worried about the lack of new lines at DOHMH to process new street vending licenses. She wanted me to.
Is that
Share
like
ahead.
mobile vending? Is that right? Like
Yes.
Food mobile vending?
Yeah.
Thank you for that question. We are certainly aware of the increased, engagement that we're going to need to be doing with regard to licensing and inspecting pursuant to local law, which was passed recently. And we are working with our colleagues at OMB to make sure that we have everything that we need to be able to staff that team up and make sure that we are ready to provide that service.
Great, thank you. I'm going to pass it over to Councilmember Hanif.
Thank you, Chair, and hi, good afternoon, and welcome, Commissioner Dr. Martin.
Thank you, Chair.
I would like to dig in about developmental disabilities programming. The fiscal 2027 preliminary budget for the agency's developmental disabilities program area is $9.6 million, of which personal services spending is $924,000 for 10 positions, and OTPS spending is $8.6 million, mostly for 68 contracts. Of those 10 budgeted positions in FY27, only 5 are active as of January, which brings the vacancy rate to 50%. What are the roles and responsibilities associated with those positions?
Thank you very much for that question. First, let's start with where the funding comes from for this program. So in terms of helping individuals who have intellectual and developmental disabilities, the majority of that funding comes from the state through Medicaid. We absolutely supplement and we serve as a backstop and gap filler and make sure that
You're saying that the $9.6 million?
Well, I'm speaking about the program overall. We are there to provide this service for individuals who are not covered by the state. In terms of the budget, I'm going to hand it over to Aaron to share a little bit more there.
Yeah, thank you, Councilmember Hanif. So the budget is split roughly half and half between city and state funding. In terms of the positions, the developmental disability-related services are contracted out.
Mm-hmm.
So, the staff lines represent dedicated oversight positions, sort of program consultants, specialists for the contracted services.
And are you able to share who provides those contracted services? Like, who are the vendors?
Yeah, we can follow up with you to get you a list of the contracted service providers.
And what are the 68 contracts related to?
What we do with this program is we oversee the local programming and working with those vendors. But in general, what those contractors do is provide services across a number of different domains. So,
Could you provide an example?
Yep. So like recreational and socialization, Article 16, clinical services, vocational services, homemaker, and classroom education. And so across a full range of different intervention points. And it's about 1,200 New Yorkers who are served annually through these various venues.
Got it. And then the contractors, are they New York City based?
That is a very good question. I'm going to pass it to Dr. Wright to share more on that. And if we don't have more, we can get back to you. But
thank you.
As the commissioner stated, that the city vendors fill the gap between what's going on with the state. And so those individuals that we have in the city, yes, work with those individuals that fall into those categories. And so, yes, my understanding, unless we can.
And yeah, we'd like to also call up Assistant Commissioner Marty Davidoff to share a little bit more on this.
Yeah, I'd just like to get a brief summary on how you all are supporting people with developmental disabilities and from start to end how this program works.
Yep.
Okay. Before you begin, I just need to swear you in. 1 second while I pull it up. Do you promise to tell the truth, the whole truth, in front of this committee and council members?
I do.
Thank you. You may begin.
Hi, good afternoon. My name is Marnie Davidoff, and I serve as the Assistant Commissioner for the Bureau of Children, Youth, and Families and Developmental Disabilities at the Health Department. So the programs that we contract for roughly fall into 3 categories. We fund services at licensed Article 16 clinics. So there's clinical services for individuals with developmental disabilities. It's one category. Another category is we fund recreational and socialization programs. And the third is that we offer contracts for vocational services for people with developmental disabilities.
Got it. And are those contractors New York City based?
Yes, those are New York City based contractors.
Got it. And are you able to give us an example of one and sort of provide what they do and how they're reaching their clients?
Sure, yeah. So for example, the recreational and socialization programs offer services to residents who are between the ages of 3 and 21, so it goes up to young adulthood. And those are focused on individuals with autism spectrum disorders, and they do a wide range of activities and services with these individuals. So they may have field trips, they may do creative arts, cooking, sports, social skills, homework assistance, obviously depending on the age, and also recreational programs and educational programs with families as well. So that's one example. And we have we have recreational socialization programs throughout all 5 boroughs.
And how are New Yorkers learning about these programs?
Yeah, I mean, I think there's a variety of ways. There's not one central point of entry into the DD programs. I think that referrals can be made through, educational programs, for example, right? Especially if there's a recreational after-school program that could be of benefit. Also, if individuals have applied for state OPWD services and don't qualify for those, they can be referred to our services as well.
Got it. And then you mentioned that for one of the programs as an example, that's New Yorkers 3 to 21 years of age. Are the various programs age-bound, or could you share if there's what other ages you all are reaching?
Right. So maybe what we can do is send you a follow-up.
I'm sorry, I missed that.
No, not a problem. There's different age breakdowns for each of the categories, so we'd be happy to send you, a follow-up with the exact ages for the various programs.
Okay, that'd be great. I'm going to pass it back to the chair and then come back for round 2.
Yeah, we'll come back because me and you, we're going to be here a while. Councilmember Stevens.
Hello, good afternoon. I just have a couple of questions. I'm going to ask some of the school-based questions, but I just had a question because last year we passed Intro 997A, where the Department of Mental Health would create a training program for peer-based mental health, and I just wanted to know, have we already started to distribute that information, and wanted to update to see how that was going? I know there has been a number of young people who have reached out to myself in my office to get more information about this, and so I just wanted to just have a quick check-in to see where we were with that program.
Yeah, and thank you for your leadership on this, Councilmember. This is an incredibly important resource. Many of our youngest New Yorkers can't make it to see a psychiatrist or a social worker or a licensed mental health clinician. So having their peer in the high school in that seat next to them is an incredibly important resource. So I'm going to hand it over to Commissioner Jamie Nichols to share a little bit more about this program. Oh, sorry.
Hi, I'd be happy to speak to that. So for the local law, we are really working very closely with our partners at the Office of School Health, and then by extension with New York City Public Schools in active planning for the implementation. As far as I am aware, we haven't begun implementation yet, but we are, as I said, in active conversations with them about it.
So do you know when it will be implemented? How far are we out? Do you have a timeline? Because again, I'm the chair of Children and Youth Services, young people, this is one of the things they are constantly talking about. Around mental health services, and this is one of the ones that they actually came in and advocated for themselves. So it is important to me to have a clear timeline, because I know even with the legislation, it was supposed to be implemented right after we pass it, so I would love to just get a timeline and update.
Yeah, what we can do is collaborate, communicate with our partners at New York City Public Schools and follow up with you to give you some precise timelines for rollout.
Definitely, I will be monitoring this closely, and I look forward to following up about this. I'm going to ask a couple of questions around school-based health centers. The preliminary plan included a one-time city-funded $1.1 million in fiscal 2026 transfer to DOE to support 2 school-based health centers with high populations of students in shelter, and the hiring of a vision program manager, 1 district implementation supervisor, and 5 mental health implementation specialists. What are the locations of those 2 school-based health centers covered by this funding, and what is the breakdown for this funding between the 2 school-based centers?
Thank you, Councilmember, for that. The 2 school-based health centers are John F. Kennedy High School and the George Wingate campus.
Sorry, what was the other one?
It's John F. Kennedy High School and George Wingate.
Oh, Wingate.
Yep.
Thank you.
And in terms of I think you asked another question around the budget.
Yeah, what was the breakdown of funding between the 2 school-based centers?
Yep. I'll hand it over to Aaron to see if we have more on that to share.
Yeah, happy to get back to you on the specific breakdown between the 2, but yes, this is 1.1 that comes from DOE, New York City Public Schools, to the health department.
I'm sorry, could you say, I'm sorry, I can't hear. Could you say that again?
My apologies, yeah. So we'll get back to you on the specific breakdown of that 1.1, how it's distributed between the 2 sites.
It's not split evenly?
I'll have to get back to you on the specifics.
Okay. I just want to say, especially when we're coming to hearings, please have the specifics, because I know myself, I know I'm new to this committee, but I like detail. So or if you can ask someone to get this information to you, because we'll be here for a bit, but I think that it's important that you have like kind of details, because I'm always in the weeds of things, so and I'm on this committee. How many total school-based health centers are in operation?
In terms of total school-based health centers, Councilmember, we have 139 school-based health centers, and this allows us to serve over 140,000 New Yorkers students across 323 different public schools.
What is DOHMH's total budget in fiscal 2026 and fiscal 2027 for school-based health centers?
Yep. I'm going to turn it over to Aaron to share more there.
Sure. The current budget is $8.7 million, and it's the same for fiscal year 27. And that supports 22 schools. Those are the 22 school-based health centers that we support financially directly as a city.
Do you happen to have a list of DOHMH funded staff in school-based centers? Do you have a list that you could share with the committee?
We can get back to you on the specifics.
What is the average amount of staff in school-based centers?
Can you repeat that question? I'm sorry, Councilman.
What is the average amount of staff in school-based health centers? Like how many staff is typically on staff?
Yeah, great. Let me call up Assistant Commissioner Lydia Ledniak to share a little bit more on the details of the program.
How is the LGBTQIA+ students specifically supported by school-based health centers?
Before you answer, I just need to swear you in. Will you please raise your right hand and respond verbally? Do you affirm to tell the truth, the whole truth, and nothing but the truth before these committees, and to respond honestly to council member questions?
Yes.
Okay, you may begin.
So to your LGBTQ+ question with regard to school-based health centers, so school-based health centers provide care to all students regardless of gender identity. The health department provides specific training to school-based health center providers on working with this population. And specifically, in addition, school-based health centers also provide referrals to gender-affirming care.
Thank you. I'll look forward to the follow-up for the questions that I asked that you didn't have information for. Thank you.
Thank you so much. I want to ask a few questions about GISH. The past two budget cycles, the council advocated to protect the existing units of GISH and expand to meet the commitments outlined in the points of agreement for closing Rikers. So could you just tell me how many GISH units are there currently? How much does it cost annually to operate a GISH unit? And how much does it cost to bring a new GISH unit online?
Yeah, thank you for that question, Chair. Currently, we have 120 units of JISH units, which are spread across a number of contracted providers. That's CAMBA, the Fortune Society, and Urban Pathways. We have recently reprocured released an updated RFP to increase the number of JISH units, and we're doing so because
That's from the money from last fiscal year, right? The added money?
I want to make sure I'm answering that question correctly.
Yeah.
Is that?
Yes, the 4.8 million is for the new revised RFP.
And then so, that is really because we want to put those JISH units out there at a market rate that's going to move the units. And so we have a plan to get to 190 new JISH units. Let me ask Assistant Commissioner Jamie Nichols to see if she has more to share on this.
Yeah, I want to know the cost annually to operate an existing unit, the cost to bring on a new one, and then as to, because since you brought up the RFP, I'm also curious because you released that amendment to the 2019 JISH RFP, and that the original one covered 380 units. The amendment only covers 190, and so I'm also curious, like, why doesn't it cover the full 380?
Yeah, let me hand it to Aaron to talk a little bit about the budget there.
Yeah. Sorry, thanks for the question, Chair. Right, so the 4.8 million is the amount that we are able to, up to 190 is what we're able to support with that.
With the 4.8?
With the 4.8.
I see, okay.
Exactly.
So it's the RFP to bring the new units online.
With the enhanced rates that are similar to the rates that match what council enhanced through its contribution.
But can you give the cost of per unit to bring a new one online and to operate an existing unit per year, per unit?
I think roughly it's around $26,000 a year for the service component to bring it online. The capital financing is a separate issue.
Yeah, the amended RFP did two things. It raised the rates to be reflective of current market prices, right? And it added a congregate option. So the rate are detailed in the RFP. There's a rate for congregate and then also scattered. And then the scattered site rates are dependent upon the size of the unit. Is it a studio, 1 bedroom, 2 bedroom? So it matches FMR. So I don't have a simple answer to that question, but it's all detailed in the RFP.
Sure. The last question on this that I want to ask about is just what's your target for JISH units? Like Dreamworld, you're like, this is how many we want and need. Will you be able to reach that target, and how much more funding would you need to meet that target?
Yeah, I can maybe share a little bit about that. Currently, as we mentioned, we have these 190 units that we're targeting, but we do have a plan to get to 350 total units. But let me hand it over to Jamie to share more.
Sure. So we've had 120 scattered site units since 2015. I want to get to 121, 122, right? We need to add more. It's a really valuable service. So I think it'll be 120 plus 190. If that's going well, I look
and then you want to get to that 380? Did you say 380?
Yeah, the 350 really, I mean, that's, there's the units that we're doing, and then there's also the Just Home units that were announced.
Yes, very excited about the
H&H
Just Home
Correctional
units. But
Services.
how much money do you guys need?
I think the how much money question is, as Jamie said, I mean, how long was that RFP out there? It was for years, right? And there was 0 responses.
7
so
years.
I think 7 years.
Okay.
So I think we're really looking forward to seeing what comes of this recently re-released one and just continuing the conversations with both council and the administration.
So I want to just shift and ask about supportive housing. The prelim plan includes baseline city funding for $81.9 million in fiscal year 2026, with inflationary increases in the out years as a funding reestimate to support existing units. Approximately 61 for the 15-15 supportive housing units, and the remaining 21 to support the pre-15-15 program units. How many total units of the 15-15 supportive housing are there in New York City?
Yeah, so.
And how many are vacant? And what's the timeline to fill those vacancies?
Yeah. So I can start things off and then kick it over to Assistant Commissioner Jamie Nichols. So we currently contract for over 13,000 units. Our current vacancy rate is about 7%. So we have a fill rate of about 93%. And so
Well, what's the number? 7% is how many units? How many homes?
7% of 13,300.
Y'all keep asking me to do
we're-
math. Like, you
we're gonna
bring your
turn it over
calculator next time.
to Assistant Commissioner Jamie Nichols on that.
Yeah.
I'll bring my calculator next time.
Thanks to Local Law 3.
It is a budget hearing.
2025, right?
Yeah.
So thank you. We have a great report with that precise number. It's 876 out of 13,000 units, but 417 of those have been linked to a person, right? So that person is found, gone to the program, seen it, said,
Yeah.
yes, I want to sign a lease, and is in the process of moving into that unit.
Okay, how long does that take?
So that can take, it depends on a number of factors, right? When the person wants to move, when the building is safe for human occupancy, right? We have to have a temporary certificate of occupancy to make sure it's safe and make sure that their vouchers are in place. It can take a couple months.
So in putting aside the folks that are like, have had applications approved, they've looked at apartments, those other vacancies, what's the timeline to fill those other vacancies?
So there are, it's about, I'm doing quick math, 76 other vacancies where there's just not yet a person. This is happening every day, right?
Yeah.
The HRA is making referrals and placing people daily.
No, but totally, but I just think
a
it's
matter of
like,
time.
yeah,
right, until
no,
the person finds.
No, totally, but I want to know what that matter of time is, if there's an estimate around like when we can expect that.
We can get back to you on that, Chair.
Okay, that'd be helpful. And then, I mean, this is a similar question looking out further, but is the city on track to build 15,000 of those 1515 units by 2030?
Yeah, so I think I can start off and then hand it over to Assistant Commissioner Jamie Nichols. We're on track to hit that on the congregate housing side, but things get a little bit more tricky when we think about scattered site housing. And so, as you might imagine, the idea of our staff members having to travel across the city and spending half the day on the subway, so it makes it more challenging. So that's why we are pursuing the congregate housing option. But we'll hand it over to Jamie.
Sure. So the original 1515 RFP was split evenly between congregate and scattered sites. 7,500 congregate, 7,500 scattered. There was initial success with the scattered site procurement. We got a number of awards in the beginning, but that plateaued as the housing market, prices went up. And so last year, we reallocated money that was originally intended as scattered site towards more congregate. So we added more opportunity for providers to submit proposals for more congregate buildings to build last year. We got a ton of proposals. Those are all being reviewed, and as we see how these awards shake out, right? What are the awards? What are the size of any one development and the construction timeline? We'll be in a better position to talk about when those units actually come to fruition.
Okay. I'm going to move over to crisis respite centers. These centers, they provide alternatives to hospital stays for people experiencing an emotional crisis. The centers offer stays in a home-like setting and have an open-door policy for folks to be able to continue their daily activities. So can you just say, the current budget and projected for FY 2027 for these centers, and how many of the crisis respite centers are funded by DOHMH?
Yeah, thank you for that question. We think that the crisis respite centers offer an important extra intervention to provide individuals who need care, and so this is an important part of our spectrum of tools to provide. With regard to the budget, let me hand it over to Aaron.
Thanks, Commissioner. So the FY26 current year budget is $5.3 million, and the FY27 budget is $2.8 million.
It's a big difference. Okay. I mean, obviously we want to see it not just stay the same, but increase, especially considering the climate in the city. How many of the crisis respite centers are funded by DOHMH? And do you fund crisis respite centers in all 5 boroughs?
Yeah. So we currently have 4 Are we talking about the crisis residences or crisis respite centers?
Respite centers specifically.
Okay. Yeah. So let me comment on that. So we currently have 4 contracts for 4 crisis residences, and these allow for individuals to stay up to 1 week in an open door setting where folks can be cared for in that way. And so we are always looking for ways to expand.
I'm sorry, I just for the,
Yep.
I want to be able to pass it over to my chair soon. I just want to know how many, so it's the 4?
Yep.
Okay, I'm just gonna, not trying to be rude, I just want
Yeah.
to be mindful there of the public and the chair over here. And you sent us a list of the contracted vendors for those crisis respite centers? If you haven't, please do.
I can tell you right now, I don't think we sent the list. It's Community Access.
Okay.
Mosaic Mental Health, SUS Services for the Underserved, and Transitional Services for New York.
Great, thank you. And then my last question on this is that there was an additional $2.5 million added at FY26 adoption to support crisis respite centers. And this was one of the council's budget response requests last year. So how specifically will that $2.5 million support the crisis respite centers?
Yeah, we are committed to continuing to do this work of exploring all options with regard to advancing the crisis respite centers. And we're having conversations with OMB and our colleagues across City Hall to explore what's possible to expand.
I'm going to move over to capital funding for a second. DOHMH has a capital budget of $553.5 million in the FY26 to 2030 capital commitment plan, but it doesn't provide a clear picture of how much the city is investing in public health capital projects versus mental hygiene projects. Can you divide it? Like, is there a way to divide it into future plans? And what are the main mental health related capital projects and what are their total budgets?
Yeah, we do have an exciting few months coming up here with regard to capital announcements. We have a brand new public health lab, 240,000 square feet, 10-story building that's going to be opening up in Harlem. In order to...
What's the price tag on?
That's a good question. We're going to have to get back to you. Go ahead.
It's about between $650 and $700 million.
Got it. Thank you.
And then in terms of breakdown between public health and mental health, I think we're going to probably have to get back to you on that.
I mean, the one thing we could say now is, the majority of our agency's capital funds are really about facilities, which is health centers and offices, which are located throughout the city, and the other piece is really IT infrastructure. So that's the vast majority. I mean, we're happy to get back to the specifics, but the bulk of it is in those 2 areas.
Okay, thank you. I shouldn't say department, Office of Community Safety. The mayor has just announced the creation of the office. We know that it's going to house programs and services at the intersection of mental health and public safety. Is DOHMH involved in the planning for the office?
Yeah, look, Chair, we have been doing this work of community mental health for decades, and we are committed to continuing to do that work. We're also excited to have conversations with folks across City Hall, at City Council, advocates, anyone who's interested in addressing the issue of community mental health. We are partnering.
As of now, have you identified any mental hygiene programs that are going to be transferred into that office?
Yeah, we're still in conversations with City Hall and OMB about what the future will look like, and I'm eager to talk to and build a relationship with the new deputy mayor for...
So under the assumption that we don't have the answers to this yet, I'm going to put these questions out there and would love follow-up. In addition to what programs might be transferred, I'd love to know how much of the DOHMH mental hygiene budget and headcount would be transferred to the office, and then just here's a general question of do you believe the creation of this office will improve mental health and public safety outcomes in New York City?
Yeah, well, first let me speak to the broader question, and that is to say that we are eager to work with our counterparts at the Office of Community Safety, and we see them as partners in doing this work. We're going to have to get back to you on the specifics of the programming and the budgets, and all of these are conversations that we're currently having across the agencies.
Great. And I'm just going to ask a couple questions on behalf of Finance Chair Lee, then I'm going to hand it over to my colleague who's going to run the show from here on out. On 988, there's a total budget of $46.8 million, including city funding of $34.3, council discretionary funding of $5 million, state funds of $7.5 million. A lot of people are invested in 988. Talk to me about what the projected funding for fiscal year 2027 is, and then also, do you have data on the total call volume, including calls not answered, the current head count that you have, and then just could you tell me if that staffing level is sufficient to meet the demand for services and improve wait times? The caveat on this is obviously we're not seeing as much call volume as we would like to, and a big part of the work is getting the word out about 988 and like preparing for there to be larger call volumes.
Super important program, and one of the most important resources that we have to offer care to individuals that are in need. This is a 24/7 hotline, 365 days a year. We're currently staffed to reach about 420-something thousand individual calls throughout the year. So that's where we are now. In terms of your question of our FY27 budget, we're at $30.8 million. And so that's what we're looking at moving forward in terms of the budget. There were other questions baked in there. Did I answer all?
Oh, just the data on the call volume and the current head count. I think based on what you're telling me, I think it's fair to say that the staffing and the funding isn't sufficient and you need more.
Let me talk
especially
about the
because
head count.
you have plans. Sorry, I just want to finish we also heard at the last hearing that you have plans to do PR campaigns, and
which we are.
That's
actually,
not
this
cheap.
year, yeah.
So that's like in addition to the work that you're already funding for 988, it's like an added layer of cost that's obviously very necessary.
Yeah, so let me speak to a couple of those points, and I'd love to hand it over to Assistant Commissioner Jamie Nichols. So you're right, we do have plans to popularize and to make sure folks are aware of 988. We actually just recently launched a paid media campaign on that subject. In terms of the headcount, it's a little tricky because this is a contracted provider, so these are not individuals that we staff or that work for us. This is a contracted provider who is doing the work. But let me hand it to Jamie Nichols to see if she has more to share.
Yeah, the most important metric we look at to understand if we're staffed adequately is the average speed of answer. How quickly are 988 counselors picking up the phone, responding to a text or a chat? And they're doing that. 90% of contacts are answered in 20 seconds or less. So that's really fast. And that shows us that their staffing pattern is responsive to the demand.
Yeah, again, my point will continue to be that not nearly enough people know about 988. It's a critical resource, and if y'all do your job, the call volume is going to rise exponentially, and we want to be prepared for that so that people won't continue to only wait 20 seconds for that. So just, you have partners in us advocating for more money being put into that space.
Well, I'll tell you this, Chair, I was just at Queensbridge houses just this past weekend, and was doing some work with our community health workers in the community. And, an individual who was part of the housing complex came up to me and said, the real issue that I have is that, I have folks on my floor in my family who need help. And I said, do you know about 988? You can call. You can have your, family or friends call. This is a service that is here for you. And so we do need more people to know about this, and we share your concern and your interest around how to get this right.
Yeah. And it's life-saving, too. We've seen what happens when, unfortunately, the wrong responder shows up, and it can be deadly. So thank you, and I'm going to pass it over to Chair Hanif.
Thank you. I just have a few more questions. Do you have dedicated staff specializing in developmental disabilities?
Yeah, thank you for that question. I'm going to have Assistant Commissioner Marnie Davis come back to share.
And then if you could also share what the funding or budgeted allocation is for dedicated staff.
Hi, yes, we do have staff dedicated to developmental disabilities work. And just to clarify, if we didn't say this earlier, that our staff are not providing direct services, so all of our services are provided via contracts with community-based organizations. Staff are there to really provide support, oversight, and support for those contracted programs and providers.
So then in terms of oversight, what is DOHMH collecting or assessing?
Yeah, we do collect data monthly from all the contracted providers on individuals served and other facets of their program's operations. It sort of depends on the type of program, but yeah.
And then outside of the contractors, does DOHMH provide anything else as services are being provided, or are you all just a conduit to the contractors?
For direct services, we are doing that through the contracts, exactly.
Okay. And then I'd like to know what other disabilities-related services DOHMH provides directly.
I would have to turn that back to.
Oh, and I also wanted to know, with the 68 contracts, how many New Yorkers are being served right now? And is there a wait time or people unable to get into the program? What are the obstacles?
So Chair, yeah, we're able to serve about 1,200 New Yorkers every single year, and that is across the spectrum of the different venues that we've discussed in the past, the clinical services, the recreational and vocational. And yeah, in terms of the question around disability, yes, this is part, yes, we do have contracted providers who do this work of helping individuals with intellectual and developmental disabilities, but this is baked into our culture and baked into the work that we do across the entire agency, and something that we take pride in.
Could you share a little bit more about what you mean by that?
Yeah, so we are making sure that we offer individualized, person-centered care, and across every single agency, and that includes people with intellectual and developmental disabilities.
And you mentioned every year 1,200 New Yorkers. What's the budget line for this? And is there any plan to expand the reach to more than 1,200?
Yeah, so I can share briefly what the FY27 budget line is. That's that's $9.6 million for this work. But let me hand it over to.
And is that more than last fiscal year?
Let me hand it to Aaron to talk a little bit about the specifics of the budget, but that's what we're looking at in terms of the coming year.
Yeah, thanks for the question. So that 9.6 is the budget for the developmental disabilities area specifically. I think if we think a little bit broader, there's early intervention, which is one of the single largest programs in our entire agency's portfolio, and that's $300-something million. So I think that's another place to think about this type of work.
And in the early intervention work, are you all providing direct services, or is it also a contracts-driven model?
It's a combination. I think I'll call up Deputy Commissioner Ledniak, EI expert.
Hi, so thank you for your question. It's a combination of both. So we provide direct services from the perspective of receiving referrals, convening meetings with families to authorize plans of care, and then the actual services, the therapeutic interventions, the evaluations, and the case management are delivered by a network of 168 provider agencies who employ or subcontract with over 8,000 therapists and teachers who are actually delivering the care.
Understood. And in the early intervention programming, how many New Yorkers are being served?
We serve 30,000 children a year.
And has that number increased, decreased?
It tends to be pretty stable year over year. However, in terms of the number of children served, we've been seeing a slight decline because the number of the birth to three population has declined a bit. However, uptake in EI has not declined as much because we're very successful at establishing partnerships and ensuring that we are appropriately capturing the children. In addition, we're really excited about the TruCare expansion because it's going to facilitate, additional identification of children for early intervention.
And among the 30,000, could you break it down by demographic? which communities are you seeing the most in need of support?
So the prevalence of disability in this population is about 10%. And so it does not vary, right, based on, race, ethnicity. If you want, we can definitely follow up with you on the specific breakdowns by borough and race, ethnicity group after.
That would be great. I know my colleague, Councilmember Riley, is very interested in autism in the Black community, and I think we would love to just learn more about what DOHMH is doing. And then, how many people with disabilities did DOHMH work with in the calendar year of 2025?
We can, tell you that from the perspective of the work that we do to supplement the state, we helped about 1,200 individuals in the last year, but that's really just in the sort of narrow framing of the work that we do with regard to that bureau. But it's hard to put the number broader in terms of all of the agency touch points with individuals with intellectual and developmental disabilities, but we can try and figure that out.
Yeah, I'd definitely like to go into a deeper dive on just how many people with disabilities. I mean, I think between DOHMH and MOPD, I'm still sort of teasing out how exactly our city is providing services or is allowing people with disabilities to reach us for resources. So this is good to know, and certainly that 1,200 number seems like it could be much bigger, and I think the funding for that is critical. The budget for disabilities is significantly lower than the budgets for mental health services, addiction services, and administration. Why is the budget for disabilities so low comparatively?
Yeah, thank you for that question, Chair. So, as you know, when we think about the services that are provided to individuals who have intellectual and developmental disabilities, the large majority of that funding comes from the state through OPWDD. And so the state is providing much of that support. Now, we do have a role to play for individuals that are not covered by the state. And so we see ourselves as supplemental, as sort of helping to buttress the state budget.
So you're saying that the state provides the funding for people with developmental disabilities or intellectual disabilities?
Through the Medicaid program.
Through the Medicaid
That's right.
program.
That's
And then you all, are there any initiatives or program areas where you are directly reaching people with intellectual and developmental and, of course, other disabilities?
Yeah, thank you for that. And the answer there is that there are individuals who are either waiting for Medicaid or who don't qualify. And for those individuals, we are helping to sort of be the safety net of the safety net for those folks.
Got it. And then what's your relationship with MOPD?
I'm going to call up Mrs. Commissioner Marnie to share more on that.
So we're very excited that one of our colleagues, Nisha Agarwal, was just appointed to lead MOPD, and we'll definitely be working closely with her to continue to plan services. I'll allow her to speak directly to what MOPD offers, but I know that they do a lot of great work, and we're excited about the opportunity to collaborate as we move forward.
And what kind of collaborations have already happened in the past?
We have engaged with them about really to just really understand the landscape of where their vocational services in particular, like they also offer some vocational services, and to really engage with them about, what those look like, what ours look like, and to think about how we can work more closely together going forward. So that's a conversation that has started, but is underway.
That's good to know, because I would love to have some reps from DOHMH at our next disabilities and accessibility hearing. having both agencies would be really, really wonderful.
You got it.
So just to wrap up, we're going to reach back out to you to receive the names of the 68 vendors and the ages per program that are being served and reached. And I think that's about it for now, or all that I remember. Thank you all so much. And I also just want to briefly note for all of the public that are here, thanks for your patience. We are running very behind, and public testimony was supposed to begin at 2:30, but we're going to take a few minutes break and then go to disabilities with MOPD, and then we will have public testimony. Thank you.
Thank you, guys.
Thank you very much, Chair. Thank you, Chair.
If you're here to testify, you must fill out a witness slip with one of the sergeant at arms, even if you signed up already online. Please do not block the front entrance doors. Thank you.
please find your seats. We will start shortly. Find your seats. Thank you.
Good afternoon, everyone. Welcome back. I'm Councilmember Shahana Hanif, Chair of the City Council Committee on Disabilities. Thank you for attending today's hearing on the city's fiscal 2027 preliminary budget for the Mayor's Office for People with Disabilities, or MOPD. I would like to note that assistive listening devices and an induction hearing loop are available in council chambers. If you would like a device, please see the Sergeant at Arms. Additionally, committee materials are available digitally via a QR code posted on a board outside of chambers. American Sign Language, live captioning, language interpretation services, and materials in alternative formats, including large print, are available with advance notice. For future hearings, to request these or any other accommodations, please contact the Council's EE office at eeoofficer@council.nyc.gov. We'll make sure that you have that, or 212-788-6936, or email translationservice@council.nyc.gov for language services at least 3 business days in advance. I would like to thank Commissioner Nisha Agarwal and Chief of Staff Sarah Roshanara from MOPD for coming in today to testify in the first budget hearing for this committee. MOPED's fiscal 2027 preliminary budget is $678,657, mainly for personnel services, covering 6 budgeted positions, of which 3 are vacant. This budget has not changed since last year's adopted budget. For too long, the needs of disabled New Yorkers have been sidelined. The creation of this committee is long overdue, and I'm looking forward to working with MOPED to ensure that the disabled community is served adequately. At today's hearing, we will seek details on MOPED's programs that support the disabled community, and we'll hear about its partnerships with city agencies on disability issues in all areas of urban life. I would like to recognize that we've been joined by Councilmember Lee, our Finance Chair.
I will now administer the oath to members of the administration. Will you please raise your right hand and respond verbally? Do you affirm to tell the truth, the whole truth, and nothing but the truth before these committees, and to respond honestly to council member questions? Thank you. You may begin your testimony when ready.
Okay, can you hear me all right? Okay, great. Good afternoon, Chair Hanif and members of the committee. Thank you for the first ever opportunity to testify today at the fiscal year budget for the Mayor's Office of People with Disabilities. My name is Nisha Agarwal, and I have short black hair and brown skin. I'm wearing a black top and black trousers and a multicolor necklace. I have aphasia, and I have my handy cane at my side. I am honored to serve as the Commissioner of the Mayor's Office for People with Disabilities, also known as MOPED, also known as MOPD. First, I will share about the role of MOPD. MOPED's mission is to ensure that New York City is accessible and inclusive for the more than 1 million New Yorkers with disabilities who live and work in our city. We believe that accessibility is not limited to one program or one agency. It is a citywide responsibility. MOPED's works closely with partners across government and external stakeholders to ensure that policies services and programs consider the needs of New Yorkers with disabilities from the start. I want to I would like to share the vision for MOPD under the leadership of Mayor Mamdani. But to understand the importance of this work, it is helpful to look at some of the challenges faced based on New Yorkers with disabilities. In employment, for example, just 40% of New Yorkers with disabilities of working age are employed, compared to 73% of the city's overall working age population. And for those who are in the labor force, the unemployment rate is nearly double, 13% of people with disabilities compared with 7% citywide. In education, almost 30% of adult New Yorkers with disabilities receive less than a high school education, compared to 16% of the city's overall population. And the opposite is true as well. While over 41% of city's overall population received a bachelor's degree or higher, only 23% of people with disabilities had the same. These inequities persist not because of lack of skill or motivation, but because of structural barriers, inaccessible practices, and limited awareness of available support. So recognizing these challenges, MOPED's vision is to strengthen, partner, and expand our services and policies for people with disabilities. I'll start with the strengths. The key priorities from the mayor: affordable housing, access to health and mental health, accessible transportation, education equity, and employment opportunities are critical to people with disabilities and to most New Yorkers. Given that, part of our strategy is to strengthen some of the existing work we already have. For example, NYC at Work program does a continuing of individual services to both job seekers and employers. For job seekers, we offer career advice, resume and individual preparedness, guidance on disclosure and reasonable accommodations, retention services, and support for those who apply for city government. On the employment side, we work with employers on recruitment support, pre-screening candidate referrals, and personalizing hiring events, among other things. This has been very successful, but MOPED wants to strengthen and expand NYC at Work by doing digital literacy training or mental health supports as people with disabilities rebuild confidence and re-enter the workforce. There are also administrative hurdles and lengthy approvals for getting a city job that can discourage both job seekers and the hiring managers. To accomplish this, we need to work with external stakeholders and internal stakeholders, our other city agencies, to do it and to do it well. We also want to grow and strengthen the systemic change side of this equation. Using policy, research, and communications strategically, we can start to influence the decision makers at the city, state, and federal level, and have an impact on people with disabilities systemically. to expand our existing programs or to work on new priorities. Building and expanding our partnerships is key. So first, I'll talk about the disability communities. Disability advocates are trusted community messengers, have deep community ties, and the ability to focus on specific issues in depth. MOPED covers the range of disability services and accessibility, has convening power, and also has access to City Hall and other city agencies. MOPED should be in constant partnership with disability advocates, working together on our shared priorities. And when we have a disagreement, have an open discussion and next steps for resolution. I will also add that MOPED should also ensure that lesser known disabilities, for example, language, learning, and mental health disabilities, should be incorporated into these discussions. Next are city agencies. Historically, people with disability were brought into at the end of any project, not at the start. This was frustrating for people with disabilities, and it was a disservice to those agencies that were involved in that project. Because in the end, we chose the faster design instead of the best design. In the new administration, however, the heads of agencies that were chosen, including me, are into collaboration and problem solving, and that is really exciting. MOPED is nimble and knowledgeable on accessibility and inclusion for people with disabilities. The agencies have deep expertise in their issues and can incorporate in accessibility and inclusion into their projects, with MOPED assisting. It's a win-win. It ensures that the city government is efficient and has a whole approach model. And New Yorkers, people with disabilities, and the broader public will recognize that this city works for them. Next would be broader social movements. In the 1960s and 1970s, disability advocates were in conversation with the civil rights movement, women's rights, LGBT rights, immigrant rights, and the anti-war movement. Now, in 2026, it feels more fragmented and siloed. It is important to pollinate those seeds again, and using MOPED's convening power to cultivate the interconnectedness that we all do. And finally, elected officials. Everyone, including people in elected office, have people in disabilities in their lives. It may be themselves, their family members, their friends, their neighbors, or their constituencies. MOPED wants to work with electeds, all of you, to share resources and information, and over time build our relationship and partnerships with all of you. MOPED's vision is bold but doable, like New York City. We don't want to do the bare minimum. We want to be the best in the country, creating innovative ideas that will have a ripple effect on other cities and states. We don't want to create programs and policies that impact some and exclude others. The goal for us is, if it is helpful, if it helps us, it can help others. So we appreciate the council's commitment to accessibility and inclusion, and its focus on the needs of New Yorkers with disabilities. We look forward to working with the council, community members, and city agencies to strengthen accessibility across the government. Thank you all for the opportunity to testify today, and I would love to have more to answer questions from you. Thank you.
Thank you, Commissioner. And congratulations again. I'm super excited really to hear your testimony and your vision about MOPED. And given this is the first inaugural Disabilities Committee, I think we are going to be a power team.
I agree.
Okay, so you went into this a little bit around the city agencies' partnerships. I want to understand if you believe New York City is currently meeting its legal obligations under the Americans with Disabilities Act across agencies, and if not, where are we falling short, and what specific investments are needed to come into compliance?
Yeah, so MOPED provides oversight, guidance, and technical expertise, and we work closely with agencies to ensure compliance with ADA and local laws. While MOPED does not doesn't have the direct enforcement authority, we're not a regulatory authority, but we play a central role in identifying issues, elevating concerns, setting accessible standards, and ensuring that agencies will follow through.
And how are you all assessing whether or not agencies are complying, and what mechanisms do you have to work with the agencies?
Yeah, so we have disability service facilitators, or DSF, are agency representatives who are committed to making their city, the city agencies, more inclusive. DSFs coordinate city agencies' efforts to comply with and carry out laws related to ADA and other federal, state, and local laws and regulations, and they they work with other agencies and services, but with people with disabilities.
And are you able to share maybe an example of how MOPED has in the past supported a city agency?
Yeah, I mean, so many examples, but a good example would be the work that we did with the Mayor's Office of Entertainment, or Media and Entertainment. And so give me a second to find that, because we have that. So hold on, give me a second. Sorry. Okay. Movie theaters in New York City must provide open captions in some of the movie showings due to a law. And MOPED collaborated with the Department of Consumer and Worker Protections and the Mayor's Office of Media and Entertainment on this issue. The Consumer and Worker Protections is the enforcer, and MOPED and MOME are worked to inform of the issues, and MOME provided the website. So that's like working with agencies to create a law that passed.
Got it. So there isn't a sort of blanket policy across all agencies around ADA accessibility, but rather, or could you describe what's standardized? And of course, what you described is very important, and it's unique, and we're grateful.
Yeah. So there's the DSFs. In every agency, and then the DSFs can also be the same as the agency ADA coordinator. So they have an ADA coordinator who manages the accessibility for the ADA laws.
And the DSF is someone who is a full-time employee, or do they have other roles, and in addition to their other role, they are DSF?
Yeah, so most DSF is are people who are in DSF, and that is on top of their primary job responsibilities. But another thing I wanted to mention is that we also do the 5-year accessibility plan, and we ask all agencies to do that on ways that we can, everything from their building to other disability and inclusion activities. So we do that for all of the agencies as well.
You give them feedback?
No, we ask them to create a 5-year accessibility plan, so every agency has that plan.
Got it. And who looks that over? And
We do.
Okay.
And also, I was working in the health department. They have staff who also review it and do that. So I think it's important that not just MOPED receives that and comments on that, but the agency leadership and also do that.
Understood. So each agency has a DSF.
Yep.
Are there any specific trainings that MOPED provides, and what are they?
Yeah. So there are, we meet with them monthly, and also MOPED staff do bi-weekly office hours for the DSF people if they have questions, concerns, etc. So we try to keep an open dialogue.
And does it seem like this piece of support could use more funding? I mean, you mentioned that DSFs have other jobs that they're doing, and this is in addition to their portfolio.
Yeah, so I'm in communication with City Hall Administrative Office and OMB, and I have a plan to restructure MOPED as I shared in my testimony, and so I don't have the details at the moment, but I'm 3 weeks starting, so.
No, totally. Well, I look forward to learning more about the restructuring. And how is a DSF appointed by the agency? What qualifications do they need?
Yeah, so all of the agencies pick a designated employee to be DSF individual, and they have assistance on the ADA laws and background on that, so that they are well equipped for ADA and other laws that happen.
So essentially, this is a staff person who, through training, becomes a DSF.
Yes.
But they don't need any other qualifications, or there aren't other eligibility requirements.
It's just the DSF, it's important for them to have knowledgeable about ADA and other laws and regulations for people with disabilities.
And how much is MOPED spending on its efforts to coordinate DSFs?
I don't know, but I can find out.
That would be great. And then, would it be beneficial for every city agency to have a disability-specific budget?
Yeah, so this is a good question, and there's our pros and cons. The benefits might be dedicated funding for accessible upgrades, et cetera, more consistent compliance, strong support for DSFs, many positives, but there are also potential negatives. Inconsistent agency size and needs, oversight, administrative oversight, and risk of siloing rather than integrating accessible plans. So we both have to be really thought about it, and I think that's important for me and our team to discuss it.
Absolutely. So it's not a one-size-fits-all model.
Definitely not.
But I agree with you that the positives are also so critically important.
Yes.
And then how do you think the city can improve its disability information resources across all agencies?
Yeah, so I think there's a lot of priorities that can be done. Standardizing accessibility pages, plain language and accessible forms, citywide accessible dashboard would be great. But again, I'm reviewing all of these great suggestions that Moped staff shared and others have shared, and once I do that, I would love to talk to staff and others on that.
Wonderful. I would like to turn it over to Finance Chair, Councilmember Lee.
Thank you so much, Chair, and it's so great to see you, Commissioner Argyle. I know. Going back to when you were Commissioner of Moya and I was at my nonprofit before, it is so great to see you, and thank you for always being a champion for us. My name is Linda Lee. I have dark brown hair. I'm wearing a black jacket, blue blouse. I have really dark circles under my eyes right now because it's budget season. So yes, and I'm Korean American, so for folks. And I've always argued that we should be giving you guys more funding when I was chair. And by the way, I just want to acknowledge the fact that I think it's great that we have a completely separate Disabilities Committee, and we have an amazing chair who is going to be helping to champion this. But as we know, a lot of our issues in the disabilities community impact every aspect of our city government. And so I'm super, super excited that this committee was able to be separated out and get its due recognition and attention, to be quite honest. So just wanted to ask a little bit about the preliminary budget. I'll be quick. In the FY27 preliminary plan, MOPED has a fiscal 2027 budgeted headcount of 6 positions. And so how are you, first of all, and I'd like to talk about where you think the needs need to grow, because I always felt like the budget for MOPED was extremely low considering the number of people that you have to service in the city. And so out of the 6 budgeted positions, I believe 3 are vacant, or is it?
So it actually is 4 headcount, and 2 positions are unfunded.
Where's it funded from then? How is it?
I'll explain.
Okay.
So for the 4 titles are commissioner, executive assistant, chief of staff, and assistant commissioner. The 2 unfunded positions were pegged in fiscal year 25, the November plan. And however, we have staff of 20 people. The 4 are positions from the Office of the Mayor. The remaining staff lines are core disability experts who are working on agency, partner agencies, but work indirectly with the coordination of MOPED. So I'll give you an example. I just talked about At Work. At Work has 6 employees, and the partner agency is SBS. So this cross-agency model actually allows disability experts to be embedded in MOPED, and it is a model that expands our impact without duplicating costs. So it's actually pretty a good model.
I was going to say, so does that mean that there's shared costs not just in staffing, but also in the other operational administrative costs as well?
Yes.
Okay, good to know. And thank you for that clarification. And I'm assuming that you've received the same letter of instructions asking agencies to look at different efficiencies. And is it, for you all at MOPED, is it the same percentage that you guys have to abide by with the 1.5%? No, it's not, right? Okay, I just wanted to make sure. And actually, the other questions I'll forego just because you answered it with the staffing part, so thank you. And just, I know that the chair is going to be asking more questions, but it would be great if you could inform us on, and I see through your testimony, inform us on some of your new needs and areas where you want to see growth. So thank you. Thank you, Chair.
Thank you. Okay. All right, wonderful. So in fiscal 2026 November plan, $25,000 in other categorical funding was added to MOPD's budget for handicapped parking education, only with an additional budgeted headcount of 1. Could you explain specifically what this funding is going to be used for and why it's added as a one-time funding, and what's the title of the additional position associated, and has this position been hired yet?
Yeah, so the one-time funding comes from a revenue collected through summons in issues to individuals who wrongfully parked in the spaces designated for people with disabilities. And this funding is OTPS, so there is no additional funding ask. It's just one-time $25,000. And I am planning for this this funding for my new mission and vision, and so I'm thinking through that as well.
Got it. And did this exist in the past as well?
It has. So we frequently receive this money when people decide to put their cars in other than the spaces that are designated for people with disabilities, so it fluctuates.
Got it. And is fiscal 26 budget higher than the previous fiscal year?
I don't know. Do you know?
And I know it's contingent on somebody getting ticketed.
Right. So the revenues come from the summons issued by NYPD, and then the funds are transferred from DOF to Mayor's office. And this fiscal year's revenue is $25,000. It's actually lower than before, only because we've been effective at ad campaigns for stopping people from parking in spaces that are designated for people with disabilities. So there's less summons, which means less revenue.
Got it. And then this program, this education program, is this a signature workshop that you all provide? What is it? And can it, if you have $0, let's say nobody's received a summons, this program can exist without that?
Well, if that is zero, that would be fantastic. And we do trainings and education materials on various topics, including this. So that would be consistent on our work.
And could you just describe what the handicapped parking education looks like?
It's not an education thing, it's just called handicap parking education.
Got it. The funding that comes from the summons.
Oh yeah, okay. Hold on, why don't you share?
I'm talking as if that funding is being used for this program, but you can clarify if I'm not.
Yeah, just to clarify, I think Commissioner Agarwal had mentioned that this is a one-time OTPS funding that comes to MOPD on an annual basis. only because it's contingent on the number of summonses issued. It historically was used, the funding that came was used to then advertise to the community about not parking in spaces designated for people with disabilities.
Got it. So this funding is specifically related still to the parking issue? Okay.
And my apologies.
Understood. No worries. And has this position been hired?
There's no.
There's no position.
Yes.
So this is just a one-shot deal for parking education. Okay, so the preliminary plan lists one contract in MOPED's budget for roughly $16,000 in FY27. Could you share the details of this contract?
Yeah, so this is money is designated to ASL interpreters, and that's the primary. And then we have that's about 16,000, and then we have another 7,000 OTPS.
That's within the 16K or in addition to, okay.
Yeah.
And is the contractor a provider from New York City or is it in-house?
Yeah, the contractor is Sign Nexus.
Do you mind spelling that? And do you provide, do they provide tactile interpretation as well?
I assume they do, but we can double check. And it's SIGN, Sign Nexus, NEXUS.
And is this a vendor that the city has been using consistently?
Yes.
And do you all evaluate them or do you hear feedback from New Yorkers?
Advocates and members of the MOPED actually like working with Stein Nexus, so we haven't received any complaints about them.
What percentage of MOPD and DOHMH contracts go to disability-led organizations?
We don't provide contracting services.
So you don't serve as a conduit or as a grantor?
Yeah, exactly.
And then are MWBE and disability-owned businesses prioritized in city procurement?
Yes, and we work with the mayor's office to procure that.
And are you able to share how many vendors that are disability-owned are providing services to New York City?
We can't now, but we will find out and share it with you later.
Yeah, I'd really love to know. I mean, it's critical that we're not only just talking about access, but we're also empowering people with disabilities to
and I think
be entrepreneurs.
And one of the highlights that I mentioned in the testimony is our work on At Work, and that impacts people with disabilities to get employment, and that's been very successful in the past, and something that I hope it will be able to grow.
Moving on to other budget needs, following the conclusion of the FY27 hearings, the council will release its preliminary budget response where we will outline budget priority items, which should be included in future financial plans. What are MOPD's most pressing budget needs?
Again, we will talk to City Hall and OMB in this discussion.
You're not able to say what might be the priorities? You have to...
I mean, I'm restructuring and so we don't have ideas at the moment, but working with City Hall and OMB, that's the goal, is to create a new structure.
Got it. And then at the moment, how many more budget positions does MOPD need?
For now, we don't have that request, but we'll let you know if that changes.
So there are no other staff lines
We
that are
have
vacant?
one line that's vacant, and I'm interviewing those people.
Okay, got it. Coming back to the workforce, as a disabled city worker who has required accommodations in my own workplace, I want to turn to questions about disabled city workers. What percentage of the city workforce identifies as having a disability?
I can't say the people in the workforce. I'd have to figure that out. Let me see. The head count, we had shared that there are, hold on, give me 1 second. We have 40% of New Yorkers with disabilities of working age are employed. So figuring that math out really rapidly, it would be, say, 1 million, 40% of the million, if that makes sense.
Well, I'm not good at math.
I know, I'm really bad at math too. We can tell you, we can tell you later, and if that helps.
And does MOPED provide additional support for those who want to get a city job?
Absolutely, and that's the reason at work, New York City at Work helps individually people who are seeking jobs and people who are employers, and they connect that in place. And so I find that the work done of New York City at Work is successful, and it could grow as well. And it has been done so well. Yeah.
I would still love to get the math of the amount of city workers who identify as having a disability. And, you know, I want to make sure that New Yorkers feel empowered, that they don't just have to apply for positions that relate to addressing disability in New York City.
For sure.
And so how are we recruiting and retaining? And are there plans for promotions and advancements in their roles?
And I'm going to meet with the commissioner of DCAS, because she they run 55A program that helps people with disabilities to get jobs without having to go through the examination process. And currently we have about half, it's like 700 job by people with disabilities, but only half are filled. And so we want to talk to the commissioner of ways that we can address that and ensure that more people with disabilities get jobs.
Could you just repeat that one more time? 700 people?
There's 700 people, job slots, and only half are filled by people with disabilities.
Got it. What accommodations exist for city employees, and how quickly are they provided?
Yeah, so broadly, every agency has ADA requirements, EEO staff involved. And so using that, like when I was in the health department, I knew that if I had any problems related to my disability, I could talk to people in EEO. We also had DSF people engaged on that topic. And so we have the people in staff. It's how do we create jobs that transition, that new jobs or existing jobs to people with disabilities to ensure that the job that they're most excited for, they can get access to that.
And then, you know, during COVID or the thick of COVID, there was a campaign by city workers to be able to work remote or have a remote accommodation that is written into our policy.
Yeah.
And the administration did not support that. and that really created harm for many, many families who had been either taking care of a loved one with long COVID or were still getting sick, did not want to come into the office as a result of that, and other issues. Do you believe that we should have a remote work option that's not just negotiated between the director and the staff person?
I mean, I can't speak in general, but I think it's like for MOPED, we have a hybrid work environment. So people that when they'll come to the office, we have a list of that, and when they're going to stay home. And I think that works fine. Also, I think that based on the agency, based on the company, it varies in case to case. So I can't say in full that I like remote, because I just don't know about every job that's happening.
Again, during COVID, MOPED partnered with DCAS and H&H to distribute 10,000 at-home test kits designed specifically for people who are vision impaired. For recent emergencies like snowstorms and hurricanes, what other work has MOPED done to help the disability community receive necessary services or supplies?
Yeah, so MOPED works closely with NYSAM, the NYC Emergency Management, to ensure disabled New Yorkers are integral on emergency planning. So we do accessible alerts and communications planning for accessibility evacuation centers and shelters. We participate in emergency work activity meetings and ensure ASL captions and plain language are available on emergency alerts, among others.
Could you talk a little bit more about the accessible evaluation centers I think you mentioned?
Yeah, so I have not been to one yet, but I think they regularly are involved in many agencies getting together about, for example, snow removal. And that is an area that MOPED is also engaged in that topic, and we share what the impact that may have with people with disabilities.
Now, do you all lean on NYSAM for the supplies and resources, or are you informing what supplies and resources they should be procuring?
Yeah, so it's really a coordination effort. So if we think about COVID and the accessible test kits, we worked with MOPED, H&H, and DCAS to create these kits. And MOPED were identifying organizations across the city, including independent living centers, providers with blind or low vision priorities, et cetera. DCAS did the logistics and provided support on that. When MOPED coordinated the other organizations to use the kits and to deliver it to people who are blind and low vision New Yorkers. So the idea is coordination with other city agencies, moving that forward.
Got it. So as I'm understanding it, MOPED is bringing together the disability-led organizations, assisted living centers, et cetera, and getting them the resources.
Yes, exactly.
And is there an evaluation process, or do you hear from these groups about what more they could use, or how has the response been during emergencies?
Yeah, and so first of all, I wasn't involved in MOPED at the time, but the numbers are outstanding. So They secured 175,000 masks and 170 gloves to 64 disability-serving organizations, and directly to 6,500 individuals. We also facilitated a donation of 25,000 masks for D73. And so all of the stuff we do, I think that what I've learned for the last 3 weeks is that Moped does a lot, and they don't get enough credit. And they're so engaged and able to do these things. And so I think that's very important to note.
And then with the disability groups, are you all meeting with them regularly? What is the relationship beyond providing supplies?
Yeah, so in the past, they did quarterly community calls. And I can go into the details on that, but from my perspective, we should meet constantly and not just quarterly. And so we are having a meeting in the next week or two of a group of community members, and partnering with them is actually key to me on how we can work with Moped and the communities that are affected.
And is the budget that you all have enough for expanding the engagement with the organizations you work with? So the money that you already have allotted is going to be used for that work, even though you are going to expand engagement with them? Yes,
exactly.
Coming back to at work, how many New Yorkers with disabilities have been connected to jobs or internships through at work?
So between July 2023 and June 2025, the program provided services to 130 people with disabilities, and helped 99 individuals obtain employment. And then the program also hosted 62 workshops for job seekers and community members, participated in 220, my number is like aphasia, 200 mock interviews, and hosted 7 job trainings. And then citywide, New York City Talent did 373 individuals with disability connection in 24 to 25. And I apologize, it's my aphasia, so if I I can share the numbers that are accurate if that's helpful.
Absolutely, thank you. Are those numbers, were they goals? Did you all have a plan in terms of like, here's how many people we want to reach and reach them and delivered?
Yeah, so in the last administration, I think the goal was to 2,500, and we surpassed that by a much more, and so that's been really...
That's to provide trainings or
trainings
who receive jobs?
Yeah, and receive jobs, right? Yeah.
So 2,500 people with disabilities were employed?
Yes. In the last administration, the goal was to connect 2,500 job seekers with disabilities connected to jobs. And as of this year, the 3-year anniversary of that program is this July, but we've so far surpassed that goal. We're at 3,737 individuals that have been connected to jobs, but this number is in partnership with MOPD and SBS and NYC Talent and DCAS.
Got it. And do you all know if that number still remains? Are folks still in their positions?
We can get that information to you. There is a team that analyzes the retention services of the individuals who have been connected. So after this hearing, we can get you the numbers of how many people are in those positions.
Yeah, it would be good to know about the retention around this program. And could you also just share what the budget for NYC at Work is this cycle and the last fiscal cycle?
So in 2024 and 2025, it was $543 or $1,000, and then 2026 and 2027 is 584,000 approximately dollars.
Okay, a little bit of a bump.
Yeah, a little bit of a bump.
And for the retention piece, does MOPED then provide support to those who may not be able to continue working or are having challenges?
Yeah, so the staff has a year for retention services if people want to find a new job, et cetera. And I think that's fantastic because retention is important, and having that timeline is really helpful.
And have retention services been used?
Yes, used all the time by employees.
Got it. And the budget for this projected fiscal cycle, is that enough?
Yeah, I think that if we want to expand, then the way this began at Work was for private funding, and then it was so successful that we got city tax levy. And so if we need to, we can go to private funders and explore expanding that money.
And then is there funding specifically within that bucket for community outreach and engagement? I'd love to know just the demographic breakdown of who you all are serving.
Yeah, we can get more in those that information, but the work that the 6 people do is immense, and they do trainings, outreach, so many stuff, and so I'll share the details afterwards.
Got it. And has there been specific outreach plans made to ensure that the pool of New Yorkers is diverse?
I think so. Yes. Okay.
Can you share a little bit more?
We have, so on an annual basis, we anonymize the data of job seekers with disabilities and sort of analyze the demographics of the job seekers that have been connected through NYC at Work. So after this hearing, we're happy to share that data with you.
Yeah, I wish you were prepared to share that right now because it is, I think, very important to understand who within the disability community is being served and not being served, and why they're not, and how we can reach them and make sure that they're not left out. So we will wait for those details. Coming to education now, Local Law 18 passed in 2023 mandated that the city create an electronic system for New York City Public Schools to share documentation to help special needs students secure their necessary accommodations when they move on to higher education. New York City Public Schools created this system in collaboration with MOPD. Could you describe MOPD's role in developing the system?
Yeah, so the New York Public Schools already had the technical infrastructure in place to implement the electronic systems required to the law. And because of that, Mayor's Office of People with Disabilities deferred to public schools on the design, build out, and day-to-day implementation of the platform. Our role was focused on providing guidance to ensure that the systems align with people with disabilities principles and comply with all of our relevant federal, state, city requirements.
So the funding associated in developing this system was all New York City Public Schools?
Yes, but our end, we also provided a dedicated digital resource page on our website titled Resource for Students with Disabilities Transitioning to High School or Higher Education. And this page provided students and families with clear information about their resources, the documents that they may need, and how to navigate the accommodations process when they move on to post-secondary education.
And so for supporting education work and students across elementary, middle, high school, college, does MOPED have any additional funding for that work, or are you all relying on CUNY, public schools?
Yeah, I mean, I think again, we work with other agencies or CUNY to do impact that coordinating with each other helps a lot. So the public schools had the logistical avenues. We had the resources and training. So working with agencies moves the ball more forward than with us just doing it alone.
Got it. But specifically on education, there isn't any separate allocation to support that work?
No.
Got it. And that's why you all don't get credit. So you all don't get credit. It seems to me like you all should play even a much more influential role in partnerships with the public schools and CUNY, and not just be giving some feedback and be hidden in the background. And so I'd be really interested to know how you take on this work moving forward. And then what other collaborations are taking place with the DOE?
Yeah, so.
And SCA.
And SCA. So CUNY, we do internship opportunities for CUNY students, promote hiring opportunities for CUNY and their alums. For DOE, we work with D75 Transition Services to explore collaboration to get from transition students connected to opportunities through At Work, New York City At Work. And those are some of the ways that we are working with other agencies.
And then for the School Construction Authority, is there anything specific that you all are guiding them through when capital projects around accessibility?
Yeah, I don't,
Well, it's through the 5-year accessibility plans. The physical, what we have every agency fill out their commitment to making sure that all of their agency programs and services are accessible. So one work stream is through the 5-year accessibility plan, but also on a case-by-case basis, if we get any information about schools that are not accessible, then we work with the relevant agencies to remediate those issues, including SCA.
But the work has to start with SCA before it comes to MOPD.
Correct. Yes.
Because so many of our schools are inaccessible, and getting them to become accessible has been a huge challenge for many of the locations. I know that my colleagues and I have been funding accessible playgrounds and play yards, and they're very, very costly. And similarly with adding ramps to schools and an elevator costs millions of dollars, and it is really, it puts us behind. I think New York City must lead in disability justice, and if our schools are inaccessible and MOPED doesn't play the influential role of really pushing for that policy, I think it's a disservice. I would like to see MOPED play a a much more energetic role in pushing for accessible schools.
Yeah, and I agree. And also information concerning accessible school buildings is contained in a division-wide built accessible profile, or BAP, list on the DOE website. And so I would encourage you to read that out. But one of my goals is to meet with the chancellor and explore ideas that we can do together to expand children.
Wonderful. You all work with HPD as well to ensure that folks with disabilities are able to use Housing Connect and the Housing Lottery. The report from 2025, Accessible NYC, states that MOPED worked with HPD to ensure that the Housing Connect 2.0 platform is compatible for screen reader users. Could you talk about MOPED's Housing Connect compatibility efforts, and is there funding associated with that work, or are you relying again on HPD's funding to move this forward?
Yeah, so our wonderful MOPED digital accessibility coordinator worked with HPD to identify digital accessibility issues and provided solutions to HPD from the launch of the Housing Connect 2.0 until about fall of 2023. And the labor costs for this for MOPD is just one individual who worked on that. So I'll just end there.
Got it. So one staff person from MOPED has this in their portfolio, but I'm assuming that this person also has other relationships with agencies in their portfolio. Yes. And that staff person's salary, does that take into account the work that's happening with HPD, or how is that determined?
I guess MOPED works with all agencies, and our role is coordinating agencies to do this work, accessibility and inclusion. Mm-hmm. And so that's our core area, is coordinating, providing our expertise, which is on accessibility and inclusion. We don't want all of the agencies to do that work. We want agencies to do that work. And I have found that with this administration, people are really excited to work with us and figure out a way to move it forward.
For the Housing Connect 2.0, what's the budget dedicated to that effort?
I'm not sure about the exact budget. Do you know? We can find out.
Thank you. But none of that funding would be coming from MOPED. I just want to make very clear. I understand the role that MOPD has. And then what additional housing support does MOPD provide?
Yeah, so when constituents contact MOPED regarding housing-related matters, we refer to community-based organizations, DSS, PEU, HPD, DOB, all of the city services and nonprofits that are relevant for that individual. We have housing resources on our website, including resources we have worked with other agencies on developing that. And some of these pamphlets, etc., I plan to review and update them as needed.
And are you all keeping data on the folks who get in touch with you all around housing issues to make sure that they remain housed or are able to find permanent housing?
We do, but if it's somebody with supportive housing, we connect them to health department. But many times they call MOPED first, and then we direct where to go if they are needed.
Got it. So in this instance as well, MOPED is providing guidance on or giving them a referral to reach out to HPD or
Yes.
the agency that would be tasked with completing their specific issue. And so I think I'm just trying to understand, like, you know, you all have a very tiny budget and you're doing a lot of connecting. And it seems like the other agencies are following ADA guidelines. However, it's not as though you all are the ones kind of identifying the problem or saying all of our schools should have elevators or like a sort of accessibility policies or advocacy. Am I right to say that?
I wouldn't. So in my vision, we do a lot of programs, but also impact. So using laws, using relationships, and using communications to message our thoughts out. That we do a little, but we want to do a lot more. And that's the goal of my vision, is having MOPED's ideas and vision available to agencies, but also to the broader public, so that they can refer to us. But I do not want our office to be another agency, because that means all that will be put into disabilities, and I think that we should work with agencies to ensure that they take their job. They don't do it like bare minimum, they do it the best of the class in style.
Understood. What steps has MOPD taken to ensure that city agency websites and mobile applications are compliant with ADA digital accessibility standards ahead of the April 2026 federal rulemaking? And does MOPED have a plan to enforce compliance across agencies that are currently out of compliance?
Yeah, so we do the compliance in the 5-year accessibility plan, but I'll find out anything more after this meeting, sorry.
And are you all able to provide an assessment of which city agency websites are currently compliant?
I think we will tell you after this meeting.
Got it. So that is something that you all are keeping track of.
Yes.
And then what is the timeline for the agencies that are not compliant, bringing them to compliance?
I'm not sure.
I can answer that. So one of our staff resources is responsible for liaising with a lot of the IT departments of various agencies and making sure their agencies' websites and digital portals that are used to interact with the public are made accessible to the WCAG standards. And every 2 years, MOPD has a responsibility to publish the work that we do in that regard.
So in that report?
In that report, we don't list out the agencies, but we list out the work that has been remediated. And it's a little technical, but we can get you the list of agencies we work with in remediating a lot of the digital assets that agencies have that interact with the public.
Got it. And for agencies that are not compliant, what are the obstacles?
Sometimes it's technical, sometimes it's financial. So to reference Commissioner Agarwal when she mentioned that if we don't get started on an agency's project from the get-go as like advisors, then a lot of the agencies may roll out with a tool that after it's put out to the public, the community comes and evaluates it and provides feedback. And we take that feedback mechanism and take that and then work with our partners to remediate those issues.
Got it. And you mentioned financial.
A lot of the times when either a good or a service is procured that's interacting with the public and it's not accessible, it's costly to retrofit them to make them accessible later. So that's the financial burdens that come into play once we get involved.
Got it. And are financial burdens going to prevent any of the agencies to not be in compliance?
It's hard to say. It would depend on the agency and the product or tool that we're talking about.
Does each agency have their own funds towards accessible communications?
Not to our knowledge.
Would you know if for the website specifically or the apps that they use, if there are separate budgets for that?
I don't know. We don't know, but we'll find out. I think it's important also that this administration and the agencies that lead want to work with Mayor's Office of People with Disabilities. And so maybe in 3 months, we'll see some changes that will impact people with disabilities and the broader public. Because the reality is elevators impact me in a positive way, but impact people with kids, impact older adults. It helps everyone. And that's the goal that we want to see for New York City.
Absolutely. And I would love to know which vendor is being used for the website, if there is one. Because I'm assuming all of the city agency websites are one contractor, or are they different?
They're probably different.
Okay. So yeah, I think, it would be interesting for me to just better understand, given you all are providing this sort of oversight and compliance, that all of these agencies have a responsibility to ensure accessible website and that they're following the guidelines. And if there is a financial burden, what is that financial burden? And how can we remediate that so that we're not saying that funds are the reason why we can't make something accessible for a city agency. You mentioned elevators. I want to talk about Access-a-Ride. What is your relationship with MTA?
We are in constant consultation with MTA to improve Access-a-Ride, including on services reliant to people with disabilities. So we advocate for the expansion of Access-a-Ride on demand pilot, so riders have more flexibility and independence. We direct rider feedback to the MTA through advisory meetings and general escalation. And we advise on accessibility improvements to Access-a-Ride vehicles and the digital tool called AAR app.
Got it. So that's pretty good chunk of work that you all are doing with MTA. Are you hearing from New Yorkers or organizations that you all work with about obstacles they're experiencing with MTA and Access-a-Ride?
Yeah, so some problems or issues are unreliable Access-a-Ride pickups and long, unpredictable travel routes. limited subway accessibility, including elevators, et cetera, and gaps in accessible pedestrian infrastructure, including the lack of curb cuts and insufficient crossing times. So all of that is like broader than accessoride, but that impacts people.
Is there other transportation-related work that MOPED is involved in?
Yeah, so we work with DOT, and we partner with DOT on monitoring issues related to accessible pedestrian signals, curb cuts, and accessible street design. We also work with TLC on expanding wheelchair accessible taxi services. And we work in interagency groups on transportation equity and pedestrian safety. And we review accessible in the mobile technology and pilot infrastructure.
And all that work also does not have a specific budget allocation?
Yes.
Got it. What additional transportation support do you hear about that New Yorkers need, which MOPD could provide with some more funding?
Again, for MOPED itself, I'll talk to OMB and City Hall, but we would like to collaborate with MTA on driver trainings for the paratransit system to ensure drivers with mobility, sensory, or cognitive disabilities are better served. We also expand outreach and driver education, including disability-specific navigation tools. And we support for research and pilots in accessible new mobile technologies. So those are some of the things.
That's very helpful, yeah, and that seems like it's all really what we need to be up to date with these requirements. Could you share how many city employees are employed under 55A and under how many agencies?
Do you know? Yeah.
As Commissioner Agarwal mentioned previously, there's about 700 slots dedicated to the 55A program, and about half of them are filled currently.
And then what are you all doing to help the city reach the 700 goal?
Yeah, so I'm meeting with the commissioner of DCAS, and she and I both want to work on the impact with disabilities and having more people do 55A programs than half. We want to increase that.
And is there a timeline for?
I'm meeting with her 2 weeks from now, so I'll let you know.
Got it. Okay, I'm going to do one last review of my questions and see if I have anything else, but we might be at the end.
Oh.
Okay, I have maybe one final set of questions. In July 2023, former Mayor Adams released a plan to support career advancement for people with disabilities. $6 million was allocated for the issuance of an RFP called Co-Designing and Delivering Inclusive Employment Programs with and for People with Disabilities. This RFP provides funding for awardees to design and implement new training and programs to help employers make their workplaces more accessible for employees with disabilities. They have to do this work in collaboration with New Yorkers with Disabilities. The RFP was released in March 2025 by the Workforce Development Corporation in collaboration with MOPED and SBS. Awardees were scheduled to be chosen by the end of 2025. Could you share who the vendors are and details about their proposals?
So the city can't publicly disclose the winners yet, but however, we will be announcing that soon. But
Got it. So would you say that you all are a little delayed?
No, it's just that they're finalizing the winners, and that will be released soon.
And what's the timeline of the RFP? Is it a 2-year, 3-year?
Yeah, so it's actually 4 years. About the first year for the co-design process, plus 3 years on the implementation.
Got it. And then are vendors part of the disability community?
Yeah, so specifically, we prioritized this type of experience and relationships in the scoring of the selection process. And the selection process, who demonstrates strong access to and work with people with disabilities, with a clear plan to recruit members of the community to serve as a co-design process.
Got it. And do you think RFPs are an effective tool to incentivize innovation in the disability space?
I mean, for this at least, I feel like it's very effective in the sense that, so you are involved in, like, the co-design process is bottom up. And values the lived experience of those people closer to the ground, compared to other models which are top-down and prescriptive. And so I think that has been successful, at least for this one example.
And then are there other municipalities or state governments which have issued similar RFPs?
Not that we know of.
Got it. And are there other policies or programs that other municipalities are providing or have launched that we are looking at to replicate?
Yeah, so we have countrywide mopeds, and I'm meeting them for the first time next week. And it's exciting because we can talk about these issues, and if they do something that we can steal, and we do something that they can steal, we'll make the country better.
Amazing. That's great. All right. Well, that was my final set of questions. Thank you, Commissioner Agarwal and Sarah, for being here and being prepared. Super appreciate it, and I'm looking forward.
Thank you very much.
Thank you. We're taking a 5-minute break. We'll be back and begin public testimony.
Ladies and gentlemen, would you kindly find your seats? We are going to start the hearing momentarily.
Find your seats, guys. Find your seats. We're going to begin shortly. Please find your seats. Settle down. Settle down. Find your seats.
I now open the hearing for public testimony. I remind members of the public that this is a government proceeding and that decorum shall be observed at all times. As such, members of the public shall remain silent at all times. The witness table is reserved for people who wish to testify. No video recording or photography is allowed from the witness table. Further, members of the public may not present audio or video recordings as testimony, but may submit transcripts of such recordings to the Sergeant-at-Arms for inclusion in the hearing record. If you wish to speak at today's hearing, please fill out an appearance card with the Sergeant-at-Arms and wait to be recognized. When recognized, you will have 2 minutes to speak on today's topic of the fiscal 2026 preliminary budget for DOHMH and OCME. I just want to say something. There's over 100 people signed up today. So in order for us to get to everyone, because we have to be out of the chambers at a certain point in time, I'm going to really ask people to please keep to the 2 minutes. If you have longer testimony, you can submit it to us, and then we'll make sure it gets into the record. If you have written statement or additional written testimony you wish to submit for the record, please provide a copy of that testimony to the Sergeant-at-Arms. You may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. Okay, the first panel is Trina Pryor, I'm sorry. I've been here since 8:30 this morning, so I'm lucky I know my name. There you go. Megan Peterson. Megan Peterson. Okie dokie. And Ryan, I'm gonna not do this the right way. Manganelli. Close enough? Okay. All right, let them get settled. Make sure they do the 2 minutes. The sergeants. Okay, we ready? Okay. Trina, you want to go? Great. You got to put the mic on. Okay, great.
Good afternoon, everyone.
Yeah.
My name is Trina Pryor, and first let me address Chairman Lynn Schulman,
Yep.
Chairwoman Tiffany Caban, and distinguished members of the committee. I'm Trina Pryor, Secretary-Treasurer of Local 372, New York City Board of Education employees of District Council 37, AFSCME. It is an honor of Local 372 to present this testimony on behalf of the 24,000 members we represent, including 256 SAPS, which is an acronym for Substance Abuse Prevention and Intervention Specialists. Under the leadership of our president, Sean D. Francois I, Local 372, we respectfully request the City of New York to fund the SAPS program through a dollar-for-dollar match with the state legislature. Since 1971, SAPS workers have provided a range of mental health and intervention services to the largest school system in the nation. Through teaching social-emotional strategies and providing behavioral support, SAPS workers ensure that the students in New York City public schools are ready to learn. In a group or individual settings, SAPS use evidence-based programs approved by Office of Addiction Services and Supports, also known as OASIS, as positive alternatives for New York City public school students in need. SAPS service grades K through 12 throughout all of New York City's 32 school districts, including special education. Okay, let me go quickly here.
Just going to ask you to summarize the rest of it and then submit it. Go ahead.
That's what I'm trying to do. Let's summarize here. Okay, Local 372's goal is to partner with you and your colleagues in the City Council, along with the mayor, in making a smart investment towards the quality of life for New York City students, their families, and communities at large. It remains our shared responsibility to ensure that our children meet and exceed their potential. Without SAPIS, we are robbing students, struggling students, of their opportunity to quality, competitive education, and untimely changing the trajectory of their futures. This is why Local 372, again, requests that the City of New York assist our efforts in pushing for a dollar-for-dollar match with the state legislature in this year's budget.
Okay.
Right now, our budget,
We have to,
Bing, bing, okay.
sorry.
It's okay.
Yeah, no, we got the gist of it, and please make sure you submit the rest of what you have.
Yes, it was going to be emailed.
Okay, great. All right, thank you very much. Okay, Megan.
Hi, thank you for having me. My name is Megan Peterson. I am a health department research scientist, and I am also the president of Local 3005. As part of DC 37, we represent scientific and technical workers at the health department and medical examiner's office. I am concerned that when we need to make budgetary cuts, as we're being asked to do now through the chief savings officer, we always cut staff lines and vacancies. But if we're going to serve the public, we need to have staff. And I would urge the city to look holistically at our contract portfolios. One example that comes up for us in the union is that we have really struggled to hire nurses and administrative public health nurses, which we represent, in good union jobs, but we spend a lot of money on contracts to costly temp agencies for nursing staff. So that's one example. I also wanted to bring up the water ecologists, who are also represented by our local, and sort of the struggles in staffing. And I just want to make the point that we can increase the number of positions and the number of staff lines that we have, but so long as those positions are being paid the wages that they are right now, we are going to continue to suffer from high turnover, difficulty hiring, and by extension, a lack of public services. That is all I had. Thank you.
Thank you very much. Go ahead.
Good afternoon. Thank you, Chairs Shulman, Caban, and Hanif, and committee members for the opportunity to testify. My name is Ryan Manganelli. I'm a senior manager of policy at the 32BJ Health Fund. Our fund provides healthcare benefits to more than 200,000 32BJ members and their families through contributions from over 5,000 employers. For years, we've seen rising hospital prices in New York City drive up the cost of health benefits and squeeze wages. I'm here today to urge the council to prioritize healthcare affordability in the city's budget by fully funding and staffing the Office of Healthcare Accountability and by working with the administration to address the ongoing impact of rising hospital prices in New York City. As the city faces a budget deficit and rising healthcare costs, it's important more than ever to lean on the Office of Healthcare Accountability, which is tasked with providing the council with recommendations on the portion of healthcare costs spent on hospital care and convening key stakeholders to examine the cost of healthcare services in the city. Last year, the office published its first report on healthcare cost drivers, affirming that the city plan also faces healthcare cost growth driven by high and rising hospital prices. Similar to other commercial payers from 2022 to 2024, the city employees' PPO health plan paid New York City area hospitals more than 2.5 times the price of Medicare on average. Hospital prices varied widely by system, from under 2 times Medicare at Mount Sinai compared to 3 times Medicare at Montefiore Health System. We urge the council to act by asking the largest hospital systems to explain these prices and their impact on employers and wages. The city and all New Yorkers need relief from unaffordable hospital prices at our leading hospitals, and the relief cannot wait any longer. Thank you.
Ryan, I have a question for you. So
Yes.
I don't know if you saw the testimony earlier, but I asked a question about the transparency portal on the website. So if at another point in time, if you could call my office and get back to me about what you see there, we want to follow up on that.
Absolutely, we'd love to follow up on the
Okay,
price
great.
comparison tool.
All right, thank you very much. This panel is excused. Thank you. All right, next panel is Robert Acevedo. Elizabeth Valdez. Mike Schweinsberg. Give them a minute. Dr. Robert, oh, I'm sorry. Robin? Robert? Robin, I'm sorry. I can't read the writing. Recant. Dr. Robin Recant? Yes, no? I guess not here. Michael Cush, or Mikal Cush? Okay. Jordan Rosenthal? Sure. Juan Pinzone? There's one here. Yes, he is. Okay. All right. Okay, Robert Acevedo, why don't you go first?
My name is Robert Acevedo, and I'm a member of Disabled in Action of Metropolitan New York. A little description. I use a wheelchair, and I'm wearing a red shirt with brown pants. The mayor's office for people with disabilities has long been chronically underfunded, limiting its ability to serve as an effective liaison between New Yorkers with disabilities and city agencies. As a result, city services, programs, activities, and newly built facilities like the Hunters Point Library in Queens have too often been planned and delivered without sufficient accessibility, producing federally non-compliant outcomes and exposing the city to costly litigation. Boo! An increase in the funding today would enable the office to intervene at the earliest stages of program and facility planning, ensuring accessibility is built in from the outset and preventing litigation, higher long-term costs. Other major cities invest significantly more in their disability offices. It is time for New York City to make a comparable commitment. We respectfully request a significant and sustained increase in the funding for the mayor's office for people with disabilities, so the city can fulfill its legal obligations and ensure full inclusion for all residents. Thank you.
Thank you very much. Elizabeth?
Good afternoon. My name is Elizabeth Valdez, and I'm the Systems Advocate at the Brooklyn Center for Independence of the Disabled. I'm here today to urge the council to make a significantly stronger commitment in the city budget to the Mayor's Office for People with Disabilities. For far too long, this office has been underfunded since its inception in 1968 and through its various forms over the years. It has never been given the level of investment needed to truly meet the needs of New Yorkers with disabilities. Today, we have an opportunity to change that. With new council leadership, the creation of a disabilities committee, a new administration, and a new commissioner at MOPD, this is the moment to reverse decades of neglect. People with disabilities interact with city government every single day, whether it's living independently, accessing transportation, securing and maintaining accessible housing, or simply participating fully in our communities. We rely on city systems to function effectively and equitably. But when those systems fail us, when there are communication breakdowns, accessibility barriers, or a lack of understanding about a disability services, the consequences are severe. Too often, individuals are pushed into nursing homes, shelters, or substandard congregate housing. These outcomes are not only devastating for individuals and families, they're also far more costly than for the city and state. Despite the growing needs of our community, MOPD's budget has not kept pace with the city's overall budget. In fact, in the proposed 2026-2027 budget, MOPD would see no increase from the $678,657 it received last year unless the council takes action. Increased funding for MOPD is not just necessary, it is also an investment in equity, efficiency, and dignity.
Thank you very much. Mike Schweinsberg.
Kindly. My name is Mike Schweinsberg. I'm the president of the 504 Democratic Club. I am an old man with graying brown hair and glasses and a checked rust-colored suit and a blue shirt. Okay, we are the largest minority by far. Yet today, I've heard 10% of the population, 1 million of us, don't go by the decennial census, which deliberately undercounts us. Check out the CDC website that did an extensive survey every year. And the last year they were allowed to publish their findings was 24, and they pegged us at 28.7% of the population. Excuse me, 28.7% of adults.
Okay.
So they're not counting our kids. Counting our kids, we're over 30% of the population. We are totally intersectional and found in every single segment of society. We are the most marginalized of every marginalized group, and 60% of our population come from communities of color. We maintain when you lift up the disability community, you are rising all marginalized communities from the bottom up. You need to understand that because here comes our budget ask. With regards to the budget for MOPED, when we came up with a figure of $10 million, $10 million for the first year for MOPED, it of course seemed quite reasonable to us, $5 a head. Those who have seen MOPED's offices know there are a great many unused cubicles and spaces that could be utilized by masses of interns and incubator projects to develop concepts and solutions in the crises areas of employment, housing, education, healthcare, transportation, mental health, disability culture, and voting.
Just round it up.
I'm just going to round it up and say, nothing about us without us, our clarion call, and next year I'm coming back, we're going to ask for 15 million, the year after that 20, the year after that 25. But MOPED has to forcefully act on behalf of the largest minority, not depend on every other agency in the city to do it. Thank you.
Thank you. Jordan?
Hi, my name is Jordan Rosenthal. I'm a social worker. I am the director of advocacy at Community Access, a supportive housing nonprofit. I'm a peer, a person with lived mental health experience, and I am the lead organizer for Correct Crisis Intervention Today, which is about a coalition trying to have non-police mental health crisis response systems. I just want to say thank you so much to all of the chairs for staying here and listening to all the testimony. Power to you guys. I couldn't do it. it. And the things that I want to highlight that are in my testimony that are bolded are the most important, things are last year, with help of the Progressive Caucus, we were able to get a $4.5 million investment in peer behavioral health workforce. I want that up to $6 million, and I want the eligibility strengthened to only be things that are in the crisis continuum, whether it's pre or post or during, right? Specifically, community access, where I work, is asking for $540,000 of that $6 million, and that's to create interdisciplinary teams that we can have internally to our housing sites. And the other ask of this that's really relevant is, as the mayor announced the Office of Community Safety today, I really urge the council to hold a joint oversight hearing between mental health and workforce development about peer behavioral workforce development, because we need more peers and more community health workers to actually make OCS have teeth. With that, you can look at my testimony. Thank you.
Thank you. Dr. Recant, right? Go ahead.
I'm here actually on behalf of myself and other people who have suffered from being on accelerated outpatient treatment teams, which I believe are illegal according to Supreme Court decisions and federal law. Forced psychiatric commitment, whether inpatient or outpatient, is illegal. And the outpatient treatment teams are funded partly by the state and partly by the New York City Department of Health and Mental Hygiene. And if you're going to give money to now there are some people who may be dangerous, but Kathy Hochul just strengthened the law and made it very clear you don't have to be dangerous. Anyone can commit you, and it has to be, by law it has to be the least restrictive alternative. You're given no alternatives. And they kept me on there for 14 years. I called the person who wrote the law in Albany, and he told me, all you have to do is tell them you don't want it. No, it didn't happen that way. And they keep you in your home. They don't tell you when they're coming. They abuse you when they come. They try to bang your door down and say, if you don't come right away, we're calling the police. They have called the police. And if you don't take medicine and forced medication, according to a Supreme Court decision from a long time ago, Rivers v. Katz is just not allowed unless it's the only way to control very, very seriously violent behavior. They give it to everyone, and they have the hearings every 6 months in the city, in the New York State Supreme, in what's called the ex parte room, which means that you can't be there, but the law says that the person receiving the treatment has to be part of the decision. And what's wrong is that this is funded partly by the New York City Department of Health and Mental Hygiene. They're going to fund such a program. It really needs to be changed. And the New York City, okay.
No, just summarize it. Go ahead.
New York City Lawyers for the Public Interest and the NYCLU and Legal Aid, they all oppose this law in many, many ways.
I thank you. Juan? Hi, Juan. How are you?
Hi, how are you? Thank you so much for the opportunity to testify. I'm Juan Pinzon. I'm the Senior Director of Government Relations at the Community Service Society. In my written testimony, I lay out 3 things that New York City can do to protect access to health coverage, as federal changes under the HR 1 bill put thousands of New Yorkers at risk of losing care. So I'm just going to highlight one of those things, which is investing in trusted community-based programs like the Managed Care Consumer Assistance Program and Access Health NYC. Programs like MACAP and Access Health are lifelines that connect New Yorkers to coverage, help them resolve insurance problems, ensure that they understand their rights. The support is especially critical for immigrant communities at this time when fear and language barriers often prevent people from seeking help through government channels. The impact of MACAP is clear. Since 2020, the program has handled more than 21,000 cases, secured over $1 million in savings for consumers, and achieved a 90% success rate. The program is also reaching those most in need. 7 in 10 clients are people of color, and most speak a language other than English at home. Thanks to the council investment last year, MACAP expanded from 12 to 20 community-based organizations, and that expansion is already working. We have seen nearly a 40% increase in cases in just the past few months, showing both the growing need and the program's effectiveness. So at this time when federal changes are creating confusion, fear, and new barriers to coverage, this is exactly the kind of infrastructure that we need to protect. This is why we urge the Council to maintain MACAP's $2 million allocation in FY27 and to invest $4.5 million in Access Health NYC to support outreach and public education. Thank you.
Thank you. Before you go, there are questions by the other members. So, Chair Hanif.
Thank you, Chair, and thank you all for your testimony. I have questions for Robert, Elizabeth, and Mike. I'd love to know what your relationship has been with MOPED, the interface, and or organizationally, personally or organizationally, and what you would like to see MOPED provide that they're not providing right now, or what more do you want them to see?
Okay, so my interaction with MOPED goes back to when I organized New York City's first Disability Pride Parade with Victor Calise, that then commissioner, making it such an easy and wonderful event. It turned out very, very well, thanks to him. And he was succeeded by someone who I never had communication with except out in public. And I'm really delighted with the new commissioner who had an early meeting with me. However, I believe that MOPED has always been underfunded and that funding's just gone down and down and down. And so now I believe it requires a dramatic, I've always thought it required a dramatic increase to deal with the myriad problems that face our community. You know, we are, as I said, totally intersectional, but that means we have lots of problems, from mental health issues to mobility problems to breathing problems. You know, I mean, we can't have that interspersed through a bunch of different agencies dealt with by non-disabled people who just don't get us. It really has to come under the auspices of one office, which I'd rather have be a department, really, but okay, all things in good time. Really would love to see MOPED better funded. It'll be fully funded, as I said, after 4 years at $25 million. But compare that with all the other agencies. That's not even comparable. So we're not asking for a lot. We're asking for a big increase, but it's not a lot of money in terms of what should be.
Thank you, Mike.
I think it can be a great agency, and I look forward to your supporting our $10 million ask. Thank you, Kat.
Of course, appreciate it. I'd like to hear from Robert and Elizabeth if you have any comments.
Well, one of my earliest interactions with MOPED was watching them give their videos to teach me how to build an accessible website, and that was a great thing, and I think they could extend those kind of videos to younger students in the schools. That would be a great thing. But remember, they need money. They need money. So, yeah, but that's...
Thank you.
Yeah.
My interaction with MOPED has been ever since I became an advocate and for people with disabilities. And we need money, just like we're all here saying that everything is underfunded for people with disabilities. You know, we're the largest minority, but we are the least funded.
Thank you.
Chair Caban has some questions also.
Thank you. I just want to thank Dr. Rakant for your testimony. Agree that there are a ton of problems with the laws around involuntary commitment and compulsive treatment, especially about how we define behavior. I mean, there's a large disconnect between, I think, what mental health professionals, peers, doctors will define as dangerous and what others who are asked to go out into the community and enforce that law would define as dangerous. So thank you for bringing light to that. Jordan, I love that you brought up the workforce question. I know that I have reached out, or we have reached out to the Committee on Economic Development because I do want to hold a joint hearing on exactly that issue, not just a pipeline for peers, but also a pipeline for street workers. I think we've talked about this before, but not every professional is got the thing to do street work. You could be a social worker and say, I want to do forensic social work, I want to do clinical social work, or I want to do work in our streets, and those are entirely different things. So I want to thank you for that. I know we had the announcement on the Office of Community Safety today, and from your perspective, just wanted to hear briefly what you think is going to be really key for being included in sort of like the organizational structure there.
Great question. Thank you so much, Councilmember Kaban, or Chairwoman Kaban. I would say the number one thing for me when I'm thinking about Be Heard in terms of changes is not only structure of the teams of who is responding, but upping the ratio of teams. I think if you look at the expansion of Be Heard and the number of teams as it's gone over, expanded to precincts, it hasn't kept up pace. So basically, because there are so many eligible calls and not enough teams, even if we were to make it citywide or 24/7, we'd still come up against the same problems because that ratio is so off. And with the fact of circling back to hiring practices, there has been lots of discussion about the difficulty of hiring social workers for the Be Heard teams. And my pitch to council and Renita Francois, if she hears me, is peers should replace the social worker on Be Heard teams. You can have someone who is like me, who holds both identities. I am a social worker and a peer. And I'm going to just say, as Jordan Rosenthal, private citizen, I can say that my MSW education would not have primed me to do that street work of being a Be Heard responder. I think that, learning and peer work and a specific training that would need to be developed through H&H or now the Office of Community Safety would have to be developed to make this workforce. But being just a social worker doesn't give you the check to have those skills.
Thank you so much, and thank you, Chair.
Thank you very much. This panel's dismissed. Thank you so much for being here and for testifying. Okay, so the next panel will be Anna Krill. Laura Jean Hawkins. Rosa. Okay, I'm gonna butcher it, but anyway. James Bristow. Anna, you want to go first?
Good afternoon.
Oh, you're going to go first? Okay.
My name is Laura Jean Hawkins, and I'm the Advisory Board Chair of Astoria Queen Sharing and Caring, DBA Sharing and Caring. I am also a member of Elmhurst Hospital's Community Advisory Board and chair the Patient Care Committee. I am here today as a woman who has been an advocate and ally of the cancer community for over 20 years. I am also a woman who has had her own health journey with thyroid disease and endometrial hyperplasia, undergoing years of biopsies and ultrasounds. Fortunately, all of my tests through the years have come back negative. That is not the case for many, however. There is currently a cancer epidemic in our state, our country, and our city. Cancer is occurring in younger and younger adults. These are called early onset cancers, which are diagnosed in adults between the ages of 18 and 49. A very public example of this is the recent death of actor James Van Der Beek, who died of stage 3 colon cancer in February, just 1 month before his 49th birthday. No one knows why this is happening, but what I can tell you is that more and more people in our community are being diagnosed with cancer, and they are turning to us for help. Help that is getting harder and harder to do with our limited funds. Since 2020, we have experienced a 25% increase in the demand for our services. Funding under the Council's Cancer Services Initiative has stayed flat since the initiative was created. The time for increased funding is now. On behalf of my board, I thank you for the Council's many years of support and for your funding. You've been very generous. But now is the time that we ask you to please increase funding for the Cancer Services Initiative and support our request of $250,000. Every dollar increased is a life benefited and possibly saved. Thank you.
Thank you. Rosa?
Good afternoon. My name is Rosa Sarmiento, and I am one of the Sharing and Caring's bilingual Spanish navigators. I'm also the wife of a cancer survivor, a former community advisor board member of Elmhurst Hospital. As a patient navigator, I have focused on increasing sharing and caring community outreach efforts in my community as the Spanish-speaking community through Queens, educating them about cancer awareness and the importance of yearly and timely cancer screening. As an immigrant myself, I understand the fears the new arrivals to our city may experience. At Sharing and Caring, we had to strive to build trust, reduce fear, and eliminate cultural and financial barriers in order to promote earlier detection and treatment, as well as to improve access to life-saving services. Over the past 2 years, I have assisted many Spanish-speaking survivors, helping them to apply for public benefits, secure access right, and other transportation services, and I have authorized emerging needs assistance for medical bills, rent, utilities, and food. My team and I have also gone out into the community, educating vulnerable at-risk population and encourage cancer screening. And the more that we do, the more that is the need. Since 2020, the demand for our services have increased 25%. Our funding from the council, however, has stayed flat. On behalf of the Queens cancer community survivors across the city, I urge you to support our request for increased funding. Thank you.
Thank you. Anna?
Good afternoon. My name is Anna Krill. I am a 2-time breast cancer survivor and founder and president of Sharing and Caring. It brings to mind 33 years ago when I was initially diagnosed with breast cancer. I prayed to God to grant me life because I wanted to raise my 2 little girls. With that prayer also came my commitment that I would give back every single day. From that point on, that is how Sharing and Caring was created. We address the disparities in Queens County. We provide support services for those who are newly diagnosed and in treatment. We help people in every single aspect of their road with cancer. We are the face of hope, we're the face of survivorship, and we are their life link. So, with that, I have to say, in 2020, again, I was diagnosed with breast cancer. And during my treatment process, I also realized a very alarming fact. Younger and younger people are being diagnosed. Their needs are greater and greater. And we need your help in order to be able to help them survive. On behalf of the cancer community, I truly urge you, please support our funding request of $250,000. It will mean everything to those who are struggling with this horrific disease. Thank you for your time and your support.
Thank you. James?
Good afternoon, Chair Schulman, Chair Caban, Chair Hanif, and members of the committees. I am James Bristow, Vice President of Public Policy and Government Affairs for Vibrant Emotional Health. Thank you for the opportunity to testify today. Vibrant is widely recognized as a national leader in crisis response. As the administrator of the 988 Suicide and Crisis Lifeline, we oversee and strengthen a nationwide network providing life-saving support 24 hours a day, 7 days a week. At the same time, we operate NYC 988 locally, giving us both macro and micro level insight into suicide prevention operations. Beyond crisis response, Vibrant Emotional Health has spent decades building deep trust in communities across the 5 boroughs, from pioneering New York City's first family support program in 1989 to managing one of the city's most robust youth and family peer support networks. We have consistently led with innovation, compassion, and cultural humility. Our programs serve New Yorkers from all walks of life, including youth and young adults, families navigating complex systems, older adults seeking to remain in community, and individuals living with co-occurring challenges. Turning to the fiscal year 27 preliminary budget, it is encouraging to see an attempt being made to address structural programmatic deficits, particularly as it pertains to right-sizing the out-year budgets for supportive housing and early intervention. It is also positive to see investment in the new public health lab, as well as the much-needed cost of living adjustment. Additionally, Vibrant Emotional Health greatly appreciates the Council and Administration's current support for NYC 988 operations through the provision of an additional $5 million in fiscal year 26, which was added in the adopted budget and is implemented via Council discretionary dollars. This additional funding facilitates increased capacity for NYC 988. The criticality of this funding has only risen over the past year as contact volume has continued to go up year over year, and the additional support allowed us to reduce wait times for all New York City contacts, ensuring quicker access to a trained crisis counselor for help seekers. We are confident in the Council and the Administration's ability to see the continuation of this vital funding stream into fiscal year 27. Furthermore, we are optimistic about the Administration and Council's commitment to mental health and want to point out additional areas that are ripe for enhanced investment. For example, youth peer services are an important tool in reducing barriers in mental health care. Yeah, just one more sentence.
Summarize.
Yeah. Young people today face unprecedented mental health challenges. Research consistently demonstrates that youth are more likely to open up to peers who share similar life experiences and speak their language. Targeting investment towards robust youth peer services such as a helpline is a way to see instant benefit. Thank you.
Okay, so wait, before you go, Chair Caban has a question and Chair Hanif. So Chair Caban?
Great. For you.
Oh, wonderful.
Should we expect an increase in the cost of administering the 988 system in future years?
Well, the contact volume continues to go up year over year, so I would say there is going to be eventually there's going to be a need for additional funding to maintain pace and to be able to ensure we have the appropriate capacity to address all help seekers that contact us.
And in April 2025, Gothamus reported discrepancies between how Vibrant Emotional Health and the city, thank you, calculate 988 call and contact volume. And these are discrepancies that appear to have contributed to a reduction in city funding for the 988 helpline program. Can you clarify the nature of these discrepancies? And were you able to hear the front part of my question?
Yes, you're
Okay,
talking about
great.
some sort of discrepancies in data reporting.
Yes.
Yes. So, I mean, I'm happy to say that the, our contract with DOHMH has been right-sized since then, and so it's, at a level along with the other sources of funding, including the council discretionary dollars, to where we're able to, meet capacity at this time. Though it is important to see that funding continued. You have to forgive me, I did just start less than 2 months ago with Vibrant, and so I'm happy to follow up with you with more specific details. But my understanding is that the discrepancy related to how metrics were tracked as it related to help seekers who also were then referred to peer specialists and also to mobile crisis teams, and how those were counted in the overall tally. And I know we had a series of meetings with DOHMH to reconcile that data and to be on the same page. So, going forward, I think we're very much in line. And like I said before, we were able to address the previous kind of contractual issues that had arisen.
Yeah, and then actually going to the contract itself, what portion of the operations are not fully covered by city or state funding, and then how are the other costs being absorbed?
Are you including discretionary dollars in the city funding?
Maybe split it up and.
Well, I can get you the exact breakdown. The city and state funding, which is some of that is passed through from the federal government, that encompasses the whole of NYC 988 operations.
Okay, so there is currently no costs that are being absorbed by outside funding, non-governmental funding?
Not to my knowledge, but I will get back to you on
Yeah, and then if you could follow up with the breakdown on the federal, state, city funding, that would be great. And then my last question for you, what are your current staff and turnover rates within 988 operations? Like, to what extent are compensation levels tied to available funding affecting your ability to recruit, to retain qualified counselors?
I appreciate that question. Thank you. I mean, retention and recruitment is always an issue, and you know, the more you're able to provide as compensation, you know, it enhances both of those aspects. We have been able to hire up pretty aggressively in the recent years, but we do see a need to increase the salary floor to be able to maintain, you know, to retain our staff. So that's something that we would like to discuss further with you and with the.
What's a counselor get paid?
Say that again?
What does a counselor get paid?
Let me follow up with you on that. I don't want to misspeak. I'm sorry, I don't have that in front of me.
Great, thank you. Thanks, Chair.
Okay, Chair Hanif?
Thank you. I wanted to know from the panel if you've had interactions through your organization with MOPED, and if so, what kind of interactions have you had? We haven't. Got it. And you know, everything that was described in your testimonies, and thank you so much for sharing your story. It takes a lot of courage to not just heal from the pain, but then to get up every single day wanting to do this work for the rest of us and for generations to come. So thank you. Breast cancer, some of the mental health issues that 988 responds to certainly include short-term or long-term disabilities. So I'm curious which city agencies you've interacted with the most.
As far as agencies.
Or offices.
With the offices, we basically work very closely with our public hospitals in Queens County.
Okay.
So that's who we primarily deal with. I have not dealt with other agencies other than perhaps Rosa, who deals with getting, you know, services for the individuals that may qualify for, let's say, food stamps or other services, accessoride, so, or even public assistance. I mean, she's better qualified to answer the questions, but she deals with those agencies, so if you...
Got it. And I will just say, of course, the Department of Health administers our contract, so we work closely with them, but vis-a-vis our contract.
Okay. And then, so is it right to say that if someone you know is basically long-term disabled and will have to take off from work, that you all are primarily working with your public hospital in Queens?
Well, with the hospital and also with processing or helping them process their disability papers, you know, working through what they require in order to be entitled to the benefits that they should be getting.
And how many cancer patients are disabled in terms of unable to work after diagnosis?
All right, I could mention to you with the younger population that I've recently been working with, most of them need to be not working while they're in treatments because the treatments are really quite aggressive. So it limits their ability to work. Possibly they may be able to work remotely. It depends on their employer again. So I would say many of our younger ones are the ones who have to go on, whether it be short-term or long-term disability. And unfortunately, with the young ones, their cancer recurs. No sooner do they, let's say it's breast cancer, no sooner do they have a diagnosis of breast cancer and finish that treatment, within 6 months, all of a sudden now it went to the bones or it went to the colon. So their road is a continual, unfortunately.
Thanks for sharing that. That's I mean, terrible, but good to know. And you're not asking for a lot of money.
Okay.
Thank you.
Thank you. Thank you. Panel's dismissed. Thank you. Okay, next panel, Casey Starr. What? Oh, there's Starr.
Fiona O'Grady.
Fiona O'Grady. Okay. Kamari Cruz. Laura Savino. Omar Cow. And Bill Gross. Okay, so, oh, Bill is here, okay. There's 3 here, okay. We have room at the table? Yeah. Okay. Faith Beham? Okay, Jahoon Kim? Deirdre DeLeo? And Dr. David Appel? No. Giordana Weber? And Miriam Mohammed Miller? Oh, Marianne, I'm sorry, I misread it. Okay. That's it. Omar Cow? Who's? What? Yeah, there's not here, okay. All right, why don't you start, we'll start from the left.
Chair Shulman, Kaban, Hanif, and members of the council, thank you for the opportunity to testify. My name is Jihoon Kim. I serve as president and CEO of In Unity Alliance. I am also a social worker and peer professional by training and a person in long-term recovery for co-occurring substance use and mental health disorders.
No, they're not here.
It's an honor to be here today representing 150 substance use and mental health providers. In addition to advocacy, we provide training and serve as the exclusive certifying body for peer recovery credentialing in New York. Our members formed In Unity Alliance to strengthen coordinated person-centered care while preserving the specialized expertise of each service system. Substance use disorders and mental health conditions remain leading contributors to disability and preventable death. They are also closely tied to housing instability, child welfare involvement, and legal system contact. Structural pressures of reducing capacity and delaying access to care when early intervention is most protective and cost-effective. Rates do not cover the actual cost of delivering services, and unpredictable grant payments make it difficult for programs to plan and operate with stability. New York City cannot reduce crises, including homelessness, without addressing the conditions that limit the capacity of community-based services designed to prevent them. We urge you to implement the $15.5 million IMT expansion investment, including the step-down program, which was included in the budget last year, invest $65.3 million in supportive housing to preserve existing units, continue to fund a 3% COLA for human services workers, and provide increased funding for New York City Council's substance use disorder and mental health initiatives as included in our written testimony. Lastly, vocational treatment services have seen a sharp increase in referrals from HRA due to work requirements for SNAP and soon for Medicaid. An assessment of need with funding to support the increase in service recipients is necessary to sustain these programs. Thank you to the New York City Council for championing these life-saving initiatives. I appreciate the committee's time and consideration of these requests.
Thank you. Next.
Good afternoon, Chairs Kaban, Shulman, Hanif, and members of the committee. Thank you for having me and your leadership in strengthening health services in New York. I'm Deirdre DeLeo, Director of Behavioral Health Crisis and Assessment Programs at VNS Health. For over 130 years, our teams have helped New Yorkers live, age, and heal in their homes and communities. Today, we serve more than 95,000 people across the city, older adults, people living with serious mental illness, and people with physical disabilities. To reduce crises and improve safety, we need strong, sustained investment in community-based behavioral health care and in the partnerships that make this work possible. We see the impact of these partnerships daily. During the recent Code Blue emergency, our teams worked alongside DOHMH to help people get to shelter and services during dangerous winter conditions. This same kind of work our Mobile Crisis Act and IMT teams do year-round. meeting people right in their neighborhoods, responding to crises, and helping them stay connected to care and housing. But crisis response alone isn't enough. Reaching people earlier makes a tremendous difference. With support from City Council discretionary funds, our Older Adult Mental Health Initiative brings primary care directly into people's homes. One couple we worked with, struggling with isolation and depression, told us, "Please keep checking up on us. What you do may seem small, but it's not small to us." We see the same impact with young people. Through the council-supported Promise Zone program, we provide counseling in schools so challenges don't become crises. As the city continues its behavioral health efforts and the new Office of Community Safety, we have a real opportunity to build on programs that are already working. Centering the voices and experiences of frontline clinicians will be essential as we move forward. Thank you again for supporting our Older Adult Mental Health Initiative and Promise Zone programs, which help New Yorkers get care before crisis occurs.
Thank you. Next.
Good afternoon, chairs and members of the council. My name is Bill Gross. I serve as the Chief Services Officer at SAGE, which is the nation's largest and oldest organization dedicated to improving the lives of LGBTQ+ older adults. Since our founding in 1978, SAGE has worked tirelessly to advocate for policies and programs that empower LGBTQ+ elders, ensuring that they can age with dignity and security and support. The people that SAGE serves have unique and often complex healthcare issues. For example, approximately 14% of LGBTQ+ New Yorkers over age 50 report frequent poor physical health. Many of our constituents delay or avoid seeking care in mainstream settings, since LGBTQ+ adults are twice as likely as their non-LGBTQ+ counterparts to report experiencing discrimination from a healthcare provider. In addition, as of 2024, 56% of all New Yorkers living with HIV are age 50 and over, and nearly 1 in 6 new HIV diagnoses occur within this age group. Our SAGE Center network serves as a safety net for LGBTQ+ elders and older elders living with HIV. We connect them to affirming providers, and we provide programming that reduces isolation, improves access to services by offering benefits counseling, legal and financial planning, educational workshops, health and wellness programs, support groups, and nutritional meals. These vital services are made possible from our partnership with the New York City Council. Our top priority is maintaining our funding, ensuring that LGBTQ+ older adults can live with dignity, and to call the city home.
Thank you very much. Next.
Thank you, Committee Chairs Caban, Hanif, and Schulman for holding this budget hearing, which recognizes the critical issue of supporting the health of New Yorkers. My name is Jordana Weber, and I am Chief Program Officer of Service Program for Older People, or SPOP. We are the only agency in New York City that is exclusively dedicated to community-based mental health care for older adults, and we provide outpatient treatment to 1,000 adults each year. We've been doing this work for over 45 years, and we offer services via telehealth at our offices on the Upper West Side of Manhattan and at satellite locations in Brooklyn, the Bronx, and Manhattan. We're only as strong as our network of community partners, and we're grateful for the opportunity to work with dozens of hospitals, older adult centers, and aging service providers to reach out to isolated adults who would otherwise have no access to mental health care. Older adults represent the fastest growing segment of New York City's population, and they are generally older, more diverse, and more isolated than ever before. An estimated 20% of the population will experience a mental health challenge at some point, ranging from mild depression to serious mental illness, such as schizophrenia or bipolar disorder, which can interfere with their ability to function and live independently. And life can be very difficult for an older adult who's managing physical and behavioral health challenges. Our role at SPOP is to provide mental health services that reduce symptoms, teach coping and problem-solving skills, and support social interaction so that older adults can stay in their communities. We're especially focused on the needs of older adults with serious mental illness. Most SMI mental health care programs are designed for younger adults and don't support clients who are also managing cognitive changes, fragile health, and the practical realities of later life. Aging services, meanwhile, are often not equipped to provide robust psychiatric care. Older adults with SMI fall through the cracks until they surface in the most visible and expensive systems we have: emergency rooms, hospitals, shelters, and too often the justice system. I'll wrap up. I therefore urge the committee to advocate for robust funding for programs and services to support community-based, age-affirming mental health care for older adults with serious mental illness. Thanks so much.
Thank you. Next.
Good afternoon. My name is Dr. David Appel, and I'm the coordinator of the New York City School-Based Health Alliance. I would like to thank the committee chair, Schulman, and members of New York City Council's health committees for the opportunity to submit testimony on school-based health centers. In my opinion, without baseline funding, the financial viability of New York City's 139 school-based health centers are in jeopardy. Increased staffing costs, decreased school enrollment, and newly migrated children with fewer options and significant unmet needs all contribute to placing school-based health centers in financial jeopardy. School-based health centers are being forced to cut back a range of services, and a significant number of school-based health centers around the city have closed, being replaced by contract nurses at a cost similar to what we are asking to keep New York City's school-based health centers in place. And it contributes to increased long-term healthcare costs, higher teen pregnancy rates and lower graduation rates, raised levels of unrelated mental health issues, and drives up ER use and hospitalizations for asthma. I am here today to urge the City Council to use tax levy dollars to support school-based health centers at the level of $100,000 per campus and $100 per student. Through the New York State Department of Health Article 6 enhancement, there's a 20% match to New York City funding for school-based health centers. So the cost is less than that for a school nurse. School-based health centers are a very efficient way to spend tax levy dollars. And I included in my testimony a comparison of services of a school of 2,000 children. It would take 2 school nurses at a cost of approximately $300,000. And they provide first aid care, can do medication administration. School-based health centers provide mental health services, dental care, vision care, thousands of immunizations a year, reproductive health, and well child care.
Thank you very much. Next.
Good afternoon. My name is Laura Savino. I am the Senior Vice President of Care Management for Institute for Community Living. ICL helps the city address the most serious mental illness crisis by supporting more than 10,000 New Yorkers annually, including housing 4,000 people each night. We successfully support individuals with the most significant problems, and these are people that you might have encountered on the subway or the streets through programs like IMT, Intense Mobile Treatment. IMT works because it provides long-term comprehensive services and is rooted in the community. It helps people stabilize, remain housed, and avoid costly traumatic system cycling. Today, nearly 700 New Yorkers sit on an IMT wait list. Individuals, again, cycling through shelters, emergency rooms, incarceration, while we know that there is a model that works. There are simply not enough IMT slots, and we are letting people stay on IMT longer than necessary because clients who have stabilized on IMT have no structured bridge to lower levels of care. This is why ICL launched STEPS. This is our step-down treatment to ensure personal success, which is a recovery-oriented pilot designed to provide structure, lower touch, less intensive traditional support services to help free up these critical IMT slots. Since launching STEPS in 2023, we've served over 150 clients. Of the 73 enrolled, 97% of those were housed, 89% avoided hospitalization, 86% avoided ER visits, and 100% were not arrested or incarcerated. STEPS is also a fraction of the price or of the cost of IMT. Now, the council recognized this and allocated $4.5 million specifically for STEPS, yet this money has not yet been procured. We are urging the release of these funds. And we are also urging you to hold, please, a joint oversight hearing with the Committee for Mental Health, Addiction, Disabilities, and a Committee on Workshop Development for the topic of behavioral workforce development, which is especially pertinent to Mayor Mamdani's promotion with his vision for the Department of Community Safety. If we don't allow these funds to be released, over 100 New Yorkers potentially have nowhere to go back into the community, and they could potentially land back on the streets with no care and no services.
Okay, thank you. Next.
Good afternoon. My name is Mariam Mohammed Miller, and I'm the Director of Government Relations and Policy at Planned Parenthood of Greater New York, or PPGNY for short. I would like to thank the committee chairs, Councilmembers Shulman, Caban, and Hanif for the opportunity for PPGNY to discuss our programs and services. PPGNY has been a trusted provider of sexual and reproductive health care and education programs throughout New York City for over 100 years. In 2025, we conducted over 67,000 patient visits and engaged over 28,000 individuals through our education and community engagement programs. We provide the full range of sexual and reproductive health care services at our healthcare centers. We are deeply committed to providing care no matter what, and we're thankful for the Council's continuous support of our work to ensure New Yorkers access the care that they deserve. We also have faced a series of attacks from the federal administration and politicians hostile to sexual and reproductive health care, limiting our ability to provide the care New Yorkers rely on. So that is why today we are asking the Council to continue to support the work that we do by asking for increases in several initiatives, including the Reproductive and Sexual Health Initiative that supports our clinical service work and our education programs, specifically our Youth Health Promoters programs that engages young people to access the care that they deserve and empowers their ability to navigate healthcare services. We are also asking for an increase in the New York City Abortion Access Fund, which is the first in the nation abortion access fund that the Council proudly championed to ensure New Yorkers can get abortion care. We're also asking for an increase in the dedicated contraceptive fund to support our ability to provide long-acting reversible contraceptive care to New Yorkers in need, as well as an increase in the Trans Equity Programs Initiative to support LGBTQ New Yorkers in need of gender-affirming care throughout our city. We look forward to continue to work with the Council to support this work, making sure that New Yorkers can get affordable and quality health care. Thank you.
Thank you so much. Any questions to the panel? Yes, sir?
Yes.
Go ahead.
I would also like to know if your organizations have had interactions with MOPED. I'm just trying to understand, given the intersection of disability in all of your testimonies, just how MOPED might be playing a role in the work that you're doing. What do you think of when we say the mayor's got a Office of Disability for people with disabilities?
I can go. SPOP would love to work with MOPED. One of the things that the commissioner said earlier on about how when you make spaces disability friendly, you're also making them aging friendly, not to mention family friendly. I think there's a lot of opportunity for crossover. At SPOP, we work a lot with people who are blind and visually impaired. We have a satellite at Visions, at Sellis Manor, and we've not worked directly with MOPED, but we have agencies that are referring to us, like Visions or like the Lighthouse, come and do trainings with our staff so that we are as disability affirming as we can be. Understandably, that's only just one type of disability. So.
Sure. Thank you.
Yeah, Planned Parenthood of Greater New York would love the opportunity to work with MOPED. We have launched a series of programs targeting folks with intellectual disabilities, young people specifically in the school system, creating specific programs to provide comprehensive sexual education in ways that meet their educational and IDD needs. So that program has been funded by private donors, supporters of Planned Parenthood, but would love to, concrete a partnership with the city to make sure that those resources are still available to folks, especially given funding cuts that we're seeing for education from the Trump administration, to be frank.
What's the funding associated with this program?
We've gotten private donations. I know that there's some state grant dollars, not clear on city level funding, but we've, inquired and would love some clarity on what the pathways are to fund that program.
Got it. Thank you.
Thank you. This panel's dismissed. Thank you. Thank you very much. Okay, next panel, Ally Taylor. Candace Kume, hopefully I'm pronouncing that correctly. Megan Lakari. Laura McAvoy. Thank you. Kathleen Robb. And Chelsea Domaski. Go ahead, Ally, go for it.
My name is Ally Taylor, president of Voters for Animal Rights. In last year's budget, for the first time ever, the city allocated $500,000 for spay-neuter services to Flatbush Cats, which funded approximately 3,500 surgeries. 2,200 of those surgeries have been completed so far, and they are on target to complete the rest by the end of this June. There is no question that Flatbush Cats' program has been a success for the pet parents and rescuers who received these affordable services. However, this investment represents only a small fraction of what is really needed. The number of requests that Flatbush Cats receives for spay-neuter surgeries and wellness appointments far outpaces available spots. Those 3,500 surgeries account for roughly 2% of the estimated need. To effectively address the 500,000 stray cats on our streets and reduce shelter intake of owned pets at NYCACC, the city must fund nearly 190,000 spay-neuter surgeries annually. Without scaling these services, we will continue to fall behind. Flatbush Cats has the infrastructure to scale up, but they need far more city funding to provide more surgeries and wellness appointments. That's why we're urging the council to allocate $1.5 million in this year's budget for spay-neuter. The rescue community is stretched beyond capacity. Volunteers across the city are stepping in to do this work, often using their own time and money and resources, and this is not a sustainable system. We can't continue to rely on an informal, unpaid workforce to provide what is essentially a critical municipal service. In addition to spay-neuter, I want to highlight another urgent issue, pet food insecurity. Last year's budget included zero funding for pet food pantries, despite the growing need. Financial hardship remains one of the leading reasons people surrender their pets. Right now, families are being forced to make impossible choices between feeding themselves and feeding their pets. In speaking with human food pantries, such as New York Common Pantry, we know that pet food is one of the most frequently requested groceries with the least availability. By providing funding for pet food to existing human pantries, they can provide a warehouse and distribute pet food most efficiently. We are calling for $2 million in funding for pet food pantry programs, and in summary, we urge the council to build on last year's progress by allocating $1.5 million for spay-neuter and $2 million for pet food pantries. The cost of providing spay-neuter and pet food is 1/3 the cost of what it would cost to shelter an animal at NYCACC, and by investing in spay-neuter and pet food pantries, the city can take meaningful, proactive steps to reduce shelter intake, improve public health, and support working families. These are not just animal welfare issues.
We have to, sorry. That's all right, no worries. Next.
Thank you so much, council members, for listening, and council member Lynn Schulman, it's great to see you again, and Chair Kaban and Chair Hanif, thank you for listening. I'm Candace Kumai. I am a journalist and writer here in New York City, and I'm one of the hundreds, if not thousands, of volunteers that goes out onto the streets every week to find cats in need and sometimes dogs as well. We go out alone to rescue these animals in distress, and because I'm not a city worker, I get heckled by locals or sometimes harassed, and I'm put in dangerous situations in the Bronx and in Harlem when I'm just out trying to help our cats and dogs. For those of us who step in, we are faced with a multitude of challenges. We care deeply, but we are exhausted. Emotionally, we are also suffering just as much as the cats and dogs on the streets. But with proper investment in spay and neuter services and programs like this pet pantry that we speak about, we can change this. Every single week, I talk to different members. We're all volunteers, completely out of pocket. And the common thread that we all share is that we are tired and we are exhausted and we are completely out of pocket emotionally and financially. New York State motto is Excelsior, which means ever upward. This is a promise to strive for a better future. New York has always been the example that the world has watched, and I please urge you today to put money towards these initiatives for the pets of New York, and I ask you, we should be striving together for Excelsior today. Thank you so much for your time.
Thank you. Next.
Good afternoon. My name is Megan LeCarry, and I am the Executive Director of Puppy Kitty New York City. As most of you know, the city is facing a quiet crisis, one that lives in our alleyways, under our stoops, in the homes of families struggling to keep up. The overpopulation crisis is not just an animal issue, it's a community issue, and it requires real city support. Low-cost, city-funded spay and neuter is the most humane and effective way to reduce suffering on our streets. It works, it stabilizes colonies, prevents endless litters, and improves neighborhood health. But right now, this burden is falling entirely on small rescuers, just like all of us up here, volunteers and other everyday New Yorkers. That is not sustainable. Our organization alone rescued over 800 animals last year, and everyone was spayed or neutered through public funds, through donations that we have to raise. But for everyone that we help, many, many more are turned away due to lack of resources. At the same time, our food bank is overwhelmed. We currently serve about 45 private rescue groups and cannot expand to the general public despite the growing need. Families are being forced to choose between feeding themselves or their pets, paying rent versus veterinary care. When access to food and vet care disappears, the consequences ripple: more unaltered animals, more litter, and more strain on the shelters and rescue groups. If we want to solve the overpopulation, we must address the root causes, and that means investing in spay and neuter and supporting community food banks. Prevention is more humane and far more cost effective. That's why we are asking you to please award $1.5 million for spay and neuter and $2 million for food banks. We are already doing the work. We just need the city to stand with us. Thank you.
Thank you. Next.
Hi, my name is Laura McAvoy. I'm the secretary of the board and a longtime volunteer for Puppy Kitty New York City. I'm here today asking for support for the funding of spay, neuter, and the pet food pantry programs for the fiscal budget of whatever year we're in now, who knows. We are struggling against a massive, endless tide of suffering, doing our best to meet the needs of our city's animals and people, but there's only so much we can do as individual organizations. This issue will take organized systemic change with city support for spay, neuter, for rescues and owned pets, and for pet food pantries to help keep families together. On a national scale, 5.8 million cats and dogs entered shelters and rescues, as reported to Shelter Animals Count by the 13,471 participating organizations in 2025. Of those, 9,371 organizations are rescues without a government contract, which accounts for 69.5% of reporting agencies. According to a 2025 survey published in Pet Food Industry, volume 67, issue 4, 42% of respondents in middle income brackets of pet owners, which would be a household income of $60,000 to $99,000 annually reported significant challenges due to the high cost of pet food. And 46% of pet owners in the lower to modest income households reported significant challenges. Funding for pet food pantries would help alleviate some of this burden for New Yorkers, and we do have the infrastructure to run a pet food pantry. We just don't have the funding to support individuals. On a smaller anecdotal scale, just this month we've done intake for 11 cats abandoned in carriers outside. One was on our porch directly overnight at 5 a.m., and 10 were left in Petco Adoption Center partners, including a litter of 6 kittens.
We need help. Summarize. Okay, thank you.
Thank you.
Hello, my name is Chelsea Domaleski. I currently work with several organizations across New York City, including New York Common Pantry, the Campaign Against Hunger, and Paws New York, to provide pet food and essential supplies to vulnerable residents. Every day, New Yorkers face an impossible choice: feed themselves or feed the pets they love like family. It's happening now. We have senior clients right now who are skipping their own Meals on Wheels donations to feed their pets and to feed their dogs and cats. At ACC, there's thousands of animals entering the shelter every year due to owner surrender, with a significant portion driven by preventable financial hardship, including food insecurity, lack of access to veterinary care, and housing instability. These surrenders disproportionately affect marginalized communities already burdened by systemic inequalities. We can change this. Investing in shelter prevention initiatives, low and no-cost veterinary services, including spay and neuter and pet pantries, keep families together and reduces strain on the shelter system. We can put funding where it matters most: food, medical care, and essential supplies. These are simple, cost-effective interventions. When families can rely on consistent access to pet food, they no longer have to stretch already limited budgets or go without eating themselves. It's one less burden, one more reason they can stay stable and keep their companions by their side. Pets are not a luxury. They're a family, emotional support, and often a lifeline. Keeping them out of shelters and with the people who love them is not only humane, it is fiscally responsible and socially just. I urge you to fund these preventative solutions, because no one in New York City should have to surrender a beloved pet just to survive. Right now, at the Campaign Against Hunger, we have a 2,500 person waiting list for pet food and supplies. This is already something that we have in motion, where we're working alongside human pantries. It does not require any kind of infrastructure intervention. It does not require building new buildings or hiring new workers. It just requires a budget so that we can allocate food and resources to our human pantry partners to serve the people who every single day are trying to feed themselves and stay afloat in New York City. And it's something that the mayor's office can do. Thank you for your time.
Thank you. Next.
Good afternoon, members of the council. Thank you for this opportunity to speak on behalf of SPCA International about the issue that directly impacts animal welfare, public health, and the stability of families across New York City. Every day, animals are born into situations where there are not enough homes, there are not enough resources, and there's not enough support systems to care for them. The result is predictable: overcrowded shelters, increased strain on municipal services, and unnecessary suffering for animals. We know how to prevent this. Spaying and neutering is the single most effective, humane solution to reducing pet overpopulation. It decreases intake pressure on shelters, improves animal health outcomes, and reduces long-term costs for our city. This work is not about limiting life, it is about protecting it. But prevention is not enough. As both a representative for SPCA International and a New York City pet owner, I know how quickly the cost of care can become overwhelming. For many families, access to affordable pet food through community pet food pantries can make the difference between keeping a beloved pet or losing them. Pet food pantries are a critical, low-cost intervention that stabilizes households, prevents unnecessary surrenders, and allows people to care for the animals they love. The resources also support the network of rescuers and community caregivers who are already doing this work, often with limited support. Without access to affordable sterilization services and pet food, their ability to respond is severely constrained. Funding accessible trap, neuter, return programs and pet food pantries is not just an animal welfare decision, it is a public investment, a smart public investment. It reduces suffering, prevents unnecessary surrenders, and strengthens our communities. We are not asking the council to take on a new problem. We're asking you to invest in solutions that already work. Together we can break the cycle of overpopulation, and we can keep families and their pets together. Thank you so much for your time and consideration.
Thank you, and I just want to state for the record that I spearheaded the pilot program for the $500,000 last year for the spay-neuter. I am an advocate for it. I'm pushing for it myself this year, and also for the pantry. So I'm pushing on both of those scores. So just so that just so everybody knows. So we'll see where we wind up. But thank you so much.
Thank you.
Panel's dismissed. Thank you. Okay, Ronnie Marks, Janine Garriga, Robert Desrello, sorry if I mispronounced that, Elaine LaPena, and Wynn Wynn, yeah, I said Wynn. Periasamy, sorry.
Wynn doesn't need a last name.
Wynn doesn't need a last name? Okay. All right, so who do we have? We have Ronnie, we have Wynn. I'm sorry? Okay. Hold on, he's not here. She's not here. Wynn's here. Just give me a couple more. All right. We're going to call up Hadley Weiss, Charles De San Pedro Jr., and Blanca Simmons. All right, let's just do this. Okay. You go first. Who wants to go first? Janine?
She's going to talk for Robert. He had to leave.
Okay, fine. Go ahead.
Thank you for the opportunity to speak to you today. I want to thank Chair Schulman, Councilmember Caban, and other council members and staff for supporting the hepatitis community in the past. I am here today as a representative of the Hepatitis C Mentor and Support Group. I've been working for 12 years on the ground and with the underserved communities, providing training on education and supportive services within syringe exchange programs and drop-in centers. I work closely with the founder and executive director of HCMSG, Ronnie Marks, who in addition to being a patient has experience working with both patients and providers. Educational groups and supportive patient mentoring services have been shown to be important elements of successful and cost-effective medical care for patients with hepatitis C and other chronic health conditions. These services improve the quality of life as well as medical outcomes for patients. The training ACMSG provides for healthcare providers help them to have a better understanding of how to work with all patients with an emphasis on high-risk populations, such as people with substance use disorder, those co-infected with HIV, the LGBTQ community, youth, and women of childbearing age dealing with hepatitis C. Our hope is to see us provide a model for the entire country, with New York City as the first city to eliminate hepatitis C. We need increased services for hepatitis, peer navigators, harm reduction, and syringe exchange services. This is why it is critical that we reduce missed opportunities to screen and diagnose patients who seek care in emergency rooms and hospitals, as well as educating providers and staff on the stigma faced by people who use drugs. There are opportunities to move toward elimination by increasing the focus on treating patients who are in the hospital for extended periods of time. Education is needed in overdose prevention, hepatitis, and HIV. People need to understand the syndemic connection between substance use and infectious disease. As an educator in the field and someone who has witnessed the lack of knowledge in communities, I can
So
tell you
just wrap it up. That's Robert's testimony?
Yeah.
Yeah, and then I'm going to give you 2 minutes for yours, but wrap his up.
Okay, so please help us ensure that all New York City residents have access to hepatitis C testing, treatment, and care regardless of race, gender, and economic status. Thank you.
Okay. Now you will have 2 minutes on your own.
Right, I'm going to go.
You're going to go first?
Yeah, I'm not going to read this whole thing. I'm just. gonna
2 minutes,
say, first
Ronnie.
of all- Okay. Thank you for the support that you have given us. I am a patient who cured of hepatitis C, and my mission is to see and give the opportunity to others to have that, no matter who they are or where they come from. The health department estimates that 330,000 people are living with hepatitis B and C, and without care and treatment, this can lead to progress to serious liver disease, liver cancer, and even death. As a patient who has been cured, I can tell you what a difference it makes in your life. I've seen people turn their lives around from being cured, and it gives them opportunities for other ways in their life to improve. Continued and increased support of the Viral Hepatitis Initiative is vital to the health and wellness of New York's most vulnerable. We have the infrastructure. We need more funding to expand these services. Please help us ensure that all New York residents have access to hepatitis C education, testing, treatment, and care regardless of race, gender, or economic status. Let's make New York City the first city to eliminate hepatitis.
Thank you. Janine, go ahead.
To Chairperson Schulman and members of the Committee on Health, my name is Janine Garriga, and I work with the Hepatitis C Mentor and Support Group, where I focus on hepatitis C education, training, and community engagement as part of the New York City Council Viral Hepatitis Prevention Initiative. Nearly 330,000 New Yorkers are living with chronic hepatitis B or C, and without care and treatment, many will progress to serious liver disease, liver cancer, or even death. These infections disproportionately impact communities already facing barriers to care, including immigrants, people with low incomes, people who use drugs, men who have sex with men, and those with histories of homelessness or involvement with the criminal justice system. Every day, this initiative reaches people who are often left out of traditional healthcare systems. Through education and community-based support, we help people understand hepatitis, get treated, and stay engaged in care. The latest data shows both progress and urgency. In 2024, 305 people were newly reported with acute hepatitis B, and 8,029 people were newly reported with chronic hepatitis B in New York City, with ongoing disparities impacting Asian and Pacific Islander and Black communities. For hepatitis C, 398 acute cases were reported, and 2,188 people were newly reported with chronic hepatitis C, the lowest level in a decade, showing that our efforts are working. But we cannot stop here. People are still becoming infected, and too many remain undiagnosed or untreated. If we are serious about eliminating hepatitis B and C in New York City, we must continue to invest in the programs that make treatment and cure possible. The Viral Hepatitis Prevention Initiative meets people where they are and does not leave them there. We respectfully ask the Council to sustain funding and approve an additional $2.76 million for a total investment of $5 million. This investment will ensure more New Yorkers are tested, treated, and cured. Thank you for your continued commitment to eliminating hepatitis B and C in New York City.
Thank you. Wynn?
Yes. All right. Hello, members of City Council. My name is Charles D. San Pedro Jr., and I have been a member of Top Clubhouse for 7 years and 3 months. Thank you for having myself and one of Top staff members, Hadley, along with our director, Bianca, and Wynn, here to testify about our need for funding to keep Top Clubhouse open. Councilmember Caban, congratulations on your appointment as chair of the Committee on Mental Health and Substance Use. We have a thrilling invitation for you. We would like you to come to our clubhouse for an excellent lunch and meet some of our members. Please stop by any weekday around 12:30. I have prepared a poem for you and hope that it shows you the love that I have for Top Clubhouse and proves that I am here for the right reasons. I love Top. It means so much, and the funding from City Council adds an amazing touch. It allows us to work on the goals we have set, and on us, our members have made a safe bet. We're happy we're still open. Us being closed would be sad. When thinking of our members, we know it would make them so mad. Please baseline our funding so we don't have more stress, and help us make Top Clubhouse a phenomenal success.
Thank you very much.
Can I just
You're
say,
welcome.
I'm in so long as we get to eat lunch together.
Yes, definitely.
Excellent.
Hey, next, go ahead.
Hello, council members, and thank you for the opportunity to testify this afternoon. My name is Hadley Weiss, and I am the program coordinator for Top Clubhouse, a small clubhouse located on the Upper West Side. I've worked at Top Clubhouse for a little over a year and a half, and in that short period of time, I've become a staunch believer in the clubhouse model. I've seen members come out of their shell through time at the clubhouse, start to smile and laugh, begin to build relationships, and gain confidence in themselves and their abilities. These transformations are stunning to watch and are a testament to the vitality of the work that clubhouses do. On the other hand, I have spoken to multiple members who express reservations about fully engaging with the clubhouse because they are deeply afraid that the clubhouse will be taken from them. These members report loneliness and isolation, which negatively impact the state of their mental health. They have told me that they want to participate in the clubhouse, but that it is frightening to allow themselves to rely on a community that might disappear. Clubhouses provide support, purpose, and structure to vulnerable New Yorkers, but we cannot do this to the best of our abilities without stability. We are so grateful for the funding City Council has provided to small clubhouses and ask that our funding be baselined so that we might extend that stability to our community. Thank you for your time.
Thank you very much. Next.
Good afternoon, Chair and members of City Council. My name is Bianca Simmons. I'm the Program Director of Top Clubhouse at Goddard Riverside on the Upper West Side. Thank you for the opportunity to speak today. You already heard from Charles, a dedicated member over 7 years, who shared through his poem just how much Top Clubhouse means to him. His words reflect something we see every day. This is not just a program, it's a community that members deeply rely on. You've also heard from my colleague Hadley, who spoke to the powerful transformations that happen within our clubhouse. Members building confidence, forming relationships, and rediscovering a sense of purpose. I want to build on both of those perspectives. At Top Clubhouse, we serve individuals living with mental health challenges who come to us for structure, connection, and opportunity. Each day, members show up not just to receive support, but to actively participate in a working community where they gain skills, build confidence, and move toward employment and independence. But what we are hearing more and more, and what Hadley referenced, is uncertainty. Members are hesitant to fully engage, not because they don't want to, but because they are unsure if the clubhouse will continue to exist. And that uncertainty has real consequences. For individuals in recovery, consistency is critical. The progress our members make is built on trust, routine, and daily connection. When that stability is threatened, it can lead to isolation, anxiety, setbacks in mental health. Members should not have to question whether their community will remain open. They should not have to decide how to invest in their own recovery based on whether funding will be there tomorrow. Stable support ensures that our doors remain open, our services remain consistent, and our members can continue to grow without disruption. Top Clubhouse, like all other small clubhouses across New York City, plays a vital role in supporting some of our most vulnerable residents, not only improving quality of life, but strengthening communities as a whole. Thank you for allowing us to share our voices today and our experiences from our members.
Thank you very much. Next. Wynn? Go ahead.
Hi, my name's Wynn, no last name needed, and I'm the Director of External Affairs at Goddard Riverside, a multi-service settlement house serving over 22,000 New Yorkers who come to us from across the city, across ages, incomes, health statuses, and more. Grateful to all four committee chairs. Congrats on the new Committee on Disabilities, and the staff for their work to make a more accessible, more healthy city for all of us. Goddard has appreciated the leadership of the council in creating and enhancing the Mental Health Clubhouses initiative. We urge the council to restore and enhance this funding to $3.79 million to cover the true costs of clubhouse work in the face of the needs from community members seeking to join and stay in these communities. We are also just one clubhouse across the wider clubhouse movement across New York City, and I urge the admin and the council to work together with clubhouses of all sizes to invest in this model so that it can stay and grow. We are grateful, in addition, to the council for allocating $4.5 million for the new citywide initiative Jordan spoke about earlier, currently called the Peer Specialist Support Initiative, which funds peer workers across a number of community-based settings, including our Top Clubhouse. We're in support of the calls to expand this to $6 million to emphasize how this criteria works, and to continue to invest and grow the peer workforce more broadly. Finally, we have a number of other behavioral health programs. All of you are welcome to join us at any time. I'm pretty sure most of you have my contact information, including IMT ACT and Young Adult ACT teams. We join other providers in calling on the city to fully fund the number of mobile response teams necessary to eliminate the wait lists for these truly important community resources, including $11 million for IMT. I'm available for questions. Thank you so much.
Thank you, we're all set. Thanks. All right, on our next panel, we will have Michael Petty, Darren Greenwood, Camilla Samuelson, Christina Sparek, Jonathan Chung, and Chantel Bodero. There you go. All right. Free to start. Yeah, go for it.
Good afternoon, Chair and Committee on Mental Health and Substance Use Disabilities and the committee members. My name is Christina
I'm so sorry. I just want to make sure you get your full 2 minutes. Can you reset that? I'm trying to rob you of 10 seconds.
As always, thank you.
I got you. Okay.
My name is Christina Sparek, and I'm an African-American woman with a headscarf, glasses, and wearing black and a colorful scarf. I'm an alternative crisis response researcher at Disability Justice Program at NILPI, New York Lawyers of the Public Interest. And we're greatly concerned about the New York City's responding to mental health crisis by sending police. We strongly oppose the current Be Heard program as police involvement remains too frequent, contributing to the criminalization of individuals in crisis. As a peer with mental health lived experience, I say no to police. No to police. The city must wholly transform its response to mental health crisis by eliminating police and replacing them with a peer-led health response. During my crisis response, which I mentioned before, you heard, I had police come to my door unannounced, and I didn't know it was police. I wasn't in crisis. I had a wellness check, and they banged on my door, and I didn't know who it was. In response, because I was afraid, I grabbed a knife in my own apartment because I thought it was an intruder trying to kill me or harm me. If my door was unlocked, the police would have came in with their body cam footage. It would have said, this allegedly mentally ill person, an EDP, tried to kill us, which would have been false. I would have been the one that would have been killed because I was in danger in my own house, and I was only protecting myself. So with that said, the scores of countless people who are dying in New York City from police response to mental health calls, we must stop the Be Heard program, and we must change it into a way where we dispatch peers and emergency responders, EMTs. We must use 988. The response time must be reasonable. It needs to be culturally responsive and trauma-informed, and establish peer-run oversight mechanism, and establish mental health services, including respite centers, 24/7 mental health clinics, to minimize first place and serve those who are in crisis to de-escalate the situation, and has to be 24 hours. NILPI urges the City Council to ensure that money previously allocated to Be Heard to be utilized solely for truly non-police responses, which includes critical competency. Thank you so much.
Thank you.
Good afternoon. My name is Darren Greenwood, and I've been a member of Shelton Loft Clubhouse for 7 years. Before Shelton Loft, I attended a larger clubhouse, but I prefer a smaller clubhouse because of the close relationships with staff and members. It feels like a family. It's easy to talk with the staff and get to know people. That one-on-one connection makes a big difference. The clubhouse atmosphere helps me stable and active. They also help with everyday challenges, both emotional and physical. 3 years ago, I experienced a very difficult time when my father passed away. I was hospitalized during that period, but with the support of the clubhouse community, I was able to bounce back. Being part of Shelton Loft helped me return to activities that give my life structure and purpose. I work at the reception desk do data entry and computer work. I also help in the clubhouse kitchen. One of my favorite things to do is make coffee for breakfast. It may sound simple, but it feels good to contribute and help start the day for everyone. I also participate in nutrition workshops and Monday Moves, which are chair exercises. I even co-hosted a workshop series teaching others how to use technical devices. In 2020, I even tried working. That job didn't turn out to be the right fit for me, but the encouragement from the clubhouse helped me feel confident enough to try. That support matters. Even though I'm currently not looking for employment, the clubhouse continues to help me improve my life. Shelton Loft has made a big difference in my life. Even today, I continue to attend the clubhouse because it keeps me active, connected, and supported. I hope to continue being part of this community and see what the future brings. Thanks for listening.
Good afternoon, Chair and members of the committee. My name is Chantel Badero, and I am a member of Lantern House Clubhouse in the Bronx. Before I came to the clubhouse, I struggled with my mental health in ways that made everyday life feel overwhelming. I experienced isolation, and it was hard to find stability or a sense of purpose. The clubhouse changed that for me. It gave me a place where I felt welcome, not judged. A place where I could rebuild my confidence, connect with others, and start to believe in myself again. Through the clubhouse, I've been able to develop skills and build relationships and take steps toward employment. It's not just a program, it's a community that supports my recovery every day. Programs like PROS and clubhouses are important because they provide ongoing support, not just during a crisis, but throughout recovery. They help people like me stay out of hospitals, stay connected, and start forward with our lives. Without these services, many of us would struggle to find stability and support. I am here today to ask you to continue investing in programs like these so more people can have the same opportunities that I had. Recovery is possible, and I am living proof of that. Thank you for listening to my story.
Good afternoon, council members. My name is Michael Petty. I am a member of Lifelinks Clubhouse, which is located in Elmhurst Hospital. I came to the Lifelinks as a suicide survivor. I tried to take my life after having enduring abuse from my parents and my father as an alcoholic. I come, like everyone else, to get funding not only for mine, but for all clubhouses. The motto was started back in 1948. There's a reason why they've been following the same model for almost 80 years, because it works. It is a place for people to have a safe haven. Mental illness is not easy to talk about, and it's so much easier when you're around members who have gone through similar or understand where you're from. A lot of people cannot get it from family or friends because simply they do not understand the illness. Also, people get mistaken when they hear the word club. They think it's a place to go play games or cook or just have a free meal. No, I have seen people work and train to go back to the workforce. 3 members of Lifelinks are right now peer counselors at Elmhurst Hospital because of the training. I am a retired chef. I have done it for 38 years. I've been able to teach people how to cook who have gone back to the workforce cooking. So if something's working, you don't break it. You don't take it apart. It's working for people. And like I said, mental illness is not easy to talk about. Thank you.
Good evening, Chairs Kaban, Hanif, Shulman, members and staff of the committee. My name is Jonathan Chung. I'm the Director of Public Policy for the National Alliance on Mental Illness of New York City, or NAMI NYC. We are the only nonprofit providing extensive direct support programs for mental health peers and for New Yorkers caring for a loved one living with mental illness. Our free programs are evidence-based and led both for and by people with lived experience, reflecting the diversity of the communities across the city that we serve. We appreciate that the City Council and the new mayoral administration are engaging seriously with the urgent need to strengthen New York City's mental health system. We are grateful to be part of these conversations. However, significant gaps still remain in the continuum of care. One critical concern is the lack of baseline funding for the Mental Health Continuum Initiative itself. The preliminary budget proposes only $5 million for this effort, which is an amount that is truly insufficient to meet the scale of need across the city. New Yorkers also urgently need greater access to mobile crisis response services. We urge the city to expand the number of intensive mobile treatment teams available to reach individuals with the highest needs. The city must also rapidly scale the Be Heard program to meet current needs, with a goal of citywide coverage and 24/7 availability. Mental health crises can arise at any hour of the day, and individuals in crisis deserve to be met with empathy from professionals who are trained in de-escalation and trauma-informed care. Finally, we respectfully ask the Council to restore and invest in critical peer-led supports for NAMI NYC's programming that we offer free of charge to the community. This includes $250,000 under the Youth Peer Support Initiative, $500,000 under the newly created Peer Support Specialist Initiative, of which we also support an increase overall in that funding, and $150,000 in Speaker Initiative funding for NAMI NYC's Family Support Services. These investments will allow us to expand the reach and capacity of our mental health helpline, education classes, more than 30 monthly support groups, outreach presentations, and our family match mentoring program.
Thank
we
you,
really
Cecily.
appreciate
Your
the
wrap-up.
Council, and thank you so much for your partnership.
Thank you.
Good afternoon, and thank you to Chair Kavan, Chair Schulman, and Chair Hanif, and the members of the committees for holding this public hearing. My name is Camilla Samuelson, and I'm a Health Justice Legal Fellow at New York Lawyers for the Public Interest. Thank you for your continued support of the Immigrant Health Initiative and Immigrant Opportunity Initiative, which save lives and improve health across the city. Immigrant New Yorkers are overburdened by mental health conditions, including from past traumas. Yet in the last year, we have seen a substantial increase in the detention of New Yorkers. In 2025 through mid-October, over 3,000 individuals were arrested by ICE in New York City. These detentions place our immigrant neighbors at risk of heightened harm. We urge the committee to think about the need for trauma-informed pre- and post-detention care, as well as programs that help to quickly reconnect released New Yorkers to health care. In the last year, NILPI provided comprehensive immigration and medical support screenings to 85 New Yorkers and direct representation to 60 community members with complex medical and immigration needs. With your support, NILPI Health Justice fought for our community by bringing to light the egregious health conditions at Orange County Jail, where many New Yorkers are held. A report, Denied Care, Denied Dignity, which we have shared with you today, documents the pervasive and life-threatening deficiencies in medical care at OCJ. Our medical providers network is seeing an increased need as well for psychological evaluations for New Yorkers in immigration detention. Mental health support is also critical for non-citizens detained by ICE upon their release from detention. We recently secured the release of 2 New Yorkers facing severe medical harm in detention. Back in community, both required urgent access to medical care. These individuals received this critical care through H&H and went through the program for survivors of torture at Bellevue. Outside of detention, confusion with healthcare navigation and fears of ICE enforcement are barriers to care. As healthcare advocates, we have worked tirelessly to establish access to healthcare and health insurance. We have also seen an uptick in people who are wrongly denied medical benefits or believe they no longer qualify for services. Thanks to NYC Care, many of these people are able to fill these gaps at H&H. As you continue to consider your funding allocations, we hope you'll consider the important connection between immigration status and health for all New Yorkers. Thank you for supporting our work and our clients. We look forward to continuing to work with you.
Thank you. Before we dismiss this panel, I just want to thank the folks that talked about their experiences and community. I'm somebody who lives with a mental health diagnosis. I'm also somebody with a disability. I know how important it is for me to have a tight-knit community of other people with mental health diagnoses, with disabilities, who are neurodivergent, whatever it might be, because oftentimes other folks don't get it. And also oftentimes, we're the ones that take care of each other because we get it. So I think it's a beautiful thing that there are these spaces where you can go to feel cared for, nurtured, get the services that you're seeking. So I just want to thank you again for coming out and testifying.
Thank you.
Yeah. Okay, the next panel. Hector Garcia, I think it says Garcia. Christina Abatista, Shlomit Levy, Sofina Tani, Tony Smith, and this just said, ex Nottage, is that right?
from ACT UP New York? Okay, all right. And sorry if I butchered any of your names. Yeah. Sorry, I mixed them all up. All right. Feel free to start.
Okay, sure. Hello. It's on. Good afternoon, Chair and members of the committee. My name is Hector Garcia, excuse me, and I am the Program Director for Lantern House Clubhouse. But I'm here also on behalf of Goodwill Industries of Greater New York, Northern New Jersey. Each year, Goodwill serves more than 30,000 New Yorkers, helping individuals overcome barriers to employment through workforce and behavioral health programs, including PROS and our mental health clubhouses. Today, I want to emphasize the importance of investing in community-based mental health services that support long-term recovery, not just crisis response. We serve individuals living with serious mental illness who often face homelessness, repeated hospitalization, and long-term unemployment. PROS and clubhouses work together to change that. PROS provides critical clinical and rehabilitative support, especially after hospitalization. Clubhouses provide a community-based environment where individuals build relationships, develop skills, and access employment opportunities. Together, they create a pathway from stabilization to independence. At Goodwill, our programs in Harlem, Astoria, and the Bronx serve hundreds of New Yorkers each year, helping individuals move from isolation toward connection, purpose, and work. But demand is growing and current funding does not fully cover the cost of these services. Without adequate investment, more individuals will cycle through emergency rooms, hospitals, and shelters, driving higher costs for the city. With the right investment, these programs reduce system strain and help New Yorkers achieve stability and workforce participation. We urge continued investment in PROS and clubhouse models as part of a comprehensive community-based mental health system. Chairperson Caban, we would also welcome the opportunity to host you and your team at our Astoria PROS program in Queens so you can see firsthand the impact these services have in your district. Thank you for your time and leadership.
Good evening. Thank you for being here, Chairs Caban, Schulman, Hanif, and thank you for the opportunity to testify. My name is Tony Smith. I'm the New York State Director at the Drug Policy Alliance. As we've heard today, overdose deaths are on the decline. And while our investments in care are working, we need to pay particular attention to where the crisis is still most acute. Overdose deaths among Black and Latino New Yorkers remain twice as high as white New Yorkers. The leading cause of pregnancy-associated death in the city is mental health conditions, which includes substance use disorder. And a concentration of these deaths occurred postpartum when parents are experiencing trauma related to separation from their infant. In recent years, New York City has embraced some practices that chip away at drug war conventions that create these types of harms. In 2020, health and hospitals began requiring providers to obtain informed consent before drug testing pregnant people and their newborns. This has contributed to a 37% drop in newborns removed by ACS while keeping parents with their newborns without negative impact on child safety. In 2021, the city authorized the opening of 2 overdose prevention centers operated by OnPoint NYC, one of the city's 15 syringe service programs. To date, these centers have provided a safe, non-stigmatizing space to individuals nearly 250,000 times. And this winter, these sites provided 24-hour shelter and safety to hundreds of people during the city's weather emergencies. These are powerful demonstrations of providing care instead of punishment. And the city is building on these successes. Last year, the city committed $4 million to site a drop-in space in the South Bronx. It's critical that this investment is fulfilled. In addition, the city should scale up harm reduction services in other geographic hotspots and other parts of the city where there is not service. Recently, the city launched an early childhood partnership between ACS and DOHMH. To keep families together, this program must not create a pipeline to ACS surveillance. Finally, DOHMH must be a key part of the city's coordination on issues related to substance use, including 911 and 311 calls, linkage to housing, and weather and other emergencies. We will provide more detail in our testimony, and we look forward to being in conversation with you all. Thank you.
Good evening, and thank you, Chairs Kaban, Schulman, and Hanif, as well as members of the committees, for the opportunity to testify today. My name is Christina Abatista, and I'm the policy analyst at Urban Pathways. We are a homeless services and supportive housing provider serving over 2,500 single adults annually. Since 2015, over 20 individuals have been killed by police officers while experiencing a mental health crisis in New York City. Traumatic encounters between police and people in crisis are not isolated incidents. They are the consequence of a failing public health system. Transforming our mental health crisis response system is essential to enhance community safety and refer people to long-term support, as opposed to crisis escalation, often resulting in serious harm and trauma. While we appreciate the city's attempts to shift crisis response to a more person-centered approach through the Be Heard program, there is much more that needs to be done for Be Heard to be a true public health response to mental health crises. Enacting the following changes will make that possible. Mandate that peers, people with lived mental health experience, be added to Be Heard teams. Peers bring indispensable firsthand knowledge, insights, and trust in the community that cannot be replicated. Expand the number of Be Heard teams to ensure citywide 24/7 coverage and to match the call volume. Establish 988 as the number to be dialed for mental health and substance use crises in place of 911 while ensuring coordination among 911, 988, and 311. And lastly, renew and expand the speaker budget initiative for the peer behavioral workforce from $4.5 to $6 million in fiscal year 2027, emphasizing peer positions in community-based mental health crisis response systems in the funding eligibility criteria. Thank you for the opportunity to testify. There's more details in my written testimony.
Good evening, Chairs Kaban, Hanif, and Schulman, and esteemed members of the committees. My name is Shlomit Levy, and I'm the Project Director for the Center for Justice Innovation's Brooklyn Mental Health Court and Felony ATI. Thank you for the opportunity to testify today. I will be speaking very quickly about CJI's court-based programs and community-based programs for adults and young people. Brooklyn Mental Health Court addresses both treatment needs and public safety concerns. Program success has been well documented with a reduction in rearrests for active participants. The court-involved youth mental health program provides specialized support for youth ages 18 to 24. The Strong Starts Court Initiative provides specialized support to infants, toddlers, and their families. This program has helped family preservation and a reduced likelihood of future abuse or neglect petitions. Funding will reach more families with improved outcomes for some of the most city's vulnerable children. The Midtown Community Justice Center's Community First program utilizes community navigators who offer peer support for clients to help clients achieve their identified goals. MCJC will seek to expand Community First to partner with NYPD and the city's new Department of Community Safety. The Empower Her Pathways to Justice program is a gender-responsive program for female ATI participants at the Staten Island Justice Center and Queens Community Justice Center. With funding, both centers will hire a case manager who will deliver trauma-informed and gender-specific programming. Bronx Community Solutions is seeking funding to cover the costs of DWI treatment and assessments for BCS participants and to fund the staffing of a DWI treatment coordinator so that BCS may continue to rapidly connect mandated participants to treatment. The Queens Community Justice Center piloted Uplift in 2022, a program that provides trauma and healing services to justice-involved young men of color. The Justice Center was able to fully implement and sustain the program thanks to the ongoing support of City Council. And finally, the Staten Island Justice Center is working in partnership with the DA's office to establish a Staten Island Community Justice Center modeled on other successful CJI sites. Almost done. The Justice Center seeks to expand these initiatives through the addition of a case manager, expanding focus on music, technology, and creative skill building, as well as their youth wellness initiative to provide support to court-involved youth and at-risk youth. Thank you.
Hello, and thank you. ACT UP New York stands with Councilmember Oze in making the following requests of the DOHMH free clinic system. Reopen the Crown Heights Clinic. At the Crown Heights Clinic provides sexual health services as well as COVID flu RSV PCR testing services. STI tests and COVID flu RSV tests use the same PCR machines that DOHMH has already purchased, and there is no other place in the city with or without insurance to get a COVID PCR test. We also ask that this clinic lead the way and become the first city-run health center to provide gender-affirming care to combat gaps in care due to cuts at the federal level. Additionally, we ask that all DOHMH sexual health clinics extend their hours to 8 a.m. to 8 p.m. Monday through Saturday to accommodate daytime workers and school-aged teens. Provide van services to immigrant neighborhoods who are avoiding health services due to targeting by ICE. Make the existing abortion hotline a transgender health navigation and abortion navigation hotline. Reopen the sexual health clinic in Staten Island. Provide proper staffing at all clinic locations. Right now, clinics are understaffed with lab technicians and intake staff and have to close early. Purchase the Manhattan Planned Parenthood that closed last year and turn it into a city-run sexual health clinic site to cover the gap in abortion and HIV care from this DOHMH service provider. Make PrEP continuity of care and medication abortion services available at all clinics. At COVID flu RSV PCR testing at least twice a week at all clinics. Finally, we ask that DOHMH generally rolls out a KN95 mask distribution program. KN95 masks, unlike surgical masks, are effective for the wearer even when those around them are not masking. But these masks are not available for purchase in New York, only online. Please provide free KN95 masks at your clinics, in subway stations, and at libraries. Even providing them for $1 each would be better than not having them at all. Thank you.
Thank you very much. Then I want to thank this panel. Appreciate your testimony. And I don't know if you saw earlier, I also echoed what Councilmember Osei said about the Crown Heights Clinic, and so we're gonna keep pressing DOHMH on their commitment to looking into that. Okay.
Thank you so much.
Thank you. Okay, next panel. All right, Lori is the first name, and I can't make out the last name. It's P-O-D, Potterer? I can't. From Include NYC? Lori, yes. I can't pronounce the last name. Starts with a P. P-O-D-Y-E. From Include NYC. No, okay. Alice Buffkin. Okay, left. Michael Schnall. Okay. Evie. I think she left. She left. Okay, I know Evie. Martha Neighbors. All right, we'll do the next panel. Carmen Garcio. Okay, we got one. Katie Mui, M-U-I, may not, okay. Sorry if I mispronounced it. Anita Kwok? No. Can't read it. I don't know if it's Annalisa Otero? No. What? Oh, yes? Okay, sorry about that. Okay, great. Nadia Chait? Oh, good. Okay. And Asada Turney? We'll just. Okay, go ahead.
Good evening, Chair Schulman, Chair Kaban, and Chair Hanif. I'm Nadia Chait. I'm the Senior Director of Policy and Advocacy at CASES. We serve over 12,000 New Yorkers annually with a holistic range of services to meet their needs in the community rather than in the carceral system. And I'd like to focus my testimony today on the need to double funding for the City Council's Court-Involved Youth Mental Health Initiative. This is a critical initiative that provides a range of services to young people who have justice involvement and mental health needs. Over 65% of young people in our juvenile justice system have a mental health challenge, and doubling funding would come at a critical time as we've seen the number of youth in detention in our city increase exponentially. So we're requesting $6.89 million in funding for FY27, and for cases specifically $260,000, which would maintain funding for our adolescent portable therapy program, which is an in-home and community-based service to help young people and their families who are struggling with mental health challenges and legal system involvement. And additional funding would allow us to add a supervising mental health clinician across all of our youth programs to enhance the quality of services, provide better training for our staff, and ensure that we are providing the best evidence-based supports. There are wait lists for a number of the Court-Involved Youth Mental Health Initiative programs, and so increasing the funding would really meet the needs in our community. We also stand with Chair Caban in calling for funding to eliminate the wait list for ACT and IMT. Cases has 9 ACT teams and 7 intensive mobile treatment teams. We strongly believe in those services. And lastly, we would like the city to consider funding to establish an outpatient competency restoration program. It's legally permitted in New York City, but rarely used. And instead, we see many folks with serious mental illness languish on Rikers Island while waiting for a state psychiatric bed. Thank you.
I'm sorry, next. Thank you very much.
Hi, everyone. I'm going to invite all of us to take a deep breath and maybe just stretch. It's been a long day. It seems like it's for everybody here. It's so good to be here with y'all. Good afternoon, Chairman Schulman, Caban, and Hanif. My name is Angelica Otero. I am here with the Coalition for Asian American Children and Families, longtime Queens resident, longtime organizer for justice. And I'm here today because I want to urge the council to include $4.5 million for Access Health NYC in the fiscal year 2027. Access Health NYC is a city council initiative supporting a network of 37 community-based organizations across all 5 boroughs that provide culturally responsive, language-accessible health education, outreach, and navigation services. These organizations help immigrant, limited English proficient, uninsured, LGBTQ+, and disabled New Yorkers access health care, public benefits, critical health information, regardless of immigration status. Through community events, educational workshops, and outreach in trusted spaces such as cultural centers, food pantries, mosques, churches, they reach residents who often face the greatest barriers to care. By helping residents access preventative care and coverage earlier, these organizations reduce emergency services and strengthen New York's public health infrastructure. Last year, Access Health NYC awardees facilitated 9,000 health referrals, 1,000 gender-based violence referrals, 4,500 referrals to social services. This year, the community groups are reporting a growing fear of misinformation in immigrant communities that are discouraging people from seeking health care and enrolling in benefits they are eligible for. The proposed Medicaid cuts, threats to language access resources, and increased immigration enforcement concerns are creating significant barriers to care. At the same time, we know that these community-based organizations remain the most trusted messengers for services, so we are urging you all to increase the funding to $4.5 million. That will strengthen the networks of these community-based organizations.
Thank you very much. Next.
Good afternoon, chairs and committee members. I'm Katie Mui, a social worker and policy and programs manager at The Network, a membership organization representing over 200 nonprofits that develop and operate supportive housing across the state. As you know, supportive housing is one of the most effective tools to ending homelessness and substantially improving the lives of those with mental health and substance use challenges. However, the model faces ongoing federal uncertainty, rising costs, and workforce challenges, placing increasing pressure on our providers. We are here today to discuss the need for targeted investments to preserve the city's existing supportive housing stock, advancing the goal of 1,300 units preserved by 2030 in alignment with the NYC 1515 reallocation plan, which the council has been in support of. Now it's time to put that plan into action. We are asking the city to invest $44 million in capital funding and $21.3 million in the expense budget to reserve 325 supportive housing units in this fiscal year. Our data shows that at least 7,600 units are prime for preservation, but are at significant risk of closure. Federal cuts to the continuum of care are imminent, meaning nonprofits will lose their operating subsidies for thousands of units, which will destabilize programs and displace tenants. By investing in preservation right now, the city can mitigate this loss. On the services side, the units that we've identified are operating contracts through NYSHIP HRA SRO support services. This is the lowest funded service contract in existence, with the base rate being only a fifth of the NYC 1515 service contract rate. Allowing nonprofits to claim the NYC 1515 rate will enable providers to deliver the level of care that is needed. The $44 million in capital funding will preserve at least 325 units that are 15 years old or older to complete necessary renovations. More information about these three funding pillars are included in my written testimony. Thank you.
Thank you so much. Next. Put your mic on.
Yes, thank you. Good afternoon, Chair Shulman, Caban, Hanif, and council members. My name is Carmen Garcia. I'm a community health worker supervisor at Make the Road, New York. On behalf of our 30,000 members, thank you so much for giving me the chance to share about our health access services for immigrant and working class New Yorkers. I'm here today to urge the council to continue and enhance funding for various health initiatives that support community health education and health navigation. These initiatives fund our health access services for New Yorkers severely impacted by federal cuts. These cuts are trying to deny basic services. We're helping immigrant New Yorkers navigate the changes in H.R. 1 and how this is impacting their benefit eligibility. We are reducing the fear and uncertainty with accurate information and culturally competent support. Our work includes health insurance and SNAP outreach, enrollment, navigation, referrals, wraparound services, and we also offer a community health worker training and a specialized health access for TG and CIQ New Yorkers. We request the council support for the following fiscal year 27 initiatives: enhance the Access Health Initiative to $4.5 million with $110,000 for Make the Road. This has helped us reach thousands of uninsured and underinsured people in Brooklyn, Queens, and Staten Island with peer-to-peer outreach and public education about options for healthcare access. We also connect people to resources to train future community health workers. We asked to maintain the MPAP program for $2 million and Make the Road funding at $82,000. We also want to ask you to renew $74,000 for Make the Road under HIV/AIDS Pathways to Care initiatives, maintain immigrant health initiative funding for supports or health insurance enrollment assistance and SNAP, and finally secure $300,000 under the Speakers Initiative for our wraparound legal health and educational services. Thank you for your support. Thank you.
Thank you very much, and I want to thank this panel. Appreciate it. Okay, next, Alex Blass. Gloria Myrie. Okay. Ashley Santiago. Oh. Crystal Scott, something Scott. I can't read the middle part. Yes, no? Okay. Aisha Gliot? Crystal Welsh is here? Oh, I'm sorry. Okay. Here. Aisha Gliot? Elliot? Sorry. Okay. Let's see, hold on a minute. Are you sure you want to start? Thanks. Put on the
Oh,
mic.
sorry.
That's all
Hello.
right.
My name is Aisha
Yes.
Elliott, and I am honored to be here today as the Chief Program Officer for the Women's Prison Association. It is one of the oldest and first organizations that support women before, during, and after their incarceration. I am also here as a woman who knows what it means to be more than the worst moment of your life. Before policy, before funding lines and agency reports, I want us to remember the women behind the numbers, behind the walls, behind the families, and behind our communities. A daughter who learned early that silence could hide pain, a woman who carries substance use in one hand and untreated trauma in the other like two heavy bags. Too often our systems only see the weight after it breaks something, but let's see them differently today. Substance use, being unhoused, and mental health struggles do not happen in isolation. They grow in the soil of trauma, in poverty, and violence survived but not healed, in systems that punish pain more quickly than they treat it. We have to remember that care is not charity. Care is infrastructure. Every dollar you invest in care returns in ways no ledger can fully measure. Not just the dollars saved in hospitals, courts, and jails, but the true return on investment is human well-being. When you fund, you're not just funding programs. What you're funding looks like stability, sounds like laughter, and feels like a woman waking up in her own space and believing she has a future worth protecting. Housing First clinical care and substance use services are not abstract policies. It is daily work for WPA, human work, and community work that can continue through the Justice Involved Supportive Housing Fund and through the Mental Health for Vulnerable Population initiatives. We want women to manifest the words of Luisa Tavares, and that is to create a life from which we do not want to escape. As a city, as leaders, as neighbors responsible for one another, our duty is not to respond when people fall. Our duty is to build the kind of systems that catch them when they do. When women, families, and communities heal, New York City becomes what it was always meant to be, a place where care is not the exception but the promise. Please support WPA in keeping that promise, and thank you very much.
Thank you very much.
Good evening, Chair Kavan, Chair Shulman, and Chair Hanif, and as well as committee members. Thank you so much for allowing me to testify today. My name is Ashley Santiago. I am the senior community organizer with Freedom Agenda, and we're one of the organizations leading the campaign to close Rikers Island. I'm also a native New Yorker and a resident of Queens. For the past 33 years, I've watched our city overly invest of systems in punishment like the Department of Correction instead of systems of healing and true rehabilitation. My 24-year-old nephew, Michael, who has been diagnosed with autism and disruptive mood dysregulation disorder, sat on Rikers Island for 2.5 years in dire need of mental health care and healing. Instead of getting that care and treatment that could have addressed the root causes of his behaviors, the real mental crisis that my nephew often experienced, of his behaviors, he was sent to Rikers Island. The real mental health crisis that my nephew often experienced there were labeled as tantrums by correctional officers who were not trained to respond to his clinical needs. At the cost of over $500,000 per year to keep someone in Rikers, New York City spent over $1 million to keep Michaels at Rikers. But despite all that money spent, he got no substantial rehabilitation or treatment. If anything, he came back to his community worse off. Coming from a low-income Latinx neighborhood in Queens created a lot of barriers to adequate treatment for my nephew, even though he struggled with mental health challenges from a young age. Without access to quality treatment, his symptoms became severe, which led to interactions with law enforcement and several psychiatric hospitalizations. After leaving Rikers living on Rikers for 2 years, my nephew was sent upstate, where he was subjected to spending his entire bid, 5 years, in solitary confinement and constant abuse from guards. He came home this year, and my family is facing the reality that his mental health has worsened, and the systems of support are so insufficient. This story is far too common. There are over 1,600 people right now on Rikers Island who are diagnosed with a serious mental illness, and that number has increased by 83% since 2022. And in the my written testimony, there's a full breakdown on where that money can be better spent. Thank you.
Appreciate that very much. Good.
Yes, good evening, everyone, and thank you for taking the time to allow me to testify today. My name is Crystal Welch Scott, and I am the clinical director for Getting Out, Staying Out. And We work with 16 to 24-year-olds who are incarcerated at Rikers Island and in other juvenile facilities, and those in the community who have been impacted by the criminal justice system or are at risk. GOSO's community-based education, anti-violence, mental health, job readiness, and paid internship programs have helped 15,000 young people overcome barriers and improve their quality of life. 93% of our participants are on a better path and do not experience incarceration. Young people are particularly vulnerable to becoming court-involved when exposed to factors such as housing and food instability, violence, and poverty at a young age, which can leave traumatic and lasting effects on mental health and quality of life. Incarceration is tied to post-traumatic stress disorder and is often linked to psychiatric conditions, including depression and anxiety. At GOSO, a team of clinicians provide clinical services, including individual, group, therapy, therapeutic case management, and holistic wraparound treatment. GOSO recently responded to increased needs for treatment of anxiety, depression, and PTSD by opening an in-house mental health clinic in partnership with the Child Center of New York. This allows us to provide robust services, including psychiatric care, which is also necessary for supportive housing placements. Additional funding through the City Council Court-Involved Youth Mental Health Initiative would ensure that organizations, including GOSO, could increase capacity to serve more young people. We are thankful to the City Council and administration for funding programs for court-involved individuals, but many services for this population remain chronically underfunded. It is essential to continue to fund the City Council violence prevention and intervention for youth and young adults and alternatives to incarceration and reentry initiatives. Thank you.
Thank you. Next.
Hello. We're both signed up to speak, but in the interest of time, we'll do a single 3-minute announcement. To my left is Department of Corrections retired Captain Gloria Murley of Rikers Island Cat Rescue, and I'm Mike Phillips, president and a co-founder of Urban Cat League, and I am proudly wearing a bright turquoise eye-ear-tipped New York t-shirt. At the Rikers Island Correctional Facility, there are over 300 cats. Free-roaming feral cat colonies spread all across the island. With money from their own pockets, for 30 years now, Department of Corrections volunteer employees feed the cats and have struggled to get the situation under control. 27 years ago, I chaired with Gloria a meeting with the Department of Corrections Commissioner to discuss addressing the situation. This is a very solvable situation. My group, Urban Cat League, has humanely reduced 2 very large colonies to 0 cats over 17 years using trap, neuter, return, and daily care and monitoring. 17 years to 0 cats. Meanwhile, at Rikers Island, 27 years after that first meeting with Department of Corrections, cats continue to be dumped on the island by employees with security clearance with no reprimand, and a cat population breeding unchecked despite ongoing efforts by employee cat volunteers. A languishing 10-year-old DOC-approved plan to bring the situation under control is now back in limbo until we can get the attention of the new administration's newly appointed Department of Corrections Commissioner. It's deja vu all over again for the 4th time. Rikers Department of Corrections serves, please 2 more minutes for Gloria. Rikers Department of Corrections serves at the pleasure of the Mayor of New York City, but no prior administration, nor the recently defunct Mayor's Office of Animal Welfare, would agree to intervene or to help motivate the Department of Corrections to complete the approved project. Outreach to 3 city council members became a circular dead end. Though physically in the Tiffany Caban Queens District, we were told that Rikers is technically in the Bronx and that in any case, the city council held no sway with Department of Corrections. Jesse Meyerson, Director of Communications for Tiffany Caban, did offer contact for 2 journalists he thought would be interested in the story. We were only asking that someone in the proper channels of city government be interested in the story. In conclusion, the Department of Corrections has approved electric hookup, plumbing, and even inmates program for the daily care of the cat population. $80,000 in private funding is waiting to outfit the already designated location for the operation. Even after finally getting a yes for the project, after 27 years of respectful negotiation with every branch of city government we could think of to approach, in the end, that yes is still a very disinterested maybe. Short of your help implementing the approved project, availability of ample spay-neuter services, rabies vaccinations, and the proposed food pantry would be a very big help. Thank you for your time.
Thank you all for listening, although I usually don't feel heard here. My name is Alex Brass. 2 months ago, on January 8th, I was triple handcuffed and the police were called for a mental health crisis. I was nonviolent. I was then injected with Haldol and benzodiazepine despite me being allergic to Haldol, which is in my chart, and was completely ignored. Somehow I managed to escape the hospital. 24 hours later, the 911 was called again because my mental health crisis was not helped at all, and I was only worse. Thankfully, Be Heard showed up, and I had quite a different experience from my first 3 experiences when the police showed up. That being said, I was brought back to CPEP, which I call the loony bin courtroom, where the next 3 weeks of my life is determined by a doctor who does not listen at all, to the point where I was given Narcan when I was not overdosing. I had the most uncomfortable 12 hours. We have one support and connection center in the entire city, and that's in Harlem. We had one in the Bronx. $50 million was invested into it, and it closed down within 2 years. I'm not quite sure why it's closed down, other than reading that certain metrics were not hit. We are at a point where we are turning people into numbers and spreadsheets. If we're gonna play the spreadsheet game, we've wasted hundreds of thousands of dollars on a friend of mine who's been sent to the loony bin 20 plus times. She's not offered any alternative care. If I was offered something like Project Renewal after my recent experience, things would be much different. However, from my understanding, Be Heard does, oh crap, I didn't get to any of this, but how many people are committing suicide after the hospital? Yes, we need to expand Be Heard, but if we don't have the proper support systems in place, if we don't have support and connection centers, and we don't have crisis stabilization centers, then we're gonna continue sending people to the hospital. 60% of people are still sent to the hospital under Be Heard, and 6% are sent to community-based care. So yes, we need to scale up, and if we don't have the proper supports, then we're set up for failure. Thank you.
Thank you very much. Really appreciate your testimony. Thank you to this panel.
Chair, if I may, just
Oh, I'm
very
sorry. Go ahead.
briefly, one, thank you for sharing your experience. I just want you to know that anything that you didn't get to, please submit it written, because it is going to be read in full. And your critiques of Be Heard are well heard.
Thank you.
Thank you.
Yes, and you
Thank
can
you for
send
your
it to
testimony.
testimony@council.nyc.gov, and you have 72 hours to do it. You have to do it today.
Okay, thank you so much.
Sure. Sheena Ansett, I may be pronouncing it incorrectly. Okay, that's her. Isaac Irizarry. Okay. Simca Ellis. Simca Ellis? No. Leave that there. Maddie Johnson. Patricia Green. There. Delmar. I'm sorry?
Patrice Green.
Oh, Patrice Green, I'm sorry. Sorry about that. And Delmore. Oh, okay.
And then maybe two more.
Hold on a minute. Alyssa Valentine. And Jamira Sepnas. Seppas. All right, go ahead. Who's, want to start from here?
Thank you, council members, for your infinite patience to listen to people for hours. I'm Maddie Samadar Johnson, a multilingual, multiracial woman who runs the community group Park Slope Cats and worked as an architect and urban planner. I've been rescuing animals for decades in New York and earlier in the several other countries I've lived or worked in. Independent rescuers like myself are beyond depleted, paying out of pocket, rescuing nonstop with no pay, doing the city's job for free from 7 a.m. to 2 a.m. It's never-ending, brutal, with no time for anything else, resolving innumerable pleas daily to help animals in distress. And it's cost us our physical, mental, emotional, and financial health. This is not just about animal rights, this is about our human rights too, to an extent. No, we are not all crazy cat ladies. We are ladies who rescue animals due to the compassion in our hearts and are getting driven crazy due to a lack of sustainable support. We cannot adopt or foster our way out of this crisis. We must stop it at its source. The only solution is city-funded, high-volume, low-cost or no-cost space neuters, access, education, enforcement. The four main barriers against spaying neutering: financial, cultural, inaccessibility, apathy. We need stronger enforcement against abuse, hoarding, neglect, and more obstacles, not more obstacles for rescuers. We need an army of citizen rescuers. Be the change, teach them young. In addition to other cases, in just the past 4 months, I successfully resolved 2 back-to-back hoarding cases in Park Slope, totaling 94 cats in deplorable conditions. Every single one of them has now been vetted, fixed, fostered, but for every single one we fix, there are hundreds on Facebook or Nextdoor posted daily, being given away free, unfixed, or being bred. This crisis is completely unsustainable. We need extensive citywide community and online outreach for spay and neuters. Mayor Mamdani, multilingual style. Kripaya sabhi billion aur kutton ki nasbandi kijiye. Apnara shob kukur ar beralder bandhyakoron koro. Sterilisez tous les chats et les chiens, s'il vous plaît.
Okay,
Por favor,
you need to wrap it up.
Gato e perros, just a minute. Kumbita kimi hayavun ki alifi gene de shongre ju je ye shoshu. Bada paltu pranione nasbande karo. Invest in low-cost spay neuter, pet pantries, empathy, action, education. Danke, shukriya. Merci.
Okay, thank you. Next.
Hi, good afternoon. My name's Isaac Irizarry. I'm the founder and director of Irizarry Animal Foundation. We rescue animals in the street. I'm gonna make this quick. I got animals to take care of. So yeah, we trap, neuter, return. We're feeding animals and helping elderly and disabled community within Bushwick and Williamsburg care for their animals. For example, if you broke your leg, I'll come through and help walk your dog, wash your dog. If you tell me there's cats in the street, I help cats, many colonies. All of this is coming out of my own hard-earned pocket, whether my job, other entrepreneurial endeavors. You heard a bunch of stuff here from our other rescuers, fellow rescuers. We're just looking for some money for $1.5 million for the TNR services and for the food bank. That's about it. Y'all got questions for me? All right, thank you so much. If you want to adopt an animal, Strays on Broadway on Instagram, IrizarryAnimalFoundation.org, and Instagram. That's it for me.
Thank you.
Thank you.
Thank you very much. Next. You gotta put your mic on, yeah. There you go.
Hi, council members. Thank you so much for having us. My name is Delmar Leon, founder of Canine Rescue NYC.
the only rescue who is also a top networker for both California and New York City Kill Shelter, focused on dogs who are euthanasia commanded and awaiting euthanasia with less than 24 hours to live. In the past year, I have split my time between California and New York City animals who need last-minute placement in order to save them before they get euthanized. As one of the only, if not the only, rescue and networker who focuses strictly on New York City ACC Youth Commanded, I have witnessed a failing animal shelter system and how they are treating our homeless or surrendered animals. They are being over-medicated, then mislabeled and placed as behavioral dogs to then be euthanized. Moreover, I have noticed one of the most crucial job openings of 2 veterinary roles that have not been filled since February of 2025, a role that pays $130,000 to $140,000 a year. Meanwhile, I wonder who is taking care of close to 300 dogs within 3 shelters. This year alone, they have killed close to 100 dogs. That is an entire shelter capacity, and we are only 2.5 months into the year. And in the past month, New York City Animal Care Center have returned 24 dogs who have been surrendered as owner reclaims, with only 6 adoptions since the year started. In the past couple of weeks, I have seen multiple animals being silent killed without giving them more than 2 weeks or 3 days. And 2 days ago, they silently killed one with only 24 hours since intake. What is the point of playing the role of a municipal shelter for New York City when they are unable to get them adopted and relying on their New Hope partner system, who can only pull a limited amount and has hit a bottleneck? And I believe it has also been a reason that dogs with fosters ready to help have been killed.
You need to.
I'm
sum
almost
it up.
done. There is no New Hope partner to pull. I am concerned as New York City ACC is planning to open a new location in Bronx and has still yet to reopen Brooklyn, and if we don't address these failing operational matters before that happens, our animals will continue suffering and more of them will get no chance to see the light of day once they enter ACC. New York has always been an example.
We gotta wrap it up.
Wrapping it up here of what other states and countries world look up to emulate, and we are.
You can't. I said to wrap it up. We submit testimony to us. Okay, thank you. Next.
Thank you, Chair Caban and members of the committee for holding this hearing on the FY27 preliminary budget as it relates to mental health, disabilities, and addiction. My name is Sheena Burnett. I am the Managing Director of Advocacy for Justice for Earth Peer Coalition and a steering committee member of CCIT NYC. I'm here today to testify about the need for substantial investments in the behavioral health continuum of care with an emphasis on employing peers, individuals with lived mental health experience to prevent crisis and other stability and offer stability post-crisis, including real investments in Be Heard. Erd Pierre, my beloved cousin, murdered by NYPD 4 years ago while experiencing a mental health crisis after calling 911, is why I continue to show up here, exposing my grief, my frustrations, and my purpose to honor his life and his legacy so he is not defined by how he was killed. When Rosario, King Wong, Michael Lynch, not limited to survivors like Jabez Chakrabarty, 22 years old, who is faced not only with more trauma and stigma, but criminal charges brought on by the Queens DA. Countless New Yorkers have been traumatized by inappropriate responses to mental health crisis calls. Since 2015, over 200 individuals have been killed by the police officers while experiencing a mental health crisis in New York City. The situation is dire and the system needs accountability, change, and transformation immediately. There is no bigger investment in this critical time we are in than investing in human lives. Invest in peers. Furthermore, expand the number of Be Heard teams to match the call volume, expand the number of Be Heard teams to ensure the citywide and 24/7 coverage, establish 988 as a number to be dialed for mental health and substance use crisis in lieu of 911 while ensuring interoperability among 988, 911, and 311. We also ask, like Jordan mentioned before, for the Committee on Mental Health, Addiction, Disabilities, jointly with the Committee on Workforce Development, must hold an oversight hearing this spring.
Thank you.
And I'll submit the rest. Thank you.
Thank you very
listening.
much. Okay, this panel is done. Thank you. Thank you very much. Okay, next, Marilyn Galfin, Jesus Garcia, Eves East, okie dokie. Ricky McGinty, Patricia Honey, and Tanya Copeland. Okay, we'll start with you. Yeah, just put on the mic. Oh, it is on? Okay, great. It has, you just push it.
Thank you all for still being here. My name is Ricky McGinty, and I am a caretaker of Community Cats. Last October, I met Leon, whose neighbor had a female cat he could not afford to get spayed, and when she had kittens, the neighbor put them on the street. Leon rescued 2 newborns and bottle raised them. When I met him, Mumu and Leonard were 5 months old, and I urged Leon to have them neutered soon. 3 weeks ago, I heard from Leon again, who had struck the same financial barriers as his neighbor. He could not afford to have the cats neutered or the ongoing costs of cat food, and he wanted my help to find a new home for the cats. Otherwise, he would have to surrender them to the ACC. One of the brothers had already started to mark his territory, meaning he was urinating around the apartment. Peeing outside of the litter box is the top reason cat owners abandon their pets. I immediately reached out to Flatbush Cats, which you allocated $500,000 for spay and neuter services in last year's budget, but they were swamped with surgeries delayed to the blizzard. After a week of networking, I found an affordable option, and Mumu and Leonard were neutered this Tuesday. Rescuing cats no longer applies only to cats living homeless in our neighborhoods, but also to the cats in our homes. To reduce the misery on the street and to keep our pets safe, we need affordable spay-neuter services and pet food pantries. These solutions work together. We need them both to address the dire situation of cats and rescuers.
Thank you very much.
Thank you.
Next.
Good job.
Oh, give her the mic.
Oh, yes.
Hi, my name is Patricia Honey, and for the past 6 years, I've rescued hundreds of strays off of our streets year after year. What you're looking at in this room is not a group of helpless constituents. It is the safety net of New York City's animal welfare. Up until now, you've had us as somewhat of a stopgap system, but this system is collapsing. New Yorkers can't donate like they used to. The stray population is exploding now as the cost of living's become unbearable for pet owners. This crisis has broken us, and the only way through now is with you by our side. Recently, I was urged by fellow rescuers to step in where they could not find a way past someone intentionally starving cats. The cats had been locked in a basement for nearly 2 months without food on purpose. Granted, I'm trained in gaining compliance, but why was I the best option? Within 20 minutes, all documented, she was giving me a full tour. I'll save you a lot of time, but I had to step over plenty of half-eaten corpses everywhere. The abuser laughed because the police had been called 3 times, and each time they took 2 steps in and walked back out. Sadly, it's no coincidence that through all of my own calls to the police, watching them consult the ASPCA, I've only come to know more than I could ever dread knowing about that 2-step, and the true song this system dances to. Justice for animal cruelty currently feels hopeless, so please empower us. to spay and neuter the majority of this issue away. Leave your mark on this city. Put your name on the grants. Let us thank you every day on social media all year. I'm begging you, fund spay and neuter fully this time. Audit the ASPCA.
Go ahead.
Roll over the NYPD, and we will take care of the rest. Thank you.
Thank you very much. Next.
Good evening to all Health Committee members, and thank you for being here so late and for this opportunity to speak. My name is Jesus Garcia, and I live in the Upper East Side. I feel like I'm in a bit of an odd member here speaking today because I'm speaking on behalf of two serious issues which kind of counter all the testimonials that I've heard today, or at least a majority of them. They have to do with issues that affect public health, and nothing has been done about them. Issue number one, New York City's health code prohibits live animals in food establishments. But despite that, we see dogs in every restaurant and food market that I've experienced. This is primarily due to the overpopulation of dogs since COVID. Dog owners feel entitled to bring their pets inside because there's really no enforcement and no accountability. These dog owners claim that the dogs are service dogs. This is eminently and inherently false. There is overwhelming evidence. I have both videos and photos showing their behavior not depicting that of a legitimate service dog. They not only are committing fraud, they are also knowingly violating the city's health code and taking full advantage of the lack of enforcement. Okay. Due to the loophole in the ADA law, there's really no credible way to distinguish a fraudulent service dog from a legitimate one. And despite no pet signs, dog owners bring their dogs inside, and business owners can't do anything or say anything for fear of litigation. This situation is out of control.
You just have to wrap up. And
I
you can
urge the
submit
committee
rest of it.
to, I'm not asking for budget or increase, I'm just urging for them to take
Enforcement.
the health code and enforce it.
Okay, thank you. Next.
Marilyn Galfin, Voices for, excuse me. Think I have to start over, wait. Go on and come back.
All right.
I lost my
Go
voice.
ahead.
Hello, I'm not from the Upper West Side. My name is Eves. I'm from Brooklyn, New York, born in Flatbush. Thank you so much for taking the time to hear me out today. I've been rescuing and fostering pit bulls here in New York for over 13 years, working at and with and through the NYC ACC. Including pet food pantries and also filling pantries will cost less than building an entirely new infrastructure. We live in a city, a world, and a time where pets are people's families, and it's no secret that certain pets are not allowed in certain neighborhoods and homes. Breed restrictions are directly connected to discrimination to certain people, and this causes people to despondently choose between their pets and their homes. For a lot of people, their home is wherever their pets are, and since we can't rectify that situation yet, the least that we can do is provide food for these pantries to at least help people feed their pets, because to show up for our community is to show up for ourselves. Thank you for listening to me today.
Thank you. Okay, want to go back to you now, or you good? Okay.
Marilyn Galfin, Voices for Shelter Animals. New York City Animal Care Centers reported 692 dogs, 863 cats euthanized in 2025. The actual number may be higher, as these figures may not fully reflect all outcomes. 36 dogs that we know of so far have already been killed in the last 2.5 weeks. Today, there were 23 dogs and 14 cats on the at-risk list, and some may have been destroyed already. I asked if the Health Committee can push for a temporary halt on euthanasia at ACC unless an animal is irremediably suffering or severely dangerous, create a task force to address this crisis, and put emergency protocols in place. We need an oversight hearing to ensure accountability and transparency. And I urge the Health Committee to contact ACC and encourage life-saving policy changes, such as making bios that actually make the animals look adoptable and updating emergency placement outcomes lists so advocates aren't promoting dead dogs. I urge this committee, and if they're not willing, we must codify these protections into law. We need immediate oversight of shelter operations by an independent third party, such things as monitoring drug use on the animals. It's a moral responsibility of the city to protect shelter animals. We must end the cycle of healthy, adoptable, treatable animals entering the shelter, receiving inadequate care, inhumane conditions, and having their lives needlessly taken. And shelter animals are not disposable commodities. With the $127 billion proposed city budget and ask of $15 million, just over 0.01% for animal welfare and prevention can reduce shelter intake, save lives, save money for the city in the future, and help people keep their beloved pets, who for many are family. In addition to funding for spay and neuter, affordable vet care, pet food, we need mandatory microchipping, humane education grants, hoarding awareness intervention, and the creation of an animal protection and emergency unit that would replace the police, animal response duties, and a task force to address animal abandonment and enforce animal laws. Animal welfare is not just a moral issue, it's a social justice issue. We must protect and preserve life. It is time for the government to show compassion, act with compassion, and make animal welfare a real priority and invest in it.
Thank you. Were you going to speak?
Yeah.
Oh.
Hi, I'm Tanya Copeland. I run an organization, a trap, neuter, return organization called Bronx Community Cats. Since 2020, we've fixed over 5,300 cats in the Bronx, but today I'm here as a Bronx resident, a pet owner, and also a volunteer for two other organizations. One is Positive Tales, and one is Bronx Dog Haven. We partner with them to provide wellness and vaccination services, as well as a large pet food pantry in the South Bronx. Back in December, after the big snowfall, we had 200 families show up with their pets in the freezing cold, waiting for pet food. And one thing I want to underscore to the council is that these people are not relying on the pet pantries as their sole source of pet food. Rather, this is supplemental, and they're hardworking people, hardworking families, and they're trying to make ends meet. And so, you know, this is a noticeable service gap that can be just very easily addressed by allocating funds in the 2027 budget. The other thing I wanted to mention is that a disproportionate number of cats that are, or animals really, surrendered to our municipal shelter are from the Bronx. And so any investment into prevention of surrender, we're already paying for it. So why not divert the funds to prevent people from surrendering their animals and keeping families together? Thank you.
Thank you very much. I want to, you're done, right? Yeah, you're good.
Yeah, I was just saying thanks.
You're good.
Yeah.
That's fine.
Yeah.
I want to thank this panel.
I had a question.
Thank you. Oh, I'm sorry. I forgot. Chair Hanif wants to ask a question.
Thank you.
Of the panel.
I have a question for you about dogs in restaurants and establishments. Could you just speak a little bit more about where you're seeing dogs inside establishments?
Pretty much every restaurant that I've been to.
And this is
in the Upper East Side and pretty much throughout the city. It's noticeable. I mean, I've been to restaurants, I've asked the management. They don't bother, there's an apathy with management because they fear litigation. The way the law is structured, nobody wants to take the chance. I'm a previous dog owner.
I mean, have you tried 311? I'm just trying to understand because I know dogs are allowed for some restaurants who are participating in outdoor dining. And that's different.
Yeah, and that's not outdoor dining. I'm talking specifically about indoor dining. It's a health concern. The health code is very specific about this. And they're breaking this left and right. It has nothing to do with any kind of animosity towards, again, I'm a I had a dog. I would never think of bringing it into a restaurant.
I mean, it's the first I'm hearing it, so I wanted to just get some more details.
I've been
I look forward to your
I've been complaining to the health department, and all I get was, your order has been closed. Thank you very much. So I hope that they take this seriously. It's an obvious health concern. I don't really need to go into, but it's concerning, and it's getting out of hand.
Thank you.
Thank you.
I want to thank the panel. Thank you very much.
you.
Thank you, Lynn.
Okay, so we have one more in-person panel to call. Andrew Levin. So, Sanja Chai? Michael Phillips? Jean Bubley? No? Okay. Wait.
She's coming.
Oh, she's coming. Sorry.
So, which one was not here? I think this one, maybe. Yeah, we'll see. And then if you maybe just do a call for names, if anyone wants to testify, they need to fill out an application.
Okay. Should I do that now? Yeah. If there's anyone here who hasn't filled out one of these cards and still needs to testify, please see one of the sergeants, and they'll have you fill it out. Okay, go ahead.
Thank you so much. My name is Sonia Chai. I'm Managing Director of Brooklyn Bridge Animal Welfare Coalition.
Okay.
We own and operate Brooklyn Cat Cafe and BBAWC Rescue Clinic. Keeping companion animals has proven to be incredibly beneficial to the mental, physical, and emotional health of their owners. But it's become a privilege to provide species and nutritionally appropriate food for pets. It's become a privilege to be able to spay or neuter your pet, and it has therefore become a privilege to own a pet at all. We looked at our organization's pet food purchases dating back to March 2019. Across a selection of the most affordable and widely available cat foods on the market, we found on average a 62% increase in prices between 2019 and 2026. That rate of increase outpaces that of human food, which grew 33% over the same time period, according to the Consumer Price Index, and a 21% increase in median rent in New York City, according to StreetEasy. Meanwhile, wages have remained stagnant and public assistance benefits have been reduced. Spay-neuter is also fundamental to keeping pets and their owners healthy and in their homes for the long run, yet affordable surgery appointments are virtually non-existent in New York City. We have conducted free community vet clinics and met many people who have waited months or even years for affordable spay-neuter appointments, while stressing over the risk of losing their homes because of complaints from neighbors or landlords regarding their intact pets' nuisance behaviors such as fighting, marking, or spraying. Also, spayed and neutered cats and dogs simply live longer, healthier lives. When people are better able to keep their pets, cats and dogs healthy as long as they can, they are better able to reap the benefits of sharing their life with a pet. They're less likely to need to surrender or abandon their animals to an already overburdened shelter and rescue system or to a dangerous life on the streets. This is why we strongly support measures to help make both pet food and spay-neuter more accessible and affordable. Thank you.
Thank you very much. Next.
Hi, my name is Ann Levin. I'm the Executive Director of Brooklyn Bridge Animal Welfare Coalition, which runs Brooklyn Cat Cafe and the BBAWC Rescue Clinic. Accessible and affordable spay and neuter surgeries are fundamentally important to solving the homeless cat crisis in New York City and ensuring pet ownership remains accessible to all New Yorkers and not a privilege only available to the wealthy. Our organization, BBAWC, operates a low-cost rescue clinic that proves that making low-cost and free spay-neuter widely available can be achieved both quickly and affordably. Since completing our first surgery in 2021, our low-cost clinic has spayed and neutered over 15,000 cats. Many of these procedures have been offered for free to rescuers or for as low as $40 for a neuter and $60 for a spay to pet owners. There is no significant waiting period. Clients are almost always able to obtain an appointment within a month. Each surgery also includes other important care such as parasite treatment, vaccines, and a microchip at no additional cost. We designed our clinic model to be replicable by other organizations and critically scalable for New York City's homeless cat crisis. We were able to fully furnish our spay-neuter suite in under 6 months with a startup grant of around $100,000. Our rescue clinic broke even in under 3 months and continues to do so today, even while we have kept the cost of our surgeries well under $200 for most of our clients. To put that in perspective, it would cost about $1,000 to $2,000 to obtain the same services from a private vet in New York City today. On an individual level, this basic veterinary care has ensured healthier and longer lives for each of the cats that have come through our doors. From a systemic view, the speed, affordable startup cost, and ongoing economic viability of BBAWC Rescue Clinic demonstrates a feasible and scalable solution to New York City's homeless animal crisis, the urgency and magnitude of which worsens by the day. Thank you.
Thank you. Next.
Thank you for the opportunity to speak today. My name is Jean Bubley, and I'm a member of the cat rescue community. The city's cat crisis is undeniable. Sadly, the city has done very little to address the issue. The only people out in the field tackling the problem are private citizen volunteers. They spend their free time trapping cats, and they spend their own money to spay and neuter them. And what do they get for their efforts? They get whopping vet bills, they get divorces, and they get nasty messages from people who think they aren't doing enough. To make matters worse, they have to compete with each other for the scarce, low-cost spay and neuter slots. Despite their heroic efforts, rescuers cannot stem the tide because new unaltered cats keep showing up and reproducing. These are dumped cats, indoor-outdoor pets, and indoor-outdoor store cats. What can the City Council do? Well, there are two things that would have an immediate impact. One is to triple the funding for low-cost spay-neuter surgeries to $1.5 million. The second thing is pet food pantries to help prevent people from surrendering or abandoning their pets due to financial hardships. As helpful as these measures would be, they are not enough by themselves. We need to educate people about spaying and neutering. We need more affordable housing that allows pets. We need legislation and social services to deal with animal hoarding cases. We need affordable veterinary care beyond spay and neuter. In short, we need a separate Department of Animal Welfare to address these complex issues. I hope this will be a high priority topic for the new Animal Welfare Committee. Meanwhile, increasing funding for low-cost, high-volume spay-neuter surgeries and funding pet food pantries would be an excellent start. Thank you for your time.
Thank you very much. I want to thank the panel. Okay, so I'm going to call a list of names of people that we called before that signed up but didn't answer, so we want to see if you're here. If you're not, then we'll move on to virtual. Michael Phillips. Isaac Irizarry. Patrice Green. Simca Ellis. Jamal Sepfas. Allison Valentine. Sofina Tani. Angel Hernandez. Faith Beham. Casey Starr. Fiorina O'Grady. Kamari Cruz. Elaine LaPena. Omar Cow. Lori from Include NYC, Alice Buffkin, Michael Schnall, Evie Hansapoulos, Martha Neighbors, Anita Kwok, Asada Terry. Okay, so these people are not here. Now we're going to go to virtual. We will now move to virtual testimony. Everyone who's virtual will have 2 minutes to testify, and only 2 minutes. If you have longer testimony, please submit it online at testimony@council.nyc.gov. Please wait for the Sergeant at Arms to prompt you before you begin your testimony. Oh, that's for me, sorry. All right, so the first one is Molly Senek.
You may begin.
Let's see.
Good evening. Thank you so much for allowing me to testify today. My name is Molly Senek. I am the Education and Employment Community Organizer at Center for Independence of the Disabled New York. There are nearly 2 million adults with disabilities living in New York City. I know that that number is a little bit higher than what MOPED typically says, and what the American Community Survey says. These numbers are directly from the CEC and from the New York State Department of Health. Yet despite the fact that people with disabilities make up almost a quarter of the population of New York City, the office that is designed to serve that population currently receives less than $1 million in city funding. This is obviously not sufficient funding to adequately address the numerous interconnected barriers that people with disabilities face in their daily lives. More information on what those barriers are included in the written testimony that I have already submitted, specifically as they relate to education, employment, transportation, voting, healthcare, mental health care, housing, and climate change. But as I said, we're looking at 2 million people, and there are a number of budget asks that we would like the council to uplift to address some of these issues, including baselining the mental health continuum, adding an additional $450 million for school accessibility projects in the capital plan, expanding New York City Outwork to double its staff from 6 to 12, and increasing investments in accessible voter technology. However, we would also like to acknowledge that having an office whose primary purpose is to address these interconnected barriers, specifically looking at disability as its primary focus, is key. And to this end, we ask that the city fund MOPED for $10 million, which I know it sounds like a large number, but only in comparison with its current funding
Time expired.
level. Thank you.
Let her finish up. Thank you.
Thank you. Just in comparison with its current funding levels, which are insufficient, not in comparison with the population it serves. Thank you so much.
Thank you so much. All right, next is Dawn Euster.
You may begin.
I'm Dawn Euster, a staff attorney in the Legal Aid Society's Education Advocacy Project. The Legal Aid Society thanks Chair Shulman, Caban, and Hanif for the opportunity to testify, and for the City Council's zealous advocacy for investments in school-based mental health services and behavioral supports in New York City public schools. The Legal Aid Society is deeply concerned about the enduring mental health crisis facing children and youth based on our experience as New York City's largest law firm, working with thousands of children and youth each year who have significant mental health challenges and who have been unable to access the mental health services they need to be successful in school and in life. Studies have shown that young people are much more likely to seek mental health services when they are accessible in school, and that these services are associated with increased attendance and academic achievement and can help reduce racial disparities in access to care. Yet far too many of our schools are inadequately resourced and unnecessarily routing students with mental health and behavioral needs to 911, emergency medical services, and hospital psychiatric emergency rooms, invoking NYPD school safety agents and police on student behavior, and resorting to suspensions. The harm disproportionately impacts Black and Brown students, students with disabilities, and students who are homeless or in the foster system, and has been linked with lower educational attainment and higher odds of future contact with the juvenile or criminal legal system. It is vital that the city prioritizes the creation and funding of a comprehensive, integrated system of school and community-based mental health and behavioral supports with cross-agency collaboration to support students in schools, prevent emotional crisis by addressing the root causes of student behavior, and respond to crises using trauma-informed, culturally responsive approaches. Finally, we urge the City Council to work with the new administration to ensure the fiscal year 2027 budget extends and baselines $5 million for the mental health continuum, extends, expands, and baselines $12 million for restorative practices in schools, invests in baseline.
Time expired.
$8 million.
Just,
Almost
just
done.
summarize the rest of it and then submit the
Sure.
testimony.
$8 million for behavioral specialists in each school district and invests in baselines funding necessary to create school-based mental health clinics, therapeutic school day treatment programs, and also necessary to expand Be Heard 24/7 citywide, adding peers and establishing 988 as the phone number for mental health crises in lieu of 911. Thank you so much.
Thank you very much. Okay. Next is Edmund Loy.
You may begin.
Thank you. Good evening, Chair Shulman, Kaban, and Hanif. Thank you for staying so late to listen to public testimony. My name is Edmund Loy, and I'm testifying on behalf of the Charles B. Wong Community Health Center. We are a federally qualified health center with locations in Chinatown and Flushing. In 2024, we served 65,000 patients, 77% of whom were limited English proficient, 83% of whom had household incomes at or below 200% of the federal poverty level, and 60% who were uninsured or were on Medicaid. Our health center and many healthcare organizations around the country are facing cuts, funding cuts, but remain open to serve the community. This is only possible in part because of support from City Council discretionary funding. I'm testifying today to ask for continued support for several initiatives so that we can continue to serve vulnerable New Yorkers. The Check Hep B program under the Viral Hepatitis Initiative provides culturally and linguistically competent health education, patient navigation, and care management services for New York City residents with chronic hepatitis B. New York City alone, an estimated 255,000 people are living with hepatitis B in 2023. At CBWCHC, 1 in 10 adult patients have chronic hepatitis B. If left unmonitored or untreated, hepatitis B can severely damage the liver, potentially causing liver failure, liver cancer, or even death. The Check Hep B program has a strong record of success with 97% of participants completing a hepatitis B medical evaluation through this program. Through Access Health, we provide education to the Asian American community about health insurance coverage, aiming to increase vulnerable New Yorkers' access to healthcare services. And lastly, through the Cancer Services Initiative, we increase awareness of risk factors, symptoms, and treatment options for breast and colorectal cancers. City Council's continued support would ensure cancer screening access through patient navigation for several hundred members of the Chinese American community, many of whom are uninsured and face numerous barriers to healthcare. With continued funding and resources, our initiatives can continue to address the health disparities and inequities experienced by the communities that we serve. Thank you for your time and for the opportunity to testify today. I'm happy to answer any questions that you may have.
Thank you very much. Next is Ella Grace.
You may begin.
Hello, good evening. Thank you all so much for staying so late and listening to public testimony. My name is Ella Grace, or E.G. Downs. I'm a social worker and the Deputy Director of Policy and Advocacy at Girls for Gender Equity. GGE is a small Black, queer, immigrant-led social work-centered nonprofit doing racial, gender, and sexuality justice work in today's hostile world. And the funding we receive is imperative to the development and growth of Black girls and gender-expansive youth of color across NYC. We request continued support from City Council for our FY27 youth programming so that GGE may continue to address the mental health needs of young people across all 5 boroughs. The political environment, including lack of accountability for perpetrators in Epstein files and the continual presence of ICE in our communities, is impacting the mental health of youth that attend our programs. Young people feel powerless, which our staff has responded to by shifting program curricula, increasing one-on-ones, updating safety protocols, and developing a new political education initiative to re-empower the youth. This is the Alliance on Gender Equity, or AGE, and we're requesting $300,000 in the form of a new City Council initiative to sustain this work. It's a youth-led space for civic engagement, leadership development, and community building. Last November, we held a town hall with over 70 young people from all 5 boroughs, where we heard from them in 6 priority areas with issues coming up that are of direct interest to this committee, specifically a demand for more student mental health and wellness centers and resources. GGE is doing this work despite financial constraints, and we hope to continue equipping young Black girls, queer, and gender-expansive youth with the tools they need to fight for an NYC that is resilient against harmful national forces working against them, and to provide social work-informed and trauma-informed mental health care. We're requesting 350,000 from the YWLD.
Time
for our
expired.
political education.
Just summarize the end of it.
Yes, just and 200,000 for our survivorship program from Dove, 100,000 from STARS, and 250,000 from ATI for our restorative justice initiatives. Thank you all so much.
Thank you, and if you have extended testimony, you could submit it online, so, because we look through all of it, all right?
Absolutely.
Great, thank you so much. Okay, next is Glenn Belofsky.
You may begin.
Thank you. Good afternoon, good evening, everyone, and
Hey,
thank
Glenn.
you again for the opportunity to be here. Good evening. Nice to see you again, Chair Schulman, and nice to meet you, Chair Caban and Chair Hanif. I wish you all good luck in this next 4 years with much success. It's interesting to me to listen all day to everybody's needs for budgeting. That's what this hearing is about. I'm here to say we know where the money is. We're giving it away to Amazon. We're giving it away to FedEx. Over $750 million through 2018. May I quickly share my screen to show the IBO report?
No, we can't, we're not allowed to do that. If
Okay.
you want to, if you
Yeah,
want to copy it and submit it in submitted testimony, you can do that.
Thank you. Yes, I already sent it to your staff,
Okay.
Chair Schulman. And yesterday I provided it to the Transportation Committee and to Finance, to Linda Lee, and to Sean yesterday. So the New York City Department of Finance created a stipulated fine program under Mike Bloomberg in 2001. The City Council got a bill in 2007, 0637, and tabled it because they didn't want to give any money to FedEx, UPS when we need the money. But the City of New York Department of Finance didn't care what our elected officials had to say, went away with it, ran away with that program anyway. And for all these years, it's been now over $1 billion in discounts. Out of that $1 billion is $50 million that's supposed to go to court justice funds under Vehicle and Traffic Law 1809A of the New York State Vehicle and Traffic Law. Imagine we've given away tens of millions of dollars in discounts to Amazon for illegal double parking in Steinway Street, Astoria Boulevard, Queens Boulevard, throughout Brooklyn and Manhattan and all boroughs. It's insane. In 2018, 1141, 2018.
Time
almost
expired.
passed.
Right,
We
Glenn,
have
you need to
39
wrap it up.
members on the bill. Thank you so much. 39 members on that bill, and we're trying to get with the speaker to have her move it in this session.
Thank you
all
so
very
much. Thanks. Okay, next is Jane Nee.
You may begin.
Good evening, chairs and council members. My name is Jane Nee, and I'm the Assistant Director of Policy on behalf of the Community Healthcare Association of New York State Chicanes, representing all of New York's health centers. Thank you for the opportunity to testify. In New York City, health centers serve more than 1.3 million patients at more than 460 sites, including mobile sites and school-based health centers, providing essential primary and preventive care to all, no matter their insurance status or ability to pay. Today, we are here to ask for your help. Health centers are facing their most severe crisis in decades. These are the challenges: a healthcare system that doesn't invest in primary care. Only 5 to 7% of healthcare spending goes to primary care, despite accounting for a third of all healthcare visits. An outdated Medicaid reimbursement system that pays health centers only 70 cents on the dollar because of reimbursement rates set more than 25 years ago. Rates that don't account for today's inflation, costs, and workforce. Already, health centers have had to close sites, forced to cut services, unable to recruit and retain providers. And now, because of HR 1, New York City health centers are at risk of losing $224 million in revenue annually, and the number of uninsured patients are expected to triple, from more than 181,000 right now to over 503,000, a 178% increase. And critical services like school-based health centers, urgent and same-day care are at risk. And so we urgently need your support. We are asking that you invest in community health centers to push the implementation of New York City Care Program Expansion, INT 16688A, passed by the council in 2021 to ensure health centers can continue care for the uninsured, to create a stable funding model for school-based health centers, and to support and expand initiatives that will strengthen the healthcare workforce. More details are in our written testimony. And so, if we fail to act, the consequences will be felt across the city. Our patients are really counting on us.
Time expired.
Just summarize the end and then submit the rest of the testimony to us.
Oh, that was the end of the testimony.
Oh, okay. Thank you very much. Okay, next is Jesse Taylor.
You may begin.
It was not letting me unmute myself. Sorry for that. Blessings to you all, and thank you for
You're
your
good.
time.
You're good now. We can hear you.
Okay, great. I'm Jesse. I'm a member of Freedom Agenda, and I'll get right into it. Mayor Mamdani needs to live up to the commitments he made during his campaign, and our city budget must include intentional, increased investment in community resources that center the well-being, safety, and civil liberties of New Yorkers, particularly criminalized, marginalized, and chronically neglected New Yorkers who are not only the most often deprived of the resources needed to survive, but are also the most often exiled to toxic, violent carceral spaces that exacerbate existing health issues brought on by conditions of structural injustice. Conditions that can be improved, fundamentally changed, and prevented with the help of intentional investment in community resources that center the well-being, safety, and civil liberties of New Yorkers. As our mayor said, every New Yorker deserves to be safe, including captive New Yorkers on Rikers Island. Rikers is an environmental sacrifice zone and site of torture and abuse built on a toxic landfill that negatively impacts the physical and mental health of the captives forced to suffer there, over 60% of whom are only there because they can't afford bail. Further, our city spends nearly $500,000 per year to incarcerate just one person on Rikers. Given the countless studies and reports that detail how investment in community programs, mental health resources, and reentry services reduces recidivism and enhances community safety, reallocating funds to meet those needs is a crucial step toward keeping every New Yorker safe. Like $11 million more to eliminate the wait list for intensive mobile treatment teams, $3 million in capital funds to support 60 new residential treatment beds, and $3.5 million to open more crisis respite centers. Additionally, as our mayor said, if we want young New Yorkers to chase their dreams here, we have to make it clear that their struggles are not just their own. Our city budget must ensure that young New Yorkers, our children, are met with love and support in times of crises instead of torture, abuse, and systemic neglect. Ending solitary confinement for child captives is not enough. Mental health care, literacy, and arts programs for our children must be prioritized and well-funded in our budget. So must non-punitive alternatives to incarceration programs and initiatives that ensure our children are housed, fed, and held.
Time expired.
Just summarize the rest of it, please.
Let's stop manufacturing preventable disasters that cause mass harm. And yeah, keep New Yorkers safe, and I'll share the rest in written testimony.
Great, thank you so much. All right, next person is Kathleen Collins.
You may begin.
Sorry to keep you waiting. Thank you, Chairs. And my name is Kathleen Collins. I'm a disabled New Yorker, and I'm the treasurer of Disabled in Action, so I understand money. The Mayor's Office for People with Disabilities is chronically underfunded, and it shows. While New York's budget tops $150 billion, the Mayor's Office for People with Disabilities funding has not kept pace with inflation, rising costs, or a growing disability population. That's not just underfunding, it's invisibility. The Mayor's Office for People with Disability needs adequate funding to ensure accessibility is built into every city policy and project. Without adequate resources, however, accessibility becomes an afterthought. The failure at Hunters Point Library makes that painfully clear. We must invest differently. Fund the Mayor's Office for People with Disabilities to act proactively at the start of planning, not after mistakes occur. Investing in accessibility is a necessary commitment to ensuring a fully inclusive city where no New Yorker is left behind. A significant budget increase for the Mayor's Office for People with Disabilities is essential for proactive planning and economic fairness. Please do that. We definitely need more funding. It's dismal that it's less than $1 million for this office, and so many people need it, and it has to do so much work. I can't believe how it even gets all it does with the little budget it has and the very tiny staff. Thank you.
Thank you very much. Next person is Lauren Pack.
You may begin.
Hi, everybody. Thank you for taking the time to be here tonight.
very late. My name is Lauren Pack. I'm the Director of Health Homes and Non-Medicaid Care Coordination Services at JCCA. I'm a social worker and I've been at JCCA for 14 years. JCCA is a child and family services agency that works with about 17,000 of New York State's children and families each year. We provide a continuum of behavioral and mental health programs in New York City, which are listed out in our written testimony. Thank you to the City Council for funding our court-involved youth mental health initiative, which provides counseling to youth who are court-involved or at risk of court involvement. This program is so successful that we consistently have a wait list and aim to expand the program to serve more at-risk youth. Thank you for also funding our opioid treatment and prevention initiative that provides counseling to youth facing or at risk of an opioid addiction. The young people and families we meet at JCCA face seemingly insurmountable obstacles. Children are enrolling into our programs with high acuity needs, presenting with increased anxiety, depression, and anger. Many of these youth are diagnosed with intellectual and developmental disabilities with co-occurring mental health diagnoses such as major depressive disorder and anxiety, and require more intensive supports like Youth Act, HBCI, community residences, and day treatment programs. At JCCA, we aim to provide youth with high quality treatment, but we face the same workforce challenges as other human services agencies. Low reimbursement rates and high caseloads have caused significant staffing challenges. We routinely have wait lists for our programs, and we are unable to serve many of these children due to our staff shortages. We experience high turnover, resulting in youth losing continuity of care. The current mental health system needs reform to better serve our young people, and we're recommending that we provide investment in the current mental health system, support diverse work enforcement with education and training supports, and encourage state partners to increase their reimbursement rates. Thank you.
Okay, next is Michael Ring.
You may begin.
Thank you for waiting for me. My name is Michael Ring. I am Vice President of Disabled in Action, and if anyone needs a verbal description of my appearance, I'm a 62-year-old white guy, and I hope you can see me in Prospect Park. It's kind of dark. Earlier this evening, the new commissioner of MOPED mentioned that when you help people with disabilities, you help everybody. And that's called the curb cut effect. That, you know, when we put curb cuts at every intersection, it really helps everybody. Parents with strollers, people making deliveries, tourists with suitcases. I wanted to take this moment to talk about the snow removal problem we had a few weeks ago. People with disabilities can't travel when there's snow on the ground. Unless there's a 4-foot shoveled area on the sidewalk, it means you can't go anywhere. I'm in the middle of running a loop of Prospect Park right now. I can do that. But if one person doesn't shovel their snow, I can't walk through snow. I can't walk on slippery surfaces. I would urge the city, when there's a snow emergency, to remind people, that property owners, that it's their responsibility to shovel their walk and to shovel the crosswalk. And revenue can be generated on this by, make people know they're going to get tickets. They'll get some tickets and then they'll shovel their snow next time. I hope this can be done, and I hope everyone has a nice day, and thanks for being there all day. Bye.
Thank you for waiting for us. The next person is Rachel Gazdick.
You may begin.
Rachel Gazdick. All right, Rhonda Braxton.
You may begin.
Good evening. My name is Rhonda Braxton, Vice President of Health and Wellness at Children's Aid.
What, the other person?
Thank you to the committee chairs and council members for the opportunity to testify. Children's Aid believes that children and youth can only thrive when they are healthy, supported, and surrounded by stability. Our health and nutrition programs are designed to meet the needs of the whole child and to engage families as essential partners in long-term well-being. To accomplish this, we integrate comprehensive health and nutrition services directly within our community schools, centers, and clinics. Through 2 community health clinics and 6 school-based health centers, we provide coordinated medical, dental, behavioral, and reproductive health care. Our nutrition programs complement these services with education, gardening, food access, and culturally responsive activities that strengthen both health and community connection. Our school-based health centers operate in communities where families face significant barriers to care. Last school year, we served more than 3,800 students and delivered over 20,000 visits, supporting preventive care, keeping students up to date on immunizations, and connecting families to follow-up services. Youth mental health needs continue to escalate, with suicide now being the leading cause of death among young people nationwide. 4 of our centers operate on Article 31 mental health clinics, and all 6 clinics connect students to community-based supports. Without these entry points, many students would simply go without care. Despite their essential roles, school-based health centers remain significantly underfunded. Former Controller Lander's 2025 report recommended dedicated school-based health center funding as a core element of citywide mental health continuum. As the state proceeds with the planned carve-in of school-based health centers into Medicaid managed care, stable city investment is critical to preserve access and prevent clinic closures. We urge the council to increase city levy funding to $25 million, providing $100,000 per site for all 139 school-based health centers. Our nutrition
Time expired.
Just summarize the end part and then submit the rest of it to us, please. Thank you.
As a result of HR 1, our SNAP-Ed funding was eliminated. Without this intervention, without an intervention, this work will end in September. We're asking for the City Council to establish bridge funding of $5 to $7 million to sustain SNAP-Ed programming through community-based providers and to coordinate with agencies to close nutrition education gaps. All affected providers should be included in any city investment aimed at preserving this critical work. Thank you.
Thank you very much. Rachel Gazdick, I'm making the call again.
You may begin.
Okay, Sylvia Pizarro.
You may begin.
Hello. Hi, my name is Sylvia Pizarro. It has been a recovery journey for me at Lifelines Clubhouse. I developed a relationship with the members. It has been a positive experience because I would get to do it well with activities like wellness. Without Lifelinks, I would be isolated in the community. I would be sad, depressed, and lost. I wouldn't know what to do with my time. The way that the program Lifelinks has helped me is that I got to know the people there. I leave home to go to Lifelinks and I feel better because I got better when I was there. I like to do the reception desk because I would greet members and answer the phone correctly. There are other parts of the Lifelinks which I think that are very good, like it provides structure, and structure is necessary to have consistency in the involvement of clubhouses.
Thank you very much. All right. One more time, we'll call for Rachel Gazdick.
You may begin.
Hello, good evening. My name is Daquan Mashburn, representing New York Edge After Schools. I'm here today to ask that you prioritize New York Edge's fiscal 27 citywide funding request. New York Edge is the city's oldest and largest provider of after-school and summer programming, serving almost 33,000 students in 134 schools across the city, including 4 Beacon Centers and 21 community schools. We also operate food pantries in Manhattan, the Bronx, Queens, and Brooklyn, providing food and personal hygiene products to our students and their families. Our programs are in 37 of the 51 council districts. We are seeking $250,000 under the council's social emotional support for student initiative. Social emotional learning is integrated in every element of our program. We are identified as Mosaic by ACT, the largest after-school provider in the nation offering social emotional support. This funding will enable us to support our current SEL programming providing high-quality evidence, school-based social emotional learning assessments, curriculum and resources for all of our partner schools and our students and their families. We are also seeking $1.5 million under the Council's after-school enrichment initiative. For over 3 decades, the New York City Council has been a vital partner in helping us fulfill our mission. Since 2020, we have tripled in size and have significantly increased the number of students served. Our council citywide funding, however, has remained flat at $1 million. New York Edge, its students and families are extremely grateful for the council's past support. The time has come, however, where increased funding is vitally needed. Council discretionary contracts are not eligible for COLA increases. This is making it increasingly difficult for New York Edge to attract and maintain quality staff to continue to offer the wide array of programs that we are known for. Increased funding will enable us to keep providing youth throughout the city with the edge that they need to succeed. Your support and advocacy on our behalf are requested. Thank you.
Can you just give us your name again? Hello? He's not doing it.
No, did they mute him?
Thank you. My name is Daquan Mashburn, representing New York Edge.
All right, thank you. Thank you. Okay, so I'm going to call these names one more time, and if you don't answer, then we're going to move on. Then we're going to move on and close the hearing. Aaliyah Jessa, Manuel De Jesus, Falquez, Rhonda Braxton, Lily Shapiro, we had her already. Yeah. Doxine Roberts, Nadine Daly, Jeffrey Zeisman. Okay. At the end, what? Alexis Foote, Stacy Wigal, Alex Stein, Kathleen, and they did already. Delonde Lewis. Okay, this closes out the March 19th preliminary hearings for the Health Committee for Mental Health and Substance Use and Disabilities. We are adjourned. We should get a picture with the staff and the three of us.